gentlemen, and a very warm welcome to one and all. I hope we are all bright and ready and infused with the much needed energy for a day filled with learning and enhancing our academic knowledge. We are delighted and extremely proud to welcome each and every one of you to the 18th Internal Medicine CME session hosted and conducted by the Department of Internal Medicine at Pushpagiri Medical College, Tiruvalla.
This annual CME was halted due to the pandemic since the past 2 years. We have been consistent with our CME through our virtual and online presence, which I am sure was hard to miss. But nevertheless, we are extremely proud to have bounced back to our normalcy, learning face to face from our great teachers. With all the zeal, vigor, and passion we possess, we humbly present to you this grand CME, which clearly reflects our months of hard work, dedication, and time-consuming endeavor.
It is truly heartwarming to see such a big crowd gathered here today, even when the world is reeling and slowly getting back to the pre-COVID era. Your eagerness, compliance, and motivation to attend this conference today reflects the grit and perseverance we all possess. And I thank you all for turning up today to make this conference a huge success. Without further preamble, let's start our program with a prayer song led by Dr. Elenta, Dr. Donna, and Dr. Nayana. Let's all rise for a moment of prayer and reflection before we begin our conference in a most auspicious way by invoking the blessings of God.
പുലരിയിൽ വിരിയും സുമം സന്ധ്യയിൽ പൊഴിയും രുദം ക്ഷണികമെങ്കിലും അനുപമം അഴകിലവയൊരുക്കിടും പരമജ്ഞാനമേ ദൈവമേ കൈവണങ്ങി നമിപ്പു ഞാൻ പുലരിയിൽ വിരിയും സുമം സന്ധ്യയിൽ പൊഴിയും രുദം ക്ഷണികമെങ്കിലും അനുപമം അഴകിലവയൊരുക്കിടും പരമജ്ഞാനമേ ദൈവമേ കൈവണങ്ങി നമിപ്പു ഞാൻ.
Please be seated.
Let's move on to the first phase of our conference, the scientific program, which I'm sure all of you are eagerly waiting for. Our scientific program is divided into 10 different topics, ranging among different systems and covering all of practical day-to-day aspects of internal medicine, all of which are chaired by the big shots, the stalwarts in medicine. Without further ado, let's move on to the first session, Approach to Pancytopenia.
The first topic is chaired by Dr. Srinath S., Professor of Medicine at Trivandrum Medical College, and Dr. Thomas Matthew, Chief Consultant Physician at St. Thomas Hospital, Chettipura, Changnasheri. I request our chair people to please occupy the seats arranged for them on the dais and to introduce our distinguished speakers.
Good morning, ladies and gentlemen. At the outset, let me thank Dr. Sunil Matthew and his team for inviting us to open the session. Pancytopenia, when it suddenly comes to mind, most of the veterans will remember one drug, that is chloromycetin, and we were all afraid of that time. But I think most of the veterans will remember that drug, chloramphenicol, which we used to, widely used in enteric fever. Now, fortunately, the drug has gone out, but things have changed in a different way. It has been taken over by chemotherapeutic agents, radiation, viral infections, and so on. So to talk about this, we have an eminent person, Dr. M. Joseph John from CMC Ludhiana. Ludhiana has been actually in forefront of hematology other than CMC Vellore. We all are aware of Dr. Marvin Chandi's name, and we know how hematology has worked in CMC Ludhiana. Dr. Joseph John is MD, DM, and of course MBA is also there in his degree. He's professor and is head of the Department of Clinical Hematology and Hemato-Oncology and Bone Marrow Transplantation, CMC. We welcome the speaker.
Invitation and introduction, and thank you Dr. Sunil and Dr. Ajish for this invitation here. Thank you. It's a pleasure to be here, and as an opening batsman we are starting with the penia, that is cytopenia, and I would try and see if how can I make it interesting to you on approaching this. So we'll have some introductions, and I want you to solve the cases as I move along, and I see many of the residents or junior consultants here, and I would be happy if it could be an interactive session if you can keep talking along the way. So by definition, when we say pancytopenia, you have all the three cell lines affected. That is, hemoglobin is down, your WBC is down, the platelets are down, and that's a starting point in which we suppose we see how do we want to approach. There are two ways to approach it. One, looking at the report, or by listening to the complaint the patient is telling us. So we have to approach all the three penias, and then we have to see if all of them are there, then how do we look at it. Looking at approach to anemia, there are two ways, laboratory versus and the clinical. As I said, you can either see the report and start thinking what could be the cause, or you can start seeing the patient and you get the report subsequently, how do we see the report, how do we see that. I wouldn't go into the details of it, but we understand that anemia is classified in micro and macro by and large. That will help us to understand it is a microcytic anemia, iron deficiency, thalassemia minor, etc., versus a megaloblastic or a macrocytic or normocytic. So your eyes have to go to hemoglobin first, followed by the MCV, and then the RDW. I'll come to that. In the clinical approach, we think in lines of all the three penias. You can think in lines of, is it a production issue, or is it a destruction issue, or is it an infiltration issue, or it is a sequestration issue. So we'll come to that in the subsequent discussions. So if it is anemia, we are thinking, is it because of a machinery issue, or a substrate is down, or not enough raw materials are not being given, that is the anemia of iron deficiency or B12 deficiency, or it's an absorption issue at the celiac disease, or it is a problem of a loss, or it is a marrow issue. So it's like a Boeing production line. So many things are happening in the marrow. So many nuts and bolts have to be done. If some of it is not there, it won't take off. So if you look at anemia, you first asking the question, is the marrow responsible, or marrow functionality is good? That's the first question. That's your retics will give you the answer. If the retics is good, that means the marrow is producing well, which means either you are losing from somewhere or it is getting destroyed. If the retics are not good, that means it is a production issue. The raw materials are not there, or a machine is itself not working, which is aplastic anemia or MDS or any infiltrative disorders there. So the thinking process is, you look at the retics, is it hemoglobin alone, or is there anything else? Then you are asking the question, is the marrow involved or not? And the retics will tell you a rough idea about marrow is involved. Then you're looking at the marrow and saying, is it cellularity is good or not good? The cellularity is good, that means the marrow is functioning well, so probably either the machine is not good or the substrate is not adequate. So then we come into the classification of that. I wouldn't go into the details of those aspects, but start thinking in this line. As I said, you look at the anemia, HB is less than 12, immediately your eyes should go to MCV and then the RDW. So now let's see what is the interpretation here. I think you can see that. So hemoglobin is 15, MCV is 85, RDW is 14. Then looks fine. 80 to 100 is the MCV, RDW is normal, and then you're looking at your WBC. WBC is 6,000 with a neutrophilic predominant of 53%. Lymphocytes are good. Then your eyes come to the platelets, 2,72,000. What's your interpretation? Normal. Okay. Apply the same here and tell me what's your interpretation here. Residents, quick. HB, MCV, RDW, WBC, platelets. HB is 8.6, that is down. You registered in your mind. Then you look at the MCV, which is 66. Your RDW is high. So which is the situation where microcytic anemia with a high RDW? Iron deficiency. What is this now? HB is 12.6, MCV is down, RDW is 16, WBC is 9.8, neutrophilic predominant, platelets are 1,28,000. What is not iron deficiency but RDW is normal? Thalassemia trait, that's right. HB is 8.5, MCV is 114, RDW is 14, platelets normal, WBC normal. Macrocytic anemia or a megaloblastic anemia. Okay, let's come to leukopenia. Again, the same thought process. Is it a decreased production, increased destruction, or increased sequestration? I wouldn't go through that. We just alluded to chloramphenicol earlier. So it is a production decrease, it is an idiosyncratic suppression at the marrow level, or it may be a failure or an infiltration. Essentially, think of that Boeing production line. Something is infiltrated and not allowing it to be assembled and secreted out. Increased destruction can be the WBC is being blocked from somewhere else, and either it is getting eaten up or it is extremely consumed and not able to cope up with the production. Oops, I think there is some. Sorry for that. Slideshow is not working. Okay, maybe I can run like this. Okay. So we talked about increased destruction, or it may be sequestered. Spleen is large and the cells have gone there. So which means a cirrhosis and a portal hypertension patient comes with splenomegaly, may have a pancytopenia. In fact, when I looked at our data, the commonest cause of pancytopenia in OPD with splenomegaly is cirrhosis and portal hypertension. And rare causes of LTs and bacterial infections can be there. Thrombocytopenia is also approached in the same manner: production, destruction, sequestration. Again, you're looking at, is the marrow having adequate megakaryocytes is the question. So most of us see the ITP patients. The question we are asking is, the platelets are down. Is there a consumption which is happening? Is the marrow adequate? When you do the marrow has adequate megakaryocytes. That's the question we are asking. If it is adequate, then you know it is a peripheral destruction and your question stops there. Then we are looking at if there is any infiltration or any other mechanisms by which it is being destroyed, which means an immune phenomenon which is happening. It could be ITP or any other causes there. Now let's come to pancytopenia. So given you an overview of this, in the next maybe 15 minutes we'll go through the questions, and if the time runs out, stop me, and that time we'll stop. We have about 10 cases to discuss. So a patient comes to you with 3 cell line abnormality. You are only looking at HB, TLC, platelets. If the platelets are down, you are seeing purpuric patches in the patient. Mucosal bleeds are more common as compared to factor deficiencies. Factor deficiencies causes muscular bleeds, joint bleeds. But this causes more of mucosal bleeds and skin purpura ecchymosis. If the WBCs are down, they are prone for bacterial and fungal infections. Of course, HB is down, they would come with transfusion dependence or looking pale. So 3 major areas where we need to look at the patient and understand that part. Again, the various causes of pancytopenia is decreased production, replacement of the marrow, or increased destruction. So in the replacement of marrow, you have leukemia, lymphoma, secondary malignancy, secondary infiltrations, or MDS. Machine is there but dysfunctional, it is not able to produce adequately. So cellularity is normal. Megaloblastic anemia, substrates are not there. So apart from anemia, you may get WBC and platelets also coming, TLC and platelets. So as compared to southern India, for whatever reason, the northern India megaloblastic anemia, the incidences are very, very high. mostly because vegetarians and not much of meat eating, and folic acid and B12 deficiency is much higher. In fact, every OPD will get 1 or 2 patients with low B12 with presenting with anemia or pancytopenia. So now there are some thinking hacks for pancytopenia, and I want you to apply those. At the end of the lecture, you should be able to apply and find out any pancytopenia diagnosis. So you ask the questions: how long has it been? Is there fever, bleeding, transfusion history? Because that's going to tell you the 3 cell line involvement. Where is he coming from? Because as I said, northern India, sometimes the B12 deficiencies are more common. Have there been prior history of tuberculosis? And understand that tuberculosis can cause anything other than pregnancy. So therefore, pre-TB comes as a major differential diagnosis of any of our problems. Prior medications, lymphadenopathy, splenomegaly. Because the differentials are now going to say pancytopenia with splenomegaly, pancytopenia with lymphadenopathy, pancytopenia with jaundice. And your differentials may turn around in this, and easy to zoom in when you think from these many directions. So that's your HB, MCV, RDW. We are recollecting the thought process we need to apply. And I want you to wear the Holmes hat. And let's see this. 25-year-old man presenting with fever and URI symptoms for 1 week. The examination was unremarkable. Routine CBC analysis are these. HB is 10, MCV 85, RDW 16, hematocrit is 35, TLC is 2800. Your thought process should be lymphocytic predominant and platelet 70,000 and SGOTPT. Any thoughts? How many residents are here? Hands up. Okay, so maybe I'll quick others. What are your thoughts here? Differential diagnosis? Sorry? Why? Fantastic. Very good. So we are looking at, I want you to start thinking of corrected retics as well. Corrected retics is your HB divided by 15 multiplied by the retics. And that will tell you the marrow is adequately programmed well, multiplying. So your observation should have been, we have a 25-year-old patient with URI symptoms with mild hypertransaminasemia, with an anemia with the corrected retics is adequate with pancytopenia. And one of the observations should have been your hematocrit is disproportionately higher than the expected. If your HB is 10, the hematocrit is generally 3 times. It is slightly more than that, and therefore I am expecting an extravasation or third space loss or a capillary leak, and there is some hemoconcentration happening. Along with that, there is some TLC down and platelets down. 1 week duration, no organomegaly, and therefore it fits the bill for hypertransamination because of viral. Wouldn't stop there. You may think dengue, you may think other infections, and say I'm going to observe him after a week. And also understand that dengue fever can cause pancytopenia. The mechanism is, how does dengue cause pancytopenia? Some hemophagocytosis as well can happen. Okay, so viral infections can cause pancytopenia. So hemoconcentration, hypertransaminasemia, where your leads there to start thinking it could be something other than the routine what is meeting the eye. All the viral infection can cause generally the mechanism is a transient suppression, just viral suppression or HLH. We may not see that all the, and of course we looked at the hemoconcentration. Okay, where the hats again, 50-year-old man with fatigue, no bleeding or fever, referred for the following reports. HB7. Next slide will be observations. For lack of time, I wouldn't engage too much in discussions, but I want you to start thinking the observations you have made and see if it matches this. Low HB, high MCV, and pancytopenia. Right? And thought process is a strict vegetarian, B12 were found to be low. Straightforward, no problem. You started him on B12, he comes after a month. HB is marginally gone up, retics are 2, and counts have recovered. So obviously counts have gone up, HB is not up to the mark. You want a 1%, 1 gram rise every week approximately, which has not happened. So what could it be then? Think of other causes as well. So the possibilities are Tell me. Sorry? Malignancy. Very unusual, no? So, common things first. So, coexisting iron deficiency is a possibility. 60% of women are iron deficient, given. So, anybody walks into your OPD, women, 60% chance that they are iron deficient anyway. So, serum ferritin may be helpful there. And also screening for hypothyroidism and autoimmune thyroiditis may be a good option there. So, watch out, look out. So, if the HB had remained 8%, 8 gram, and the retics had gone up to 20%, what would your thought process now be? Same scenario, different setting I am saying now. HB is same, but retics is 20%. What could be the possibility? And you see him that he has some mild hyperbilirubinemia, indirect hyperbilirubinemia, LDH is high. Sorry? Hemolysis. So, autoimmune hemolytic anemia is a possibility. So, you ask for DCT because in the very first time he may have presented with an unmasked megaloblastic anemia for a low grade autoimmune hemolysis going on. So, the consumption was more, and we saw the person as a B12 deficiency. Okay. Hats again. Hepatitis C infection with cirrhosis and portal hypertension, no fever or purpura. Examination reveals a 5 centimeter spleen. Note your observations and see if it matched this. We had almost everything abnormal. Of course, your corrected ratings is down. That means marrow is not adequately producing as much as you want. HB is down, MCB is down, and RDW is high. Pancytopenia. So, your interpretation here would be hepatitis infection with an iron deficiency anemia and pancytopenia. Now, what can cause all of this together? Sorry? Hypersplenism. But how do you expect the iron deficiency anemia? Straightforward. So, if you have cirrhosis, portal hypertension, they must have had a bleed. So, then the spinning a yarn around it will be, the storyline has to be completed. So, yeah, cirrhosis, portal hypertension, retics are not high because there is a substrate deficiency and he is bleeding from the varices, and therefore you have an iron deficiency anemia. So, bone marrow will be normal and reduced iron stores will be there. Okay. 55-year-old man with same story. Now he has generalized lymphadenopathy. And the storyline is, what are the observations there? As compared to the previous person, same patient can present similarly, but now lymphadenopathy, but some differences are there in the blood counts. Okay? Did your observations match here? In terms of a reticulocytosis is being seen now, and there is pancytopenia with a lymphocytic predominance, and there is lymphadenopathy in a hepatitis C patient. What would you offer now? What tests would you want to do? You want to do a DCT here because the retics are high. Whenever retics are high and HB is down and there are no blood loss obvious or on deficiency state, start thinking of hemolysis. So, confirmation is by DCT. And now you have to start thinking hepatitis C, autoimmune hemolysis, lymphadenopathy. There could be some lymphomas can be there. So, you would want a lymph node biopsy, bone marrow and a DCT. Bone marrow we generally avoid if it is only retics high. If the retics are high and other cell lines are not involved, you don't need a marrow. Because the cell lines are down, the other cell lines are down and the retics are high, you need a marrow there. So, lymphoproliferation can be there in such situation. 10-year-old boy with URI symptoms, scattered rhonchi, blood counts are like this. Local doctor treated him with antibiotics and 1 unit of blood, but the pre-medication was given. So, this was the blood count of the child. Note down the observations there. And HB is down. There is leukocytosis with lymphocytic predominance. And of course, now start thinking in a child with lymphocytic predominance. Up to 7 years, you can have normal lymphocytosis. Disproportionate there, higher counts, platelets are down. Very innocuous, the blood has been given. And now, 5 days later, he is brought to you with this counts. Now, he is seeing you at this point. Now, you are seeing his old report when he came. Now you see that the 80,000 has become 2,000. DLC is almost the same. Platelets are not down. HB is 6.5. On 6 he got 1 gram, 1 unit. The rise should have been about 7, 7.5, but it has not gone up as much as you wanted. And the TLC has gone down. What has happened here? What is the most likely possibility here? So this is, we see such cases at least once or twice a year, and that's why I want the residents to understand this and go. Very innocuously they have given hydrocot in this patient. So this is an ALL patient who has got the steroids and therefore now has developed cytopenia because of the steroids. One shot of steroids sometimes can mask the blast in the peripheral blood. So if you do not look for those, it is a problem sometimes. Okay. So this is an ALL which is masked by the steroids. 30-year-old man with high-grade fever for 10 days with gum bleed and purpura. Examination reveals a 5 centimeter spleen. This you may often see in your practice. 10 days fever, gum bleed, purpura, splenomegaly, pancytopenia. Register the findings, and OTPD is slightly on the higher side. Retic creat is okay. The observations are pancytopenia with lymphocytic predominance with mild transaminitis. Clinical features, all cell lines are affected. Now compare with the first case we discussed of a viral patient. Okay, not that symptomatic that time. Now there is a disproportionate gum bleed and purpura which is there. Disproportionate in the sense it is not that all 10,000 platelets will bleed. If the patient's platelets are less than 10,000, the probability of a spontaneous bleed is generally about 1 to 5%, not that much. So when they are symptomatic, start thinking of other causes which is involving the bleeding diathesis is there. So now start thinking in those lines. There is transaminitis, and working diagnosis would be to start thinking of acute leukemia, typhoid, viral infection, disseminated COX, MP. And I'm just looking at the possibilities of pancytopenia with splenomegaly. So when in doubt, as a resident, go back to your drawing board, start thinking what are the differentials for pancytopenia with splenomegaly, and start working backwards with your probable working diagnosis. So bone marrow did not show increased blast, not received steroids. So what it could be? If you do the marrow and you are looking at two things, hypercellular versus hypocellular, and this patient's cellularity was hypercellular. Anybody wants to say what could be this diagnosis? Marrow has not shown the blast, and it shows hypercellular marrow, and there is cytopenia, patient is bleeding, there is a splenomegaly. MDS. So the marrow should have shown dysplasia. Marrow has not shown dysplasia. Good thought. MDS to have a splenomegaly, MDS with fibrosis may have splenomegaly, but not that acute history. Tuberculosis could have been a possibility, but usually symptomatology may not be that, bleeding purpura may not be that much, but it can be there. Anybody? You're dealing with dengue fever, similar situation can arise. Important to know this. HLH. Hemophagocytic lymphohistiocytosis, very important diagnosis to remember. Do a ferritin under dilution. You will do a ferritin, they'll say more than 2,000, not good enough. Ask for ferritin under dilution, they'll give you 10,000, 15,000. Then look for other criteria to be done, fibrinogen, etc. Viral fevers can trigger this, and this is a diagnosis which is often missed. That's why I'm asking, and unless a pathologist is tuned and the consultant is constantly asking, I want you to look for it, you may miss it. Former goalkeeper Prashanta Dora dies of HLH. So it is not an uncommon disease. It is there. Many people have lost their lives with this, and some of the, many patients have lost life because of this. Okay, quick few more. I have 4 minutes to go, I think. 30-year-old man with fever, splenomegaly, and pancytopenia. Observations are 7 grams HB, pancytopenia, hepatosplenomegaly now. Differential diagnoses are these. For hepatosplenomegaly with pancytopenia, your drawing board is this, and no hemophagocytosis. Important thing to say is that your tryphin was inadequate, and therefore you did not get the diagnosis. If your differential diagnosis is tuberculosis or sarcoidosis, please go back and convince the patient for a repeat tryphin. Sometimes we overlook this piece and we may miss the bus. So that's the importance I want to make through from this slide. So working diagnosis, 40-year-old man with DVT with pancytopenia. So pancytopenia, hypocellular marrow, DVT, what's the connect? Because of time shortage, I am moving fast. Hypoplastic anemia, DVT, cola-colored urine. Residents? PNH, yes. PNH is an important aspect to look at. What's the diagnosis? Straightforward. Polydactyly, pancytopenia, faces are different, Fanconi's. But all polydactylies are not. So somebody should answer this question. Women at the back. Who's the film actor with polydactyly? Hrithik Roshan, that's right. So all polydactyly does not mean they are Fanconi. Okay, scientists who died of, this is now KBC style. KBC has taken up this pancytopenia in the past. So what's the diagnosis there? Mary Curie. So chloramphenicol, Mary Curie. So last question, 33-year-old lady with complaints of episodes of gum bleeds for last 1 week, ecchymotic patches. There is pancytopenia, DVT and bleeding now. Okay, so PNH could have caused that in the past, as I said, but short history, DVT with bleeding and pancytopenia. What is clear is that it is not a lymphocytic predominant. Aplastic anemia, usually it is lymphocytosis are more. Your neutrophils are more. What is the one diagnosis you should not miss with bleeding, DVT, pancytopenia, neutrophilic predominance? Promyelocytes are high. What's the diagnosis? No, APML, acute promyelocytic pathology. Residents should not miss this diagnosis because it is a life-threatening thing. You need to do a PT, APTT and make a diagnosis. The point to learn is that pancytopenia with bleeding, think of APML because this is one emergency you must be looking at it. I have not gone through many other pancytopenias, and this is how I approach. I said about the age, symptoms, lymphadenopathy. Then you look at the diagnosis, and of course, always communicate with the pathologist. And this is something which we all mistake all the time. Thank you very much.
Okay, thank you, Dr. Joseph, for your very interesting case scenario-based presentations. Even though it looks very simple, in actual practice, this is not so simple, I feel. And it's a big problem for all the clinicians also, when you get anemia, pancytopenia, bicytopenia. And maybe we are expecting questions from the audience and queries.
Yeah, so you must send it. We are all sending it, and occasionally we are picking up. So even if we don't find it is important to send CBNAT, I would say we must send it. Now, if you ask me what percentage of conversions, I do not have a baseline to talk about, but it is important to send because of DNA-based testing.
Any more questions? I would like to comment about what some conditions, peripheral pancytopenia with the cellular marrow, maybe for the residents.
Yeah, so look, your thought process is peripheral is pancytopenia. I don't have a cause. Think through the differential count first. First, look at the DLC. Lymphocyte, RBCs, lymphocytes, neutrophils, and the cell lines there. This is HLH, as I would say. These are the causes of cellular marrow with this thing. And of course, if it is a lymphoma infiltrating marrow also, you may get a cellular marrow with pancytopenia. Myelofibrosis also, you may get the same situation. But findings will be classical in the marrow.
How often you get a pancytopenia in a viral hepatitis? I have seen only one case throughout my career.
Actually, sir, with the dengue, and there is a discussion now, HLH series has been published in dengue. Dengue fever, I would say 50 to 60% of the patients are getting pancytopenia.
Viral hepatitis, sir.
Hepatitis
How many
B
cases
is
have
the-
you come across? I have seen only just one case with a viral
When
hepatitis.
ABC you are talking about?
Yeah,
yeah.
hepatotrophic virus.
Yeah, maybe Dr. Epen can answer that. How often do you find acute?
I have seen just a single case throughout my 36 years of
Yeah.
career. One case of pancytopenia with a viral hepatitis.
Yeah.
Any questions from the audience? Lot of residents are here. So how frequently iron deficiency anemia may be resulting in a hyperproliferative anemia? Is it common? Simple iron deficiency.
Now, iron deficiency causing pancytopenia is unusual. So as I said, if there is an iron deficiency and a pancytopenia picture, start thinking of, okay, if there is a spleen, that's the first question I will ask. If it is because of that, as I said, hepatitis C or cirrhosis and portal hypertension per se. Second is PNH, is what you need to think if there is an iron deficiency and pancytopenia, or dual deficiency anemias, B12 deficiency with iron deficiency.
Of the 50% idiopathic, which most of the time I think 50% cases are categorized as idiopathic. Of those 50%, if you work out, what would have been your finding on those idiopathic cases?
No, so when you say idiopathic pancytopenia, no. So, I would say, I would look at Dr. Maman Chandy's response usually. When you say refractory anemias, it is just that the doctor is refractory to the diagnosis. It is not that anemia is refractory. So, I wouldn't use the word idiopathic pancytopenia there. I would rather rename it as immune pancytopenia. If I cannot get a diagnosis, I looked at, suppose I got a pancytopenia, I'm asking the pathologist, is there any dysplasia? And they are very sure that there is no dysplasia. I look for clonalities in the marrow, that is cytogenetics and if required an NGS. Sometimes this can happen with the clonal abnormality with no abnormality in the dysplasia part of it. If I have ruled out all the possible causes, no splenomegaly, and then you are boiling down to saying it could be an immune phenomenon, then you look for an ANA. Look for connective tissue disorders there. And then work around that part. And if you still can't put it, then there is a diagnosis called idiopathic cytopenia of unknown significance, called ICUS. That is something which we will keep for it's a placeholder kind of a thing where we don't have anything better to say there. So I label it as ICUS and I keep following them up on a regular basis. Understand that constitutionally, especially African countries, you can have a leukopenia situation there. Not pancytopenia, but leukopenia.
Malaria you have not included.
Malaria can cause, if there is a splenomegaly, they can cause in an acute setup, yes, of course it can cause that.
And questions from the audience? Residents? I think everybody understand everything at
Okay.
the session. Yes, thank you, Joseph,
Thank
for
you,
a
sir.
very good presentation, and that's why they don't have any questions, sir, because they understand everything.
Hematology remains the most sought out super specialty now. After the saturation, hematology along with rheumatology and endocrinology remain the top three. So hematology is still one of the best, and so as sir said, though it looks very simple, but at times you have to most of the time 50%, more than 50% cases, you need a hematologist to make a final diagnosis. Thank you very much, sir, for
Thank
your
you.
excellent.
Bye.
Thank you so much, sir. I am sure all our postgraduates are buzzing with all this vital information and can wait to apply his clinical principles practically. I would like to invite our chair people, Dr. Srinath sir and Dr. Thomas Matthew sir, to kindly present Dr. Joseph Jones sir with a small token of our gratitude and appreciation.
Thank you so much, sirs. I would also like to invite on stage Dr. Abdul Khader, HOD and Professor of Medicine, Pushpagiri Medical College, to present our chair people with a certificate.
Dr. Srinath sir and Dr. Thomas Matthew sir. Thank you so much, sir. Next up, I would like to invite on stage Dr. Abraham Itichin, Professor and HOD of Medicine, MOSC Medical College, Kolancherry, and Dr. Johnson, who is a Senior Consultant Physician at Christian Medical Center, Pandalam, as the next topic's chair people. Welcome, sirs. Please take a seat.
We are prepared for us a very demanding and elusive topic next on our list of scientific menu, managing drug-induced hepatitis, to be delivered to us by none other than Dr. C.E. Eapen, who is a professor in the Department of Hepatology at the very prestigious CMC Vellore. Let's sit and pin our ears and eyes back for this session. Over to you, Dr. Abraham, sir, and Dr. Johnson, sir.
At the outset, may I thank Dr. Sunil Matthew and Dr. Abdul Kader for inviting us to be chairpersons for this session. Dr. C. needs no introduction. I have known him since many years. He's a person who is into research, an avid researcher, and a good speaker too. And if I were to read his professional career, I think I might take the entire time for this session. So I just cut short with his 2 words. He's a man who is interested in the liver, just not the hepatitis part, but infections and so many original papers. In fact, he has come to our institution and given talks on some of the papers which are landmark papers actually. Now coming to the topic for today, hepatitis, drug-induced hepatitis. There was a time when we used to equate ATT and hepatitis, because those were the times when we never had so many drugs that caused hepatitis. But now the pharmacological armamentarium has expanded beyond our imagination, and so with that we also have the problem of hepatitis. And I think there would be no better person to talk on this subject than Dr. C. Eapen. Over to you, sir.
Thank you, Dr. Abraham, for the kind introduction, and thanks to Dr. Sunil and the team in Pushpagiri for this opportunity to come again to talk at the CME. So the topic I have to engage with you is drug-induced hepatitis. I hope I can keep you interested with this topic. So how do we diagnose drug-induced hepatitis? Now, to diagnose that, first the clinician has to figure out, is the LFT looking like hepatocellular or cholestatic, or is it a mixed picture? So we know that hepatocellular is raised AST, ALT, or SGOT, SGPT, and cholestatic would be raised alkaline phosphatase. So this has been put into some numbers by this formula called the R value, and there is some cutoff decided on that. So if it's predominantly SGPT, we say it's hepatocellular, and predominantly cholestatic is raised alk phos, or combinations of these. Now, how do we attribute, if there is an LFT change, into is it caused by a drug? So the causality has been made by some scores. So one example is called the RUCAM score. Now, it's all circumstantial evidence. The person who's got an acute LFT abnormality, there is no other cause found, and there is a potentially hepatotoxic drug being taken, is how the scores go. The maximum weightage is given for the point number 7, where it's re-challenging with the same drug. Now, almost it's often unethical to do that, but sometimes in some scenario, we are forced into giving a drug, knowing that the drug could again cause toxicity, but we're running out of options. But often the point number 7, when it happens, is the person doesn't recognize it. Neither the patient nor the doctor realized that the diclofenac I'm giving for the arthritis of the knee was causing the jaundice, and I'm re-challenging that. That can happen that way. And the scores are tallied and come out as highly probable drug-induced hepatitis, possible, unlikely, or excluded. That's how the score works. Now, DILI, or drug-induced liver injury, can be categorized into those which happen when you take the usual dose of the drug, and those who happen with an overdose. If somebody took paracetamol overdose for poisoning, that's one type of DILI. But when we talk about DILI, we refer to usually an usual dose of the drug. Now, usual dose of the normal dose of the drug can either cause what is termed as direct or intrinsic toxicity. If people take paracetamol as a regular doses, some people will get dose-dependent liver toxicity, and that is predictable. On the other hand, there can also be idiosyncratic, or it is not dose-dependent, and it's not predictable. So some of the idiosyncratic DILIs come with either skin rash, eosinophilia, fever, etc., what is called the DRESS syndrome. And a lot of work on this has come from St. John's, Bangalore, where Dr. Harshad Devbabi's focus is DILI. So he is a world expert on DILI. So in this article, he highlights that when DRESS happen, when there is skin rash and jaundice, eosinophilia, etc., the patient is declaring himself or herself to their family and to the doctor there's something going on. For that reason, this category of DILI has got lower mortality, because very soon either the patient or the family or the doctor realizes that something is wrong. Otherwise, what happens is when there is a DILI, I don't realize it. Neither the doctor also is not realizing that. But in this category, everyone understands something is going on. So quickly, so that translates into lower mortality. That's one of the highlights of this article. Now, when we get somebody has got DILI, it's common sense. One drug is causing a problem, we'll stop the drug. But the question comes, should we give steroid to that patient or not? So steroids are given if a patient has got this form of DILI, where there is a component of an immunoallergic variety. Then we think about adding on steroid. Example is a person who gets sulfa drugs, dapsone given by dermatologists. The dermatologist may not refer to the physician. They'll give steroid. They'll stop the dapsone. That's a normal thing. So skin rash with DILI are typically seen with anti-epileptic drugs. Carbamazepine can cause it. Sulfonamides can cause it, etc. Now, why do some drugs cause this idiosyncratic DILI? In this professor shown in the Three Idiots picture, they made that professor look very eccentric. He can write with both hands and all. He is idiosyncratic. Why am I idiosyncratic? Why is it that when I take carbamazepine, I get one rash and fever? What makes me idiosyncratic? That's the meaning of the word idiosyncratic. Now, I'm moving away from drug-induced hepatitis to autoimmune hepatitis just to get us understanding the mechanism. We know that the theory why autoimmune hepatitis happens is thought that is triggered by either a virus or a drug. So suppose there's a girl, a teenage girl, for acne takes minocycline. Why does she now develop autoimmune hepatitis? So the answer, our understanding is the interaction between the HLA antigen on the antigen presenting cells and where the virus or drug now is presented and interacts with the T lymphocytes. And these are now, there's a molecular mimicry between this virus or drug with antigens in the liver, in the hepatocyte. For example, the type 1 autoimmune hepatitis, the self antigen which is targeted is the one receptor on the cell surface of the hepatocyte called the ASGPR, or the AS sialoglycoprotein receptor. And in type 2 autoimmune hepatitis, it's a drug metabolizing enzyme inside the hepatocyte, which is the target for the host immune response. So that sets the stage why HLA seems to be important in drug-induced hepatitis. So studies now have answered that question, why is that professor idiosyncratic or eccentric? So there's a lot of work in UK done by a good friend of mine. He's from Mangalore, Professor Guru Aital. He's in Nottingham. In fact, the top publication is from him. So in this publication, in this article, they looked at 51 patients who had flucloxacillin-induced hepatitis or jaundice, and 282 European controls who took flucloxacillin and did not have jaundice. Now, normally in any article, we look at odds ratio. And if you say odds ratio of 2 is very good. Here the odds ratio was 45. It was very high. So that person is born with an HLA predisposition. If I take flucloxacin, I will get hepatitis. The odds are very high. In fact, he is proposing that this test should be available as a blood spot test in the GP practice in UK, because if you can identify that, I will not give flucloxacin. Only problem is that the rarity of that phenomenon is not translating into numbers. Look at the minocycline. Minocycline can trigger autoimmune hepatitis. It's a drug commonly used for treating acne. So again, the odds ratio here for a particular HLA antigen genotype is 29. So these are strikingly high, very high odds ratios picked up on this GWAS studies, which are of interest now, explaining why idiosyncrasy happens. However, how common are these HLA signatures in the general population? Now, this will vary depending on ethnicity, and this work is from Europe. So let's look at the fluclox, that row again. That particular HLA B5701, which is positive in 84% of DLE cases, are positive in 6% of the normal population. So these are some information which is now available, especially from the Western world. Which are the drugs which cause DLE in India? There's a pan-Indian study on the left, and the one on the right is a study by Dr. Abraham Koshi from Lakeshore Hospital, which came out this year. So, as per the pan-Indian study, the commonest drugs they highlighted, there were multiple centers all over India, where anti-TB drugs, the complement and alternative medications called CAM, or herbal medications, anti-epileptics, antibiotics, and NSAIDs. In UK, the commonest drug which causes jaundice is amoxicillin clavulanic acid. It's a MCQ question. So the commonest drug in the UK which causes drug-induced hepatitis is augmentin or co-amoxiclav. And again, NSAID is another common cause of jaundice in the Western world, but in India it's more of, and in the West it will be antibiotics and NSAIDs. Under antibiotics would be amoxicillin clavulanic acid and flucloxacillin are examples, and NSAIDs. Well, in India it's anti-TB drugs and CAM. These are the commonest drugs which cause drug-induced hepatitis. So Cyriac Phillips, who's now in Rajagiri Hospital, Alway, has been spending a lot of energy on highlighting the toxicity of herbal drugs to the liver. So this interesting study, where he picked up patients who had alcoholic hepatitis. Now, severe alcoholic hepatitis is a life-threatening illness, and looked at 27 patients who then took herbal medicines to treat alcoholic hepatitis, or treat the jaundice, and the 29 who did not. There was some difference in the liver biopsy, which show that there were more necrosis and cholestasis in the patients who got herbal drugs. But look at the survival curve, survival numbers. The 30-day survival was 37% in the people who had alcoholic hepatitis plus took herbal drugs, which had caused hepatotoxicity. The 6-month, 180-day survival was 18% compared to 52%. So he is highlighting that what is considered as innocuous may not be so, and the need to be aware of this, to be careful about using herbal drugs just like that in people with jaundice. And if you're starting any of these drugs, the need for monitoring LFTs, etc., have to be considered. So they further analyzed these drugs used by these patients in this particular study. So they had alcoholic hepatitis, and many had died later on. And they found that there were high levels of these heavy metals of lead, nickel, arsenic, etc., which is how these drugs act, I think. But they also found medicines which are used in allopathy practice, which were considered adulterants in this herbal drugs. For example, there was amoxicillin, diclofenac, alcohol, spironolactone. It's a long list. So this is a big problem and an unregulated section of the industry in India, of practice in India. So this is highlighting one such case report which came in BMJ again from Syriaca B. Phillips. A teetotaler with NAFLD cirrhosis suddenly had acute worsening. And they couldn't find any cause for why the LFT worsened acutely. The liver biopsy looks like alcoholic hepatitis, severe alcoholic hepatitis. But the patient and family says, no, I don't drink alcohol. But he says for the last 1 month he was taking a homeopathy medicine to treat jaundice, which turned out to be Gilbert syndrome. So then they took the drug and analyzed that. The drug had 18% ethanol in it. So literally the person is taking high concentration of alcohol every day without knowing I am taking alcohol. And some people who take a lot of alcohol will get severe alcoholic hepatitis. I recollect when I was a small child, I used to get severe arthritis. So my dad felt I should have, my dad is a medical doctor, I should have Ayurvedic treatment. And it worked very well. I no longer have arthritis. But I remember when I drank the aristam, one nice burning taste used to come nicely here. So it's a good feeling. But now I think it is wine. That's how the feeling of how I drink. If I were to drink wine, it would be. But these are the norms in these treatments. There's nothing wrong with that, I guess. But just that our own awareness has to increase. And should we be monitoring these patients then? If somebody was giving a potentially toxic drug, then should I monitor? Are questions which are currently not being addressed. Let's take a imaginary scenario, but as a common referral for us in hepatology. Somebody is on anti-TB drugs, INH, rifampicin, pyrazinamide, or I took statins for dyslipidemia, and a week later SGPT is 60. Can we continue the drug? So what are the stopping rules? So there are two stopping rules. If a patient is asymptomatic, we can continue the drug till the ALT is up to 5 times upper limit of normal. And only if it is above 5 times should I stop. So if the upper limit is 40 up to 200, I am okay to continue. If the patient is symptomatic, at any LFT derangement I should stop. Now symptomatic is what are the symptoms of hepatitis? There are no specific symptoms. There will be some anorexia, nausea, vomiting may be there, and icterus may happen. So there are non-specific. But these are thought to be very, very important symptoms in this scenario. This is called the Hy's law. Hy Zimmerman, more than 100 years ago, described that in a setting of drug-induced hepatitis, if a person would develop the hepatocellular type of DILI, let us say INH would cause hepatocellular DILI. If that person developed clinical icterus, the chance of death is more than 10%. 100 years later, that observation still remains true. So thereby, if a person with a potentially hepatocellular type of a drug which can cause that toxicity develops clinical icterus, the Hy's law remains true and we have to stop the drug. Now this important study from SWIMS Tirupati along with AIIMS Delhi looked at when we stopped anti-TB drugs, when the person got drug-induced hepatitis, what regime shall I restart with? So they compared 3 different regimes, either starting all the drugs at one go, so the person already got ATT drug-induced hepatitis, or start drugs one by one as per the American Thoracic Society guidelines and by the British Thoracic Society guidelines. And they concluded that whichever way it was done, there was no difference in the rate of hepatotoxicity on reintroducing the drug. And they felt that in some scenario, for example, bilateral extensive pulmonary TB, etc., one could introduce all the drugs at the full dose from day one itself, reintroduce it. Now, this is for us to interpret and decide how we want to use it in our own practice. It depends on how aggressive or conservative you are as a physician. But just want to highlight that there is such information available in literature which may guide our treatment of a particular patient. What about patients with underlying chronic liver disease? Let's say underlying cirrhosis. And we know that tuberculosis is commoner in people with cirrhosis, especially extrapulmonary tuberculosis. So the risk of getting drug-induced hepatitis is not higher in these patients. However, the leeway for tolerating such an insult is lesser in a person who's got cirrhosis. So that principle guides our treatment policy. So suppose a person got cirrhosis and they got child A, B, and C, which and has got pulmonary tuberculosis, which ATT should I use? So this recommendation from author from PGA Chandigarh suggests that in a person who's child A, one could use 2 potentially hepatotoxic anti-tuberculous drugs, but they would not use pyrazinamide, which causes dose-dependent toxicity. While in a person with child B, one could give 1 potentially hepatotoxic drug, and they preferred rifampicin over INH, but would avoid pyrazinamide. But with child C disease, they would not use any hepatotoxic drug at all and give only non-hepatotoxic drugs for a longer time period. So let me end with one case scenario. This is a 52-year-old healthcare worker, diabetic, with a significant ethanol use history, came with jaundice, and for which he took herbal medicines, and then developed ascites and breathlessness 2 months later. His bilirubin is 6, albumin is 2.9, OT and PT were actually normal, ALK was normal, INR 1.7. He has a small left pleural effusion. He's got chronic liver disease, portal hypertension on ultrasound. Endoscopy showed small varices. B and C virus are negative. Ferritin was very high, was quite high, 1600. The pleural fluid was exudative, and ascitic fluid looked like a mixed pattern. Tests for tuberculosis were negative. The expert TB PCR was negative on pleural ascitic fluid. So essentially he's got what appears to be tuberculous ascites and left pleural effusion. He could have the syndrome of acute or chronic liver failure. The herbal drugs may have contributed to the acute worsening, and underlying alcohol, NAFLD, etc. could be chronic disease. This could also be decompensating cirrhosis. He was diabetic. When he first got admitted, his sodium was 109. He was quite unwell that time. So I was thinking I'll ask for show of hands, but to save time, I won't do that. Which of these 3 options in this real life true patient would you think you would do? First is, we are thinking it is tuberculosis. We have not proven it. But I think in this scenario, I would take it as it is TB. Would we give INH or rifampicin as a single drug and give add-on non-hepatotoxic drugs, which are examples are levofloxacin or ofloxacin and ethambutol. Option 2 is to give all the routine first-line drugs for TB. 3 is to give only non-hepatotoxic drugs. So what I opted for was to give him only levofloxacin and ethambutol, and he was also on diuretics like Lasix, Aldactone, Midodrine, etc. Now he was on the medicine for 6 months. He comes as outpatient. He looks okay. He's not very well, not very unwell after that, not needing admissions. When you cross 6 months, you wonder, is there a toxicity keeping on giving these drugs? Ethambutol can affect the eye. So then after 6 months, I stopped it after discussing with him. He's a medical professional himself. 3 months later, he came back with fever. And now the ascites now looks chylous now. A CT scan is now reported like a cocoon in the abdomen, sclerosing peritonitis. He underwent a peritoneal biopsy, which did not show granulomas, but the expert TB PCR was positive. So we asked ID department, who I think O.C. Abraham may be here. They felt setting is like it could be MDR TB. We did not treat aggressively enough the first time. And all these are possibilities. So again, which drug should we use now? So we started INH as a single drug of the potentially hepatotoxic drugs and added on, again restarted on levofloxacin and ethambutol. And after 2 months or so, added on rifampicin. And after, I think, a total of 9 months, we stopped at INH rifampicin, and the other drugs were given for 2 months or so. He's done fairly well, and a year later, he remains happy. However, his bilirubin is still 2.9, but he is back at work and looks well. So we want to use the example of just to say how the thought process goes in trying to address the issue of preventing drug-induced hepatitis in a person with tuberculosis and underlying cirrhosis. Thank you.
Now that's what I would call a medical feast. Thank you so much, sir, for that brilliant talk, which has definitely tickled our frontal cortex.
Thank you, Dr. Epan, for the excellent talk. And any question from the floor, please?
The delay criteria, when will you say, what criteria you say it is highly probable, possible, probable or possible? That is one question. Again, one more question.
Yes. The criteria is there are weightage given for each score on a range from -1 to +3, and the criteria can be added cumulatively. These are coming as apps now, so online we can do that, and then it will come out as the total score comes as highly probable, so there are cutoffs for that only. But there are limitations with the criteria as well. I'm just highlighting that there are criteria like this which are trying to give numerical values for the circumstantial evidence to say delay.
In the case scenario, given TB positivity, is it chylosositis or pseudocylosositis?
Beg your pardon?
In this case scenario,
Yes.
TB PCR, as per TB PCR positive, you said it is chylosositis. I want to clarify whether it is chylous or pseudocylous by criteria wise.
I'm sorry, I didn't catch the question. Expert TB PCR is positive.
Chylosositis or is it a pseudocylosositis?
Okay. Why is the chylosositis there? So it's possible that TB was causing obstruction to the lymphatic drainage, and it's known that that's one reason why chylosositis can happen. On the other hand, it may have been another illness altogether, and maybe the chylosositis may be a malignancy brewing internally which is blocking the lymphatic drainage. These were possibilities. But in him, luckily, they all seem to have regressed after giving the anti-TB drugs. So I think it was linked to the tuberculous process, and he seemed to have done well with that. It's uncommon to see chylosositis, but it's unnerving as well. When we do a large volume paracentesis, milky ascites keeps coming out, okay, to say. So we may see 1-2 patients like that per year. Then we try to work out if we can find out any treatable cause to try and look for that. That's what we would do.
INH idiosyncratic reactions.
I agree with you. It's an uncommon scenario to have INH-induced drug reaction. Only thing is, this audience, everyone is very familiar with that. We are all tuned to that. That's why, in fact, you're asking the question. But I want to highlight, moving away from your question, that we are not tuned like that with the Ayurvedic medicine, for example. We only see them when there's a problem. But the routine person, let's say somebody is on INH rifampicin. Will we check an SGPT or bilirubin? We may. We are thinking about it. But that thinking is not happening now with the Ayurvedic medicine. That's the other side of the story. It seems to be uncommon with INH because we are aware of it. So we are telling the patient and we are looking for the test. So the earlier we catch something, then more likely we can not have a problem. I think that's the crux really. If I was not aware, and if I'm keeping on giving the drug, suppose I had a problem, but no one told me, then I'm catching it later and later on in the illness. That's what I think will happen.
So, suppose a patient is on 10 drugs, including antibiotics, anti-inflammatory, etc., came in with the baseline normal LFT. Third or fourth hospital day, OTPT is now 150 to 200. Billy may be elevated, not elevated. What is your algorithmic approach at that point?
Thank you. This is from hematology, renal transplant, etc. There's a common scenario. The drug list is 10, not 2 drugs. These are post bone marrow transplant, etc. So answer is very simple. In pharmacology, it's very difficult for the examiner to fail the candidate. He says, what are the drug side effects? Nausea, vomiting, jaundice. It is true. If you look at a case report, any drug can cause that. So we have to use that approach here as well. Any of these 10 drugs can cause the SGPT high, or bilirubin to be high. But some drugs are more prone for it. That's how I'm approaching it. So the first point is any drug can cause it. Okay. Now, two, should I now intervene? I use those two rules. If the enzymes are up to 5 times, I'm okay to continue. If I'm thinking of a particular drug, if it's causing, usually we know the drug, for example, is let's say ATT. Can I continue or not? So it depends on these two rules. If the enzymes are less than 200, or if I have no symptoms, I'm okay to continue. So I look in the drug list for potentially hepatotoxic drugs. I know that some of the drugs can be like that. A lot of drugs are not like that. So I use that to say I'm okay with the drug, to the drug to be used or not. Some drugs which I see commonly are not being recognized as a problem is, for example, the use of amoxicillin clavulanic acid. But is that true in our population? We do not know as yet the propensity for it. Those studies, exhaustive studies, have been done only in the Caucasian population. But it is true that the drug registries from India, reports from India, rate amoxicillin clavulanic acid also as one of the drugs by the causation scores, causality scores as well. That's what they do.
There's just two questions from my side, sir. One is regarding this term idiosyncrasy. Don't you think it's a wastebasket diagnosis? Because as I see it, it's probably that we have not, research has not reached to that point where we can pinpoint a cause for the reaction, and so we say idiosyncrasy and be happy with that. Probably in future, that as research advances, we may reach a point where one diagnosis will be out of that. That's my first question.
No, I fully agree with that. It's a bit like Joseph mentioning that this refractory anemia is a refractoriness of the mind of the physician who's tired out of, they can't figure out differential diagnosis. So surely we will find out more and more clarity in the answers. That's what the UK study by Guru Aital is showing. That if I'm born with a HLA genotype, which says that I have a 49.6 odds of getting hepatitis if I took flucloxacin, I am idiosyncratic. I'm like that 3 idiots professor. If I take it, I'll get it. So he says in the GP practice, you check it. If I have it, do not prescribe the drug any longer, like that. But it's not making economic sense now to do that, but it's possible. They have developed like that. So I agree with you that the more and more we understand this, but that needs studies from India. So you talked about research. I would encourage all of us. So let me ask you a question. Do you think medical practice in India will change? Is there a half-life for medical knowledge? So, and what is the half-life? So there are literature on that. 20 years ago, the half-life for medical knowledge was something like 10 years. Now the half-life is in weeks. So that means what is now the NEET exam this year, next year the exam will be the same answers are wrong. It's changing now. It's very, very rapid. In India, if it were to change, who will make the change? So it is bound to be some of us. So both the seniors and the juniors. The seniors by now would have their own, by their own experiences, are starting to make observations. But who has run around making this? So I would encourage all of us to think it through. So surely yes. So that's how it will go. And I think as newer understandings of idiopathic illnesses, which we call it by such names, have to come from within us.
So the last question again. That is, we always consider SGOT, SGPT as part of the liver, but we keep forgetting that it's a muscle enzyme also. And some of these drugs are known to cause myositis. Some of the illnesses for which we treat not only produces myositis, they also have hepatic dysfunction. So have you come across such cases in your practice, and what would be your guidance?
Yeah, thank you, Abraham. That's a very important point. Recollect a staff member in CMC brought their child for evaluation. So the fact that the child has had a muscular dystrophy problem was not detected by the medical professional parents nor by anybody else. But for the LFT, somebody else picked up to say OT is more than PT, and that was later on turned out to be the diagnosis. So uncommonly it can happen that way. We know that SGOT more than SGPT is one feature of severe alcoholic hepatitis. And increasingly we have a treatment called PLEX, plasma exchange in liver failure, which is now very exciting new phenomenon.
I may point out that Dr. Epen, probably he's humble, so humble that he doesn't admit that he is one of the person who has done a lot of research in that in the world, and most of the landmark papers are by Dr. Epen.
Well, I'm part of the team is doing it. It's true that, but we are, so in that group of patients, most patients will have OT more than PT. So I think it's reflecting mitochondrial toxicity in the liver in that situation. It's again liver specific there, but majority are, it's not only alcohol, there are other etiologies as well. So for example, in Tamil Nadu, one such category is rat poison. In Kerala also it is there, but it's much more common in Tamil Nadu. And there again, we may get a lot of patients with OT more than PT. So we think it's also mitochondrial damage in the liver is happening there as well.
Okay, we already overshot the time by I think 10 minutes, but I think none of us have lost because it was an excellent talk. So
Shall I ask one more question?
Yes.
In congestive cardiac failure, especially right side heart failure, where you get a right heart overload, you get a OTPD high, you can win thousands. So the cardiologist start on statins. The patient probably on statins, on high dose of statins. Should we continue it? Dr. Sadhan is here. He can make a comment also.
So from what I understood, first of all, I must say I've worked under Dr. John long ago in Paramula. That's 1982. No, 88, I think, 88. So the question is about statin and OTPT. Is that the question? Yeah. So it's a common question for discussion again with hepatology. Fatty liver disease, dyslipidemia, and OTPT. Should we, how do you approach it? So I keep telling myself it's possible that the OTPT elevation may also be because of the drugs. For example, statins or
I'm telling
fenofibrate.
of right heart failure, where you get a right side heart failure, right RV, RA overload, and you get a hepatic congestion. In that case, you get a thousands of OTPT may be so much raised, you know. It comes in thousands.
Oh, in thousands you're saying.
Thousands.
Okay.
So should we...
So fair enough. So you are asking about if the enzymes were in 1,000 range. Yeah. So this 1,000 range enzyme is a scary thing. Sometimes will be very high. May even go 10,000 SGOT, SGPT. There are only few differential diagnoses. In fact, only 3 usually come to mind. One is for what is called ischemic hepatitis or hypoxic hepatitis, where either there was hypotensive event or the person has just got congestion acutely as well in the liver. 2 is drug-induced hepatitis or acute viral hepatitis. So again, we have to keep all differences in mind, and so long as we maintain normal hemodynamics, nothing more needs to be done. By and large, the patient settles down in the situation of a hypoxic hepatitis.
Shall we conclude the session then? Okay. Thank you so much for the...
Thank you so much, sir. I request Dr. Abraham and Dr. Johnson to please present a small memento on behalf of Pushpagiri Medical College to Dr. Epen, sir. Ladies and gentlemen, please put your hands together. Thank you again, sir. We sincerely look forward to more classes from you. I would also take this opportunity to please welcome Dr. Sheila Kurian, former Professor of Medicine at Government Medical College, Kottayam, on stage to kindly present Dr. Abraham and Dr. Johnson with a small token for being such excellent chair people. Thank you so much, ma'am. Thank you so much, sirs. the third topic we have in store for you is titled Approach to Resistant Hypertension. A very common OPD situation we face and a difficult area to treat, isn't it? Well, not anymore. I am sure Dr. M.
That is more common in fat than in lean. Then the giants in the field of history of medicine, Gallen, William Harvey, Stephen Hale, Rivarossi, so many giants who taught us what hypertension is. Going to the topic proper, the resistant hypertension. How will you define a resistant hypertension? The latest guidelines on hypertension is as per International Society of Hypertension Guideline 2020. And as per this guidelines, normal blood pressure is less than 130/85. 130/85 to 140/90 is high normal. 140/90 to 160/100 is grade 1 hypertension. And anything more than or equal to 160/100 is grade 2. This is the latest definition and grading of hypertension. There are specific measurements to define hypertension as per ABPM and home BP monitoring also available. Now I am going to take you through a case scenario. This is a 36-year-old man who presented in the casualty with an intracerebral hemorrhage. His blood pressure was 240/120. He has no family history of hypertension. On further evaluation, he has left ventricular hypertrophy, some abnormal urine analysis, and an abnormal kidney function. Is this a resistant hypertension? You can't say that at present. So how will you define resistant hypertension? As per 2020 ISH guidelines, resistant hypertension is defined as a seated office blood pressure. All the individual words are important. Seated office blood pressure of more than 140/90. If the patient is on 3 different groups of antihypertensives, in either in the maximum dose or maximum tolerated dose, and one of the drugs should be a diuretic. The same definition is called different guidelines from American Heart Society, coronary, all the different societies accepting the same definition of resistant hypertension. So our patient was initiated on nifedipine 30 milligram twice daily, telmisartan 40 mg twice daily, and chlorthalidone 50 mg. Still blood pressure is 160/100. Can you call this as resistant hypertension now? Probably yes, because he is on 3 drugs. One is diuretic, still blood pressure is not controlled. Probably yes. A few other newer terminologies that has been introduced into this area by these different latest guidelines. Uncontrolled resistant is the same what we define now. What is controlled resistant hypertension? If your blood pressure gets controlled with 4 antihypertensive, you call it as a controlled resistant hypertension. What is apparent treatment resistant hypertension? Blood pressure by clinic BP measurement is uncontrolled, but you lack the data of one of these following regarding the dose of the drugs, adherence of the patient, and out of BP value is not available. If any one is absent, you can't definitely diagnose this is a resistant hypertension because you can't rule out a pseudo resistance here. So you define this as an apparent treatment resistant hypertension. What is refractory hypertension? Your blood pressure is uncontrolled in spite of at least 5 antihypertensives. One of which should be a thiazide-like diuretic and mineralocorticoid, MR blocker, or a spironolactone. Patient should be on a thiazide-like and a MR blocker containing 5 antihypertensives, still blood pressure is uncontrolled, defined refractory hypertension. And the refractory hypertension will be roughly around 3% of resistant hypertension. So you have a group of uncontrolled hypertension, then subgroup of this up to 25 to 30% will be an apparent treatment resistant, then pseudo resistance to be ruled out. Finally, the true resistant hypertension is roughly around 10%. And this was proved in several
landmark trials and population-based studies, roughly around 10% you will get the treatment resistance, and the CRIC study have shown that it is much higher in patients with a chronic kidney disease. It is up to 20% in those with chronic kidney disease. Now what is pseudo-resistance then? You call it as a pseudo-resistance when patient has no resistant hypertension, but blood pressure uncontrolled. It is not true resistance. So what are the common causes? 5 most common causes of pseudo-resistance. One is errors in the BP measurement. There are set guidelines how to take up the BP. But in the routine clinical practice, we are not following all these strict guidelines. So very, very labile to have errors in the BP measurement. Poor adherence to medication. It is thought that 40% of people stop their medication by 1 year if you start them on antihypertensives. And the study shows that up to 34% of them have undetectable drug in the blood. They have not taken it at all. So these are the drug non-adherence. And what are the common causes? We should address this issue to improve the antihypertensive adherence. Most of the patients with hypertension are asymptomatic. They are aware that they are hypertensive when they develop an IC bleed, acute myocardial infarction, renal failure, etc. And they are unaware about these life-threatening complications. As we said, patients are afraid of taking lifelong medication, that too allopathic medications in quotation. They are not aware of taking Ayurvedic medications or homeo medication, but allopathic medication they are afraid to take lifelong. And cost of the medications, lifelong cost involved. All these are different reasons why 40% drug non-adherence is there in this area. So what is rule of half in hypertension? Only 50% of those who are hypertensive aware that they are hypertensive. Those who are aware about that they are hypertensive, 50% take treatment. Those who take treatment, only 50% have a controlled blood pressure. So this is rule of half in hypertension. Why again go to the slide has gone to the first slide. Okay, so the other common suboptimal, there's some changes in the order of the slides. What about the physician's inertia? Physician's inertia in the area of, there is some change. The studies have shown that 84% of situation, physicians have not changed the prescription. Just repeat all. So that is another common cause of uncontrolled hypertension. And the non-adherence to your lifestyle modifications, your dietary restrictions, and its small percentage of white coat effect. So these are some of the common causes for pseudo-resistance in the day-to-day clinical practice. And if you look into the various causes of true resistance, chronic kidney disease is one of the common cause of resistant hypertension. Secondary hypertension most commonly is resistant to treatment. Older age, obesity, various psychological factors, obstructive sleep apnea, and several drugs, a huge list of drugs which can interfere with your treatment. So you have to be careful when evaluating a patient with uncontrolled hypertension. Why we are worried about such resistant hypertension? Because it is proportional to increased morbidity, mortality. We are giving large number of drugs in high doses, so drug side effect. Most of them may have secondary causes of hypertension, so they may be benefited with further evaluation and treatment for secondary causes. Because of these reasons, it is important to consider. and it is thought that just a 5 millimeter reduction in blood pressure is translated into a coronary artery disease decrement by 9%, stroke decreases by 14%, all-cause mortality decreases by 7%, and you can save 27,600 lives can be saved per year by just 5 millimeter reduction in blood pressure. But still, hypertension is a neglected and undertreated situation. Going into the pathophysiology of resistant hypertension, contributions comes from various organs, adrenal gland, kidney, the vasculature as such, variations in the cardiac output, obstructive sleep apnea, renin-angiotensin system. Several factors contribute to the resistance in hypertension. So our patient was initiated on nifedipine and he is probably has a resistant hypertension. Now how to go ahead? Is this a primary or a secondary hypertension? Of usually 90% of hypertension are primary, only 10% is secondary. Of the 10%, 80% is renal. So that is how the overall different causes of hypertension comes. When to suspect a secondary hypertension when you handle a difficult to control hypertension? Regarding the age of the patient, any hypertension new onset, less than 30, more than 55. Think of secondary causes. When the hypertension patient present with a blood pressure of more than 200, first time, think of secondary cause. Target organ dysfunction, presented with an IC bleed, presented with an acute myocardial infarction, presented with renal failure, presenting with a target organ dysfunction. Resistant hypertension always rule out secondary causes. Any history of renal disease, present or past, heavy smoker, peripheral vascular disease, history of a coronary artery disease, TIA, think of a vascular disease. So these are the some of dictum for the postgraduates to think of a secondary cause when you handle a case of uncontrolled hypertension. How to proceed? These are the investigations to be done, minimum investigation to be done in any hypertensives when you evaluate for the first time. Basic investigation for hypertension. Now, here is a patient who is an obese with a family history of hypertension, diabetes. He has dyslipidemia, hyperuricemia. Routine evaluation shows only 1+ proteinuria, no sediments. Kidney functions are near normal. Overall, your clinical diagnosis is primary hypertension here, isn't it? And resistant hypertension in primary is less than 1%. Less than 1%. Another situation, blood pressure got controlled. Urine shows significant proteinuria of 3+, active sediments in urine, abnormal kidney function persisting. Here, the diagnosis will be a renal parenchymal hypertension. It can also be a hypertensive kidney disease. And the points in favor of hypertensive kidney disease, onset between 30 to 50. Hypertension should be at least 5 years of duration, usually 10 or 15 years of hypertension. After blood pressure control, proteinuria decreases, no sediments in urine, RFT stabilizes, your kidney size will be marginally small, means 8 to 9 centimeters. You are justified in making a diagnosis of hypertensive kidney disease. Whereas, a patient with a parenchymal, kidney parenchymal hypertension, any age group, less than 30, usually in a glomerular disease, hypertension duration is not mandatory. There will be some history to suggest a kidney disease, episodes of gross hematuria, one episode of acute glomerulonephritis at age 10, massive, significant, more than 2 gram proteinuria, and an active, all these indicate a renal parenchymal disease. But most of the time, it is not easy to differentiate these two. Hypertension can be the villain or a victim of the condition, and you may have to go ahead with a kidney biopsy to confirm. Another situation where a heavy smoker, a diabetic with a history of myocardial infarction post-PTCA, history of peripheral vascular disease, claudication, extensive bruit on clinical examination, systolo-diastolic bruit on the abdominal examination, one kidney is contracted on ultrasound. You have no other diagnosis other than an atherosclerotic renovascular hypertension. Then you go ahead with your further evaluation, Doppler, CT, MRI, depending upon your GFR, confirm and go ahead with revascularization if indicated. Another situation, again a young adult, presented with a hypokalemic periodic paralysis or on routine evaluation, striking hypokalemia. ECG also shows features of hypokalemia. So you have hyperaldosteronism in your mind with triad of hypertension, hypokalemia, metabolic alkalosis. You have hyperaldosteronism. You go ahead with further evaluation, serum aldosterone level, aldosterone renin ratio more than 30, go ahead with the CT, venous adrenal vein sampling if you have some difficulty to localize the compartmentalize the adrenal gland. Cushing syndrome, you also all know how to go ahead. Pheochromocytoma, 4% of resistant hypertension is likely to be due to pheochromocytoma. Plasma-free metanephrine, 24-hour urine metanephrine, go ahead with further evaluation. So the algorithm says evaluation of resistant hypertension, confirm treatment resistance, you should be on 3 drugs, including diuretics, etc. Exclude pseudo-resistance, assess for secondary causes, and assess for the target organ functions, baseline algorithm. Now how to go ahead with treatment. Lifestyle modification, well discussed and well addressed tissue area. These are the lifestyle modification, various lifestyle modification and expected blood pressure control with different lifestyle modification. And this is the TRIUMPH trial which looked into this lifestyle modification alone in resistant hypertension. And they have shown that it decreases blood pressure along with some improvement in cognitive function also. So this is a landmark trial with respect to lifestyle modification. Patient those with obstructive sleep apnea, will they be benefited with a CPAP in terms of blood pressure control? And this is the well discussed HIPARCO trial published in 2013 and HIPARCO 2 trial published in 2021 and shown that the good adherence to CPAP significantly reduces blood pressure in those with resistant hypertension and obstructive sleep apnea. Going on to the pharmacological aspects. Pharmacological aspects, you should have a very good drug adherence to be there, for which drugs should be cheaper, you should use once daily dosing, and combination pills are recommended. And choice of drug is less important than the actual blood pressure control. That also to be taken into consideration. And if the patient is on a single antihypertensive, better to be in the evening dose because you may have to maintain that nocturnal dip. Resistant hypertension, pharmacological, the current guidelines says that patients should be on an ACE inhibitors or ARB plus a long-acting calcium channel blocker plus a thiazide-like diuretic. This is the ideal combination as per the current recommendation. If the patient is on a thiazide diuretic, they ask us to shift to thiazide-like diuretic like chlorthalidone or intepamoride. Why? Because they require only once daily dose, longer T-half and more potent than thiazides. If the patient is still volume overloaded, still edematous, you can either add a loop diuretic or switch over to loop diuretic. GFR less than 30 ml, no role for thiazide, switch over to loop. Patient on furosemide, switch over to toracimide because it is more potent and better bioavailability than furosemide. So maybe better in terms of drug resistance. You titrate the dose of diuretic depending upon the BP, whether your target blood pressure has been achieved, maximum dose, patient is already on maximum dose, drug side effect, volume status of the patient, unexplained deterioration of GFR because of volume depletion. All these has to be taken into account to adjust the dose of diuretics. What next? Already 3 drugs, full dose, maximum dose. What next? The 4th drug to be added is either a spironolactone or a MR blocker or a epithelial sodium. All are collecting that diuretic. Add one of the collecting that diuretic, and the spironolactone was studied as per the well famous pathway 2 trial, which showed that compared to placebo, bisoprolol and doxazosine, spironolactone was the best to reduce the blood pressure in resistant hypertension. This was the post hoc analysis of fidelity trial which showed, the slide is not, has not come in full. Fidelity trial post hoc analysis has shown that, slide is not coming fully, shown that shown that the finerenone is effective compared to spironolactone in terms of blood pressure control in resistant hypertension with less hyperkalemia. Now, after fourth drug, what next? What should be the fifth drug if the patient is going to refractory state? There is no definite data on the selection of fifth drug. If patient has got good heart rate of more than 70, add a vasodilatory beta blocker. What are the vasodilatory beta blockers? Nebivolol, labetalol, or carvedilol. These are the recommended beta blockers for blood pressure control. Still sympathetic overactivity, if you suspect, add clonidine. Next one will be hydralazine, and last minoxidil if the patient is already on a beta blocker. So this is how you go down adding the new drug. So management, step 1, maximize the lifestyle modification, optimize your 3-drug recommended regimen. Then add if the patient is on thiazide diuretic, change over to thiazide-like, add mineralocorticoid receptor blocker, then beta blocker, hydralazine, and minoxidil. That is how you come down adding new drug. What are the new drugs in the pipeline after minoxidil? These are the 2 drugs, aprocitentan. Precision trial has gone into, this is an endothelin receptor A and B, dual receptor blocker, and have shown that it reduces blood pressure in resistant hypertension. The baxdrostat, which is an aldosterone synthase inhibitor, again the BRIC hypertension trial phase 2 has been completed, results awaited, and have shown some improvement in blood pressure, those who are already on 4 antihypertensives. SGLT2 inhibitor, is it worthful to add in resistant hypertension? The EMPA-REG outcome trial post hoc analysis have shown it has improved the blood pressure in those with resistant hypertension. What about ARNI, sacubitril valsartan combination? In those with hypertension, heart failure with preserved ejection fraction, that is FDA approved only for heart failure with preserved ejection fraction. And the subgroup analysis have shown that the combination has improved blood pressure compared to valsartan alone. So there is some benefit for ARNI also. Once you have completed your optimal medical management, what next? Blood pressure is still uncontrolled. Do you have any interventions possible here? These are the 3 interventions in the area of hypertension treatment: renal denervation, carotid baroreceptor stimulation, and central arteriovenous fistula creation. What is renal sympathetic denervation? Sympathetic nerves passing through the adventitia of the renal arteries ablated. Either a radiofrequency ablation, ultrasound ablation, or even chemical ablation has been tried. This is a huge list of RCTs that has been conducted in this area of renal denervation, simplicity, and they have come forward with a global simplicity registry itself for continuing the research. And a few of the recent trials has been continuing in this area, but again FDA has not approved yet the renal denervation as the treatment. And this is the ongoing trial, spiral hypertension off trial, up to about 10 to 5 millimeters of mercury fall has been addressed. Almost all trials have reduced blood pressure by 5 to 10. Carotid baroreceptor stimulation by using BAT devices, another Hotman system. And this is the arteriovenous fistula. You are making a 4 millimeter connection between the external iliac artery and vein and decompressing your arterial system. So these are the various new interventions that has been tried. In spite of all these recent intervention, new drugs, etc., still blood pressure is a neglected disease. So there is a World Hypertension Day on May 17th, and month May is considered as the Hypertension Awareness Month. And the World Hypertension Day of 22, the theme was measure your blood pressure accurately, control it, and live longer. That was the theme of 2022 World Hypertension Day. And this is Niagara Falls. In the honor of World Hypertension Day 2017, Niagara Falls lit up red and blue for 15 minutes to help the spread of awareness among the population. So they were also keen in helping us to improve the awareness on hypertension. Thank you.
Thank you, madam. And most of the physicians, we all come across patients with resistant hypertension. But the incidence of refractory hypertension, as you said, is less. One question is, have you ever...
percent of resistant hypertension goes for refractory state.
Have you ever done this renal denervation?
In
because
patients with CKD, it is very common.
Right.
Patient requires 5 or 6 antihypertensives. Still blood pressure is uncontrolled.
Renal denervation, have you come across?
I have tried
because
2 or 3 patients, but the method is not accurate. Finally we abandoned that.
Good morning. First, I should thank the Department of Medicine and the organizers of this this conference, and especially Dr. Sunil Matthew for having invited me for this very good conference and also offering me as to be the chair. Dr. Sridhar, you did a very good presentation. Congratulations. And you were very clear and rather authoritative, I would say. Comments are that hypertension is a day-to-day practice and thing for a physician. What I would suggest is that we should spend more time with the patient once you are see a hypertensive, and never rely on anybody else's blood pressure. If you're going to write a prescription, you have to check the BP. That's number one. And then you have to ask one question to every hypertensive patient before you check the BP. That would be, have you taken your BP medicines today? You will be surprised that
90% might not have taken.
Yeah, more than 50% of the patients would say, I have not taken the medicines. There are three main reasons for this. One is they must have already exhausted their tablets and coming for the refill. Second, that is also very common. I've been taking this medicine for such a long time. Now let me see if my BP is okay. The third is even more funny, that many of those patients who come into the hospital will be coming for blood tests like fasting blood sugar, fasting lipids. Then I say, why didn't you take the blood pressure? No, I came fasting. So insist that fasting is only for food, not for BP medicines. And these BP medicines are time bound, and timing is very important. Each medicine has a half-life and peak of action. What is the point in giving a bank officer who is going to the bank in heavy traffic antihypertensive at 9 a.m.? It won't work. It will start working only at 11 o'clock or 12. So timing the medications are very, very important. And sometimes all our people, our Indians, have got a feeling that you should take all medicines after food. So I know one Ammachi who said, sir, you told me to take medicine at 7 o'clock, so I get up at 6:30 and make something and then take the medicine. So insist, and we should have something like hypertension education to the patients, where our people should call the patients regarding the BP, regarding the frequency of medications. That only will control the BP. As Dr. Sridhar has correctly pointed out, as we come to the new year of hypertension, a drastic change in the management of hypertension is essential. Just one thing which I wanted to inquire was that the role of what you call clinic hypertension, or the previous white coat hypertension. This is prevalent in even those who are hypertensives.
That is what is a white coat effect.
White coat effect, hypertensive. So this we have to have a lot of counseling and
up to 20 to 25% chance of having a white coat effect.
White coat effect, and this is can be overcome only by home BP monitoring.
Home BP or ABPM is a must.
ABPM will be expensive, and there are a lot of things in that, But home BP monitoring, everybody should encourage their patients for home BP and also teach them how to check the BP. And Dr. Slida had shown the slide of how you sit and rest your elbow on the table, and that is very important.
Not possible in the heavy OPD, sir. That is the
But
problem.
then it is very important to control the BP as well. You can have the questions.
The session is now open for questions and discussion.
Thank you. Your talk was, as usual, your talk was very informative and very emphatic. But I want to comment or ask, whenever I see, I am a neurologist, whenever I am seeing your prescription, I am really afraid.
Looking at the number of antihypertensives.
No, it's not because of the number of antihypertensive, but afraid because there is a diuretics, thiazide diuretics.
There is a diuretic.
Diuretics. As a neurologist, my main problem is the hyponatremia. You know that every physician faces the problem of hyponatremia. And actually, you know that especially in the old age, younger age, there is no problem. If the person is bit obese, edematous, there is no problem. But most of the other category, especially after the age of 60 and all,
elderly female are more prone for drug-induced. More common with thiazide, sir.
It's with thiazide. And
Not
whenever I see in the common platforms, thiazide is so much highlighted, I am getting more and more afraid because of the hyponatremia.
That is a common problem with thiazides in elderly female.
You may not be seeing that hyponatremia because they all come to physicians or neurologists. The magnitude of hyponatremia is very high, very high. Even patients themselves that says that we have hyponatremia. This is because
we feel that patient is more afraid of more tuned to hyponatremia.
What I feel is all these studies were done in a Western population where the climate is very comfortable, the amount of sweating is very low, whereas when you come to India, most of the people have not using AC or anything like that, they are sweating like that. That may be the loss of salt through the sweat may be the reason for hyponatremia. So I always say that you don't agree with me, but in my clinic I always advise them, as physician, cardiologist, nephrologist, if possible, avoid thiazides. Other diuretics are of no problem.
Maybe, but that is a maximum dose that recommended for chlorthalidone.
Nowadays, almost all the people are aware about the sodium. Sodium even the bystanders will come.
Sodium
Everybody is aware of this problem now.
Even patients are also aware.
Sodium and use diuretics. That is the main reason. Because hypertension means absolute rejection of the salt. That should not be the thing. They should be allowed to take permitted dose quantity of the salt. If both are there, then definitely the patient will go for hypertension.
Yes, Sunil.
Madam, in some patients with pregnancy, that is not the toxemia, but hypertension complicating pregnancy, may be difficult to control the hypertension.
They very likely to superimposed preeclampsia also.
And suppose the patient is not having preeclampsia or eclampsia, see what are the drugs which you can use to control the hypertension?
Drug of choice is labetalol in pregnancy. Alpha-methyl dopa is not available now. So currently drug of choice is labetalol followed by calcium channel blockers.
Excellent and very vivid presentation. And this is actually not a question on resistant hypertension directly, because today actually the hypertension is a public health problem.
Yes.
So the guidelines say that you have to start detecting early detection of hypertension, and your age group is limited to be
Adolescent
30.
hypertension is gaining
Yes,
more and more.
the question is the same. 30. So when we were doing the quality standards and all that, there we have done the opportunistic detection of hypertension or measurement of hypertension starting from 18 years. What is your recommendation or what is your choice of the age group?
Yeah, age group is now becoming more and more, younger age group is developing primary hypertension. So good old 30 has to become has to come down.
Okay, thank you.
Calcium channel blocker. I think we should not use calcium channel blocker as a whole term. It's only nifedipine. Amlodipine is not recommended for pregnancy, I understand. Amlodipine is not recommended for. I would like
Usually we use nifedipine. Nifedipine for pregnancy.
Amlodipine is not advisable.
Nifedipine.
Amlodipine is not advised.
Labetalol plus nifedipine is usual
amlodipine
combination.
is not advised. You use the broader term calcium channel blocker.
Okay.
So the comment is that amlodipine cannot be used in.
Okay.
Why?
That is
Dr. Sarjan maybe can comment.
There are no questions, so we will wind up the session because we are late. Thank you, Dr. Ledano. Thank you.
There. Now, was that so hard? Looking forward to apply your clinical acumen in our OPD setting, ma'am. Thank you so much for clearing out all our queries and giving us the much required confidence in tackling this issue. I invite our chair people to please deliver a memento of appreciation and gratitude to Srilata ma'am. I also invite Dr. Nazlin Salam ma'am, consultant physician at GH Trivandrum, to please bestow a certificate of appreciation for our chair people, Dr. Vijay Kumar K and Dr. S.K. Matthew. Thank you, respected teachers. The following is for the kind information of all our postgraduate students. You can upload your poster material in the system, which has been arranged at the Ambassador Hall on the second floor of the venue. Thank you. We shall shortly move on to our inauguration ceremony. We proudly once again welcome all the members of the audience, delegates, presenters, and postgraduate students to the 18th Internal Medicine CME session hosted and conducted by the Department of Internal Medicine at Pushpagiri Medical College, Tiruvalla. It is an honor beyond measure bestowed upon us by our department to introduce and welcome such distinguished and esteemed guests who have graciously accepted our invitation and has graced us with their presence. I hereby invite Madam Dr. T.K. Suma, Principal at TDMC Alapura, Reverend Father Jose Kallumalikal, CEO of Pushpagiri Group of Institutions, our patrons, Dr. Cyril Joseph, President of the IMA branch at Tiruvalla, Dr. Tommy Philip, Principal and Professor of Medicine at Pushpagiri Medical College, Tiruvalla, Dr. Abdul Khader, Professor and HOD of Department of Internal Medicine at Pushpagiri Medical College, Tiruvalla, Dr. Sunil Matthew, the Organizing Chairman of our CME and Associate Professor of Medicine at Pushpagiri Medical College, Tiruvalla, and finally, Dr. Ajish Koshi, a young and dynamic Organizing Secretary and one of my closest friends. Please occupy your respective places on stage, dear sirs and madam. Distinguished guests, faculty, and postgraduates. A day without prayer is a day without blessing, and a life without prayer is a life without power. Let us begin our conference in a most auspicious manner by invoking the blessings of the Almighty. I request everyone to kindly rise for the prayer song led by Dr. Elenta, Dr. Nayana, and Dr. Donna.
പുലരിയിൽ വിരിയും സുമം സന്ധ്യയിൽ പൊഴിയും രുദം ക്ഷണികമെങ്കിലും അനുപമം അഴകിലവയൊരുക്കിടും പരമജ്ഞാനമേ ദൈവമേ കൈവണങ്ങി നമിപ്പു ഞാൻ പുലരിയിൽ വിരിയും സുമം സന്ധ്യയിൽ പൊഴിയും രുദം ക്ഷണികമെങ്കിലും അനുപമം അഴകിലവയൊരുക്കിടും പരമജ്ഞാനമേ ദൈവമേ കൈവണങ്ങി നമിപ്പു ഞാൻ.
Please be seated. To welcome our little gathering, I would like to invite on stage a man who needs no introduction, a brilliant diagnostician and clinician, a teacher beloved by all of his students, and a friend and confidant to many of us gathered here, Dr. Abdul Khader, Professor and HOD of the Department of Internal Medicine, Pushpagiri Medical College, Tiruvalla, and also the Scientific Committee Chairman of this conference. We invite you on stage, sir, to deliver the welcome address.
So, good morning to one of all. My duty is to welcome all the distinguished dignitaries. But before I go to my official duty, let me tell about few words about the Pushpagiri Medical College, the Department of Medicine CME. This is the one which started about 18 years back when the first department was already formed by Professor Suman. From then onwards, for the last 17 years, in spite of the COVID scenario, we could continue our academic engagement even online. What we usually prefer is not to project our own faculty. We consider that it is the prestige for us, our institution or department, to get all the speakers and faculty throughout the country and throughout the state, and we keep it. And all of you will enjoy that session. Then, this is the 20th year of celebration. So this time, we dedicate our CMB to the, along with the the 20th year celebration of our college. So now I'm going to my duty as to welcome. In fact, first I have to welcome our own father, Jose Kalmaliklachan, is the CEO of the Pushpagari Medical Society, and always the brain behind every activity in our department, very close friend of each one of us, encouraging or involving any activities of the department, always Father will be the forefront. When I told about to chair our session, Father, even though today is Sunday, very busy schedule, Father agreed to come. So I extend the heartiest welcome to Father to chair this session. Now the second person again, my own colleague and classmate, Dr. T.K. Suma, the distinguished, it is our honor to have to inaugurate this session. So a very apt person we got, and she's nobody other than all of you know about Dr. Suma. He is in fact the pioneer in the research in the Department of Medical Education. In fact, when we joined the Department of Medicine, the research in our state was so in the primitive, and from there what we have now is, I should acknowledge the work of Dr. Suma. So started in the field of filariology or filariasis. She had made this or took a place in the global scenario, including the WHO. So I welcome you, madam, for this auspicious occasion. The other dignitaries, I don't know how I will welcome our Professor of Medicine and the Dean of our hospital, the college, Dr. Toby Philip. As a formality, I just welcome you, sir. Then, of course, again, our colleague, Dr. Sunil Matthew, who is actually his hard work for the last 2 months has culminated in this grand occasion. I should welcome you, sir, as formality. Then, of course, our IMA, all of you know that any critical movement in the doctor's field, what may be practice or anything, always IMA is forefront, and is very happy that we got the IMA President Tiruvalla to be a guest of honor to this. Then, of course, I have to welcome again my faculty, Dr. Ajish, the young, enthusiastic, and most energetic, my faculty, who is the organizing secretary. So, Dr. Ajish, as just a formality, I don't know whether I should welcome you or not, or yes, so with that, I have to welcome the most important, all my speakers, we have selected the nation, the best speakers and faculty who is the forefront of in their subjects. So I welcome you all for this conference and the CMP program. Then, of course, I have to welcome all the chairpersons. Many of them are my colleagues and classmates. So I welcome you all for this meeting. It will not be complete if I welcome the most important part of the persons or the beneficiaries of this meeting is the delegates, my postgraduates, practicing physicians, and all the supporters of this conference, including the pharma companies. I welcome you all for this movement. Once again, thanking you, and I wish a very happy and very memorable academic feast from this CMP. Thank you all.
Thank you, sir. A great leader is one who knows the way, goes the way, and shows the way. Leadership is not about a title or a designation. It's about impact, influence, and inspiration. To all my fellow Girians, these characteristics best describe a man we have all seen conducting and performing his duties behind closed doors, enabling us to be the best version of ourselves, making an impact every day, influencing and inspiring us to be better than yesterday by setting an example through his life. Without further ado, may I please invite Reverend Father Jose Kallumalikal, CEO, Pushpagiri Group of Institutions, to deliver the presidential address.
Good morning and welcome to Tiruvalla, the homeland of Pushpagiri. As we are celebrating, as we are in the mood of celebrating 20th anniversary of Pushpagiri College of Medicine and Pushpagiri College of Nursing, let me congratulate the General Medicine Department for organizing this CME. Dear doctors, it gives me an immense pleasure in seeing you all eagerly coming for the internal medicine CME and showing your interest in updating the professional knowledge and to discuss the details in new approaches and techniques in medical system. Continuing medical education sections are all the more important where knowledge sharing happens. Newer medical treatment protocols are to be developed on the basis of diseases causing pathogens, its mutation, and its effects in the human body. Hence, sharing of experience and modality of treatment will help the peers as well as the upcoming medical professional. While organizing this type of CME, with or without our knowledge, we are rooting ourselves in the field of medical profession. Updating the knowledge and skill is very important to withstand in the field of medicine or to become the trendsetters of the field. Time is very important in the field of medical profession. Timely assessment and management saves life. While updating the knowledge, you are preparing yourself, training your thoughts, fixing your decisions, and preparing your mind and hands to act in situation. So, keep the momentum and fill you with good knowledge, skill, and attitude. We all know medical treatment is all the more complex, and the cost is also important factor to be addressed. That is why many of the people from different sector discuss about the factor affordable cost. Medical treatment shall be provided at affordable cost, and at the same time it shall be accessible to all also. That is why World Health Organization now gives thrust in the policy of universal health coverage. Universal health coverage means that all individuals and communities receive the health service they need without suffering financial hardship. It includes the full spectrum of essential quality health service from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. Hence, in order to achieve the target policy of World Health Organization in terms of universal health coverage, the major hurdle we faced in our state is the skyrocketing of cost of medical treatment. Availability of human resources, human facilities, and accessibility is better in our state compared to some other region of our country. Other cost factors are increasing day by day. So here we have to go for a ethical practice which mission hospitals like ours and others would like to support and promote. I also thank the doctors community in Kerala and our country who all support us in this noble venture in giving affordable medical treatment to the people of our society. As we all know, the COVID-19 pandemic was a nightmare and it's affected our whole system. The healthcare system was also affected. When the pandemic outbreak was there, naturally the care to other trust areas like cancer, TB screening, mental health service, chronic health conditions like diabetic and hypertension, etc., were affected. But due to effort and dedicated by you all people, we will recoup all our health index, which are benchmarked as world class. So I would like to congratulate the whole medical fraternity in handling the pandemic situation with courage and thereby instilling faith and hope among the people. May God bless you, and let me wish you advance Happy Christmas and Happy New Year. With the short words, let me conclude my speech. Thank you very much.
Thank you, Father, for those words of encouragement and motivation. It is my privilege and great honor to introduce an eminent personality among us, Dr. T.K. Suma, who is the Principal and Professor of Medicine at TDMC Alapura, who very graciously responded to our sincere request to be the guest of honor for today's CME. She is the Director of Filariasis Research Center India, the WHO Collaborating Center of Lymphatic Filariasis. Light fades away the darkness, spreading the Almighty's grace and divine energy. Light symbolizes abundance, prosperity, knowledge, and wisdom. The lighting of the lamp is regarded as a bow down to knowledge. To solemnize this special occasion, I would like to invite the dignitaries on the dais to please come forward and light the lamp and kickstart today's program. Ladies and gentlemen, please put your hands together and let's give a great round of applause for our honorable chief guest of the day, Dr. T.K. Suma ma'am. I request you kindly, madam, to formally inaugurate the 18th Internal Medicine CME session conducted by the Department of Internal Medicine, Pushpagiri Medical College, and to declare this conference open. I request you, Madam, to deliver a few words as part of our inaugural address.
The chairperson of this session, Father Jose Kalumalikal, Dr. Tommy Phillip, the principal of Pushpagiri Institute of Medical Sciences, Dr. Cyril Joseph, President IMA Tiruvalla, Dr. Sunil Matthew is the organizer of this CME, along with Dr. Abdul Khader, Dr. Ajish Koshi, the delegates, the distinguished speakers, the residents, ladies and gentlemen, and friends. At the outset, let me thank the organizers for inviting me to inaugurate this very important continuing medical education program. It is always a pleasure to attend a CME program or conference organized by Dr. Sunil Matthew and team, and also the Pushpagiri Institute of Medical Sciences, because Dr. Sunil Matthew and Abdul Khader put in a lot of care to select the topics, and not only in selecting the topic, bringing in the best person or the excellent guests, excellent experts in that particular field to deliver this speech. I don't think we need any evidence for that after we have listened to Dr. Joseph Joan, Dr. C. Penn, and Dr. Srilata. And when you are looking at the program also, you can see that he has brought in experts in each field, so that everyone who attends this CME program will be benefited. And I'm sure that whenever you attend the program by the Pushpagiri Institute of Medical Sciences, we go back with a lot of new knowledge. And that is part of our bringing, and it will be in various fields also. So I would like to congratulate, first of all, Dr. Sunil Matthew and the team, and Dr. Abdul Khader and the whole team for the excellent conduct of the CME. Now, as principal of medical college, one of the things which worrying me is the attitude or the change in behavior of the present day students. Because we know that when the student comes for even the MBBS, now they think that they can all learn from the Google or from information getting on from the internet. So it may not be like they may not be looking at the correct platform or correct evidence-based medicine or any new things, but whatever may be the knowledge which they get at a very short time. And I feel that will be short-lived also, because students, they are not, sometimes they are not writing exams, because they will say that if you want to write a medicine exam, you don't have to write it in the third semester, but we'll write it in the final semester, because that is when it comes. So when we were students, we didn't have any internet or any computer or anything. I remember that in 1983, when I was a postgraduate student, that is a time when the AIDS was coming in, the information about it. So my professor asked me to do a presentation for the Saturday morning program. So it was very difficult for me, because there was no system like internet or library, or only thing which we could depend upon were the textbooks. But nothing has come out in the textbook those days about the HIV or AIDS. So the professor himself supplied some of the journals, excerpts from the journals, and full article was not available. So had to go through that and present that one, because that was the first presentation about AIDS which happened in Trivandrum Medical College, where I did my postgraduate studies in MD in medicine. So, but now it is not like that. When you are doing the usual rounds itself, suppose there is some question or wanted to know about whether there is a protocol on that, students will immediately take up the mobile from the pocket and say that these are the things available. But I don't think that could be a sustainable thing. And as we all say, that it is the clinical medicine. The clinical medicine is dwindling like anything. And for these meetings, like as I have told that how Sunil Matthew and team and most should do that, select the topics and select the speakers. So the speakers coming here are the experts, and not only as experts, they are experienced, Because when you have a senior person presenting, that what is not the extent of knowledge, sometimes the postgraduate student can say that I have more knowledge about this topic, but the experience which is counts, and experience especially in clinical medicine. And clinical medicine, I mean all the disciplines and the clinical experience and the approach patients and how to do and all that. So that gives a lot of, that could be giving an inspiration to the students also. So what I said is that now there are, I'm happy that here in this room, the hall was full during the academic sessions, and there are a lot of junior residents attending the conference. But there was a time when they were not much interested in attending this conference. So it should be the junior residents who should be making a lot of advantage of these sessions, where you will be able to cover a lot of topics and gaining information from the experts. And now what is happening is that previously it was there in other universities alone, but now in our university, Kerala University of Health Sciences also, it is mandatory that before appearing for the exam, they should have a paper presented or a poster presented, and that they should have a publication of thesis. So for all these programs will be very helpful, and you will also be able to meet experts, because in other international conferences and all that, there is a networking program is there, but I don't see it much here. But that networking program, you can also even discuss with the experts in the topic or in the discipline which you are interested in, and you can get many times you can think about the research and can do whatever would you like you would like to do more. So these opportunities should be or must be utilized by the young generation and the postgraduate students definitely. And so I think I'm happy that here it is, that may be the reason because of the topics and the speakers selected by the team. So I'm very happy, and I'm very happy to the father explaining about the universal health coverage. Yes, the universal health coverage is coming in a big way, and the WHO is working on it also, and I have also a part to play on developing the beneficiary packages for the neglected tropical disease. So that will be helpful for the patients who are not able to have an out-of-pocket expenditure. So that will be helpful for them. So I was very happy to listen to Father talking about the universal health coverage. So this altogether, I am sure that at the end of this day, we will be definitely made rich by a lot of knowledge. And I again thank the organizers for inviting me to inaugurate this session. And I declare this CME, Continuing Medical Education Program by the Pushpagiri Institute of Medical Sciences, being inaugurated. Thank you.
Thank you so much, ma'am, for those inspiring words. The audience was surely captivated by your words of wisdom. Next, I would like to call upon Dr. Tommy Phillip, Professor and Principal of Pushpagiri Medical College, to felicitate the gathering with his thoughtful and inspiring words.
Our guest of honor, Suma Madam, our CEO, Reverend Father Jos Kalumalikal, HOD Dr. Abdul Qadir Sir, Dr. Cyril, IMA President, Dr. Sunil Matthew, Dr. Ajish, Dr. Abraham Varghese, our Medical Director and Professor of Medicine, our distinguished speakers and chairpersons, dear colleagues and postgraduate students, a warm good morning to one and all. I am here representing the Department of Medicine as well as the Pushpagiri Medical College today. In fact, as part of the medicine department, we are very happy to conduct the 18th CME session. This is after a gap of 2 years where we had the CME online platform. But it's very, very encouraged to come back to the usual pre-COVID era. A very nice feeling to see the entire hall full, because the real sort of CMEs which are offline makes a lot of difference, because it makes interactions, that is academic as well as social interactions, possible. So in that way, it's a very, very happy moment for all of us. And as far as our institution is concerned, as mentioned before, this is the 20th year. Pushpagiri Medical College started in the year of 2002. So in that context also, this CME is very, very important for us. And I especially appreciate the efforts of Dr. Sunil Matthew, the organizing chairman, Dr. Ajish and Dr. Abdul Khasa, the HOD. Of course, it is a teamwork to make it possible today. I extend my thanks to all our distinguished speakers and the chairpersons who have come from within and outside the state. Already we had 3 excellent sessions with very, very good interactions, and I promise a very interesting further sessions. So once again, I wish you all a good learning experience today. Thank you all.
Thank you, sir, for those kind words. Next on stage, I would like to invite Dr. Cyril Joseph, President of the IMA Tiruvalla, to felicitate the audience.
Good morning, all of you. Respected Father Jose Kalumanikal, Suma Madam, Abdul Ghadar Sir, Dr. Tommy Philip, Dr. Sunil and Dr. Ajish, and all senior teachers, faculty and delegates. A warm welcome from Indian Medical Association of the Tiruvallur branch. I thank Dr. Sunil for having given representation to the IMA Tiruvalla in presence of this august body. I wish all this CME for presenting this a lavish academic feast. And in addition to this CME, I also wish to share on this platform a thought process from the Indian Medical Association in the present scenario. In the backdrop of violence against doctors, I think we should also keep our mind open on why this happens. Educating the public is one thing, and I think it has been taken for granted that violence against the medical fraternity can be taken for granted. I think taking a cue from Srilata Madam's presentation, probably we should have some lighting of Niagara Falls on this violence against doctors, probably, maybe to increase the awareness. And second thing is silence is violence. I think most of these instances, it is important that we also speak up. When we don't speak up, it is the other voices against us which get which make more noise and also make more effect. Especially in the backdrop of another feature that mixopathy is going to be a reality with the advent of the Indian medical graduate in 2030. So it's the swords are all open in all directions, and it is my earnest request to all members in the medical profession to have a thought, because it's not only the IMA leaders who can get us out of these issues, and involvement of all the members in the medical fraternity need to fight this. Thank you. And before I end, I would like to invite all of you for the Indian Medical Association Kerala State Branch Conference of the year 2023, which has been granted to IMA Tiruvalla. Thank you.
Thank you, sir. And finally, may I take this opportunity to invite on stage none other than our dear Dr. Sunil Matthew, sir, who played the most pivotal role in bringing this grand event into reality. He has always been a constant mentor and motivator to many of us, the former president of the API Kerala chapter and our organizing chairman. Please put your hands together to welcome Dr. Sunil Matthew, sir.
Respected our CHN, Dr. Suma, Dr. Tommy Philip, and Dr. Abdul Khadar, Dr. Cyril, and our organizing secretary, Dr. Ajish. After a long wait of the COVID, it's our immense pleasure to conduct a CME program like this. I really appreciate the effort taken by my colleague, Dr. Ajish, Dr. Sanal, and the organizing committee for its excellent work and untiring efforts to make this event a memorable one. We are very fortunate in getting Dr. Suma Madam, the ideal person for this inauguration of our CME. The most important personalities are the delegates. Without delegates, any conference will not be a successful one. So my duty is to wish all the delegates a good academic feast. Thank you all.
I also take this opportunity to welcome Dr. Rajesh Koshi, the organizing secretary of this conference, the man behind all the hard work you see on stage, who has worked tirelessly over many months to bring this conference to a fruitful end. I request both of you to please gift the prestigious Aradmulla Kannadi to our honorable chief guest, Dr. T.K. Suma, on behalf of the Department of Internal Medicine, Pushpagiri Medical College. Every good thing must come to an end. On this note, I invite Dr. Rajesh Koshi, our young and dynamic organizing secretary, to deliver the vote of thanks.
Good morning, one and all. Thank you is a prayer. It's not been seen or touched, but felt by the heart. As the organizing secretary, it's my privilege and honor to propose a vote of thanks on this auspicious occasion. First of all, I am thankful to Almighty God for giving us the courage and spirit to arrange this glorious function. At the outset, let me thank my department head, Dr. C. Abdul Qadir sir, for vesting me this responsibility. I thank sir for the welcoming speech and his all-hearted support and dedication as a scientific committee chairman, especially in selecting topics for our CME. Thank you so much, sir. I take this opportunity to express my gratitude to our Honorable Chief Guest, Dr. T.K. Suma ma'am, Principal, TD Medical College, Alapi, for being us today despite her busy schedule and professional commitments. Thank you, ma'am. We express our gratitude to Reverend Father George Kalumalikal, CEO, Pushpagiri Group of Institutions, for the presidential address, his wholehearted support and motivation that helped us to drive the CME forward. I would like to thank Dr. Tommy Philip, our beloved principal, Dr. Cyril Joseph, President IMA TIRUVALLA, for felicitating this occasion. Thank you, sirs. I would like to extend my gratitude to Reverend Father George Velliparambal, Director, Father Thomas Periarath, Hospital Administrator, Professor R.N. Sharma, our Emeritus Professor and previous HOD, Dr. Abraham Varghese, sir, Hospital Medical Director, as the patrons of our CME, who helped us immensely with their valuable contribution and encouragement. Now comes the real hero of today's CME. I express my heartfelt gratitude to Dr. Sunil Matthew sir, organizing chairman, former president of API Kerala, who is a veteran in organizing the CME, for his valuable guidance and being the pillar of support. From the day one we started thinking about our CME, he was always there, starting from selecting the topics or chairpersons, speakers, and whatnot. Thank you so much, sir. I now express my extreme gratitude to all my speakers for accepting our invitation and gracing this occasion with their presence. I also express my thanks to all chairpersons for accepting our request and chairing our sessions. This CME would not be complete without delegates. And thank each one of you for your enthusiastic participation, and also thanking all the postgraduate students from all over medical college from Kerala for their commitment and getting involved in poster presentation. I'm very much thankful to Hotel Elite and the management for the hospitality, Mahadeva audiovisual team for the assistance, DTalk Mr. Radish, Lalji printers and designers, all the pharmaceutical companies, and all those who have worked behind the scenes to set up this stage. And an event of this dimension cannot happen overnight. The wheels started rolling months in advance. We have been fortunate enough to be backed up by a team of very motivated and dedicated colleagues who have been working very hard for the CME to happen. I cannot thank everyone enough for the involvement they have shown and the willingness they have expressed to take on the completion of tasks beyond their comfort zones. I am greatly obliged to them, starting from our senior staff to my colleagues, my PG students, my interns, and our non-teaching staff, Mrs. Jayasri Chechi, for all the clerical and technical work. Due to time constraints, let me stop here. If by mistake I have left anyone, please Pardon me. Thank you, one and all. Wishing all of you a wonderful day.
This marks the end to our formal inaugural function. I thank each and every one of you, my dear audience, for being an active participant and a wonderful guest in today's proceedings, and thereby helping us make the CME what it is, a grand success. This is for the kind information of all our postgraduate students. Please proceed to the Ambassador Hall on the second floor of this building for the poster competition. Moving on to our fourth session of the day, a topic so very common, so very grave, with potentially very hazardous results, yet so very little knowledge regarding its management: thyrotoxicosis and pregnancy. To chair the next session and to introduce our next speaker, I would like to call upon Dr. G. Vijayakumar, who is the Chief Physician at Medical Trust Hospital and Diabetes Care Center, Kulanada, and Dr. Sunil Antony, Associate Professor at Believers Medical College, Tiruvalla. The topic is hosted by Dr. Belinda George, Associate Professor in the Department of Endocrinology at St. John's Medical College Hospital, Bangalore. Dr. G. Vijayakumar and Dr. Sunil Antony.
Good morning. So at the outset, I thank the organizers of the CME, especially Sunil Matthew sir and Abdul Qadir sir, for giving me an opportunity to chair the session on thyrotoxia and pregnancy. As we all know, the thyrotoxicosis presenting in pregnancy is not a rare clinical situation. As a clinician, the important thing is to differentiate between the physiological patterns in thyroid dysfunction gestation and intrinsic hyperthyroidism. And the early recognition, accurate diagnosis, and appropriate management of thyrotoxicosis during pregnancy is an important for decreasing the risk for adverse events in maternal and fetal outcomes. And to enlighten on this topic, we have an eminent speaker, Belinda George. He's a completed MBBS, MD, and DM from St. John's, and he recently published so many publications in your biodata, and is having a lot of research activities. And over to you, madam.
Thank you, sir, for the kind introduction. At the outset, let me thank Dr. Sunil Matthew and his team for giving me this opportunity and inviting me here today. So the topic for today's session is thyrotoxicosis and pregnancy. I understand that largely we have a crowd of physicians here, so I have kept it geared towards what is relevant for treating medical doctors. So this is the broad outline. We will just look at very briefly physiological changes in pregnancy, and we will look at few salient points. Yeah, I think now it's audible, right? Thank you. It's working? Am I audible now? Yeah. All right. So this is the outline for today. We will look at physiological changes, and we look at a few points that you should know when you manage thyrotoxicosis in pregnancy. And I will essentially be using a few cases to get these points across. So we'll start off with a broad case. I'll use that mic. Yeah. So we'll start off with a 23-year-old lady who is a primee, who has come for a routine visit at 10 weeks of gestation. And we always screen for thyroid function test these days. So the TSH was done as part of routine testing, and it came as 0.05. So how would you, not audible?
Yes.
Better? Can you increase the... Check. Is it better? Audible? Okay. Routine testing was done and the TSH was 0.05. Still not audible. Okay, I can try shouting, but my voice is not so good.
Check.
Yeah? Is it audible now? Okay, great. So on routine testing, the TSH was low, and this is something that we see clinically. So what should be our next best step? So we'll just look at a little bit of physiology before we solve that case. So generally what happens in pregnancy is that you will see that the HCG as it begins to rise. HCG is very similar to TSH structurally. So HCG is like a TSH agonist. It has some TSH activity. Because of this, it acts like TSH and causes an increase in the free T4, which is secreted from the thyroid gland. So as the free T4 goes up, the TSH will come down because it is inversely related, right? Because of negative inhibition. So this HCG effect can cause a fall in TSH in the early trimester. And that is what is shown in this graph here. Yeah. So in this graph here, you can see the light blue line, which is the HCG. I think my pointer is not visible here. So the light blue line is the HCG, in which you can see the HCG rises, particularly in the... All right, no problem. It's all right, I can manage without it also. So you can see the light blue line, which is the HCG, which rises, but it's not visible here, right? That rises in the first trimester. You can see that it peaks around 10 weeks of gestation, and by around the patient reaches 20 weeks of gestation, the HCG has come down, and then it remains as a plateau. Thank you. Then it remains as a plateau for the rest of the pregnancy, right? So here you can see the FT4, the relationship between FT4 and HCG. Higher the HCG, higher the FT4, showing that HCG acts exactly like TSH, but with much less potency on the thyroid gland. So here you can see the reciprocal effect on TSH. As the FT4 rises, as the HCG goes up, you will see that the TSH dips. And then from 20 weeks onwards, you can see that the TSH goes back up and remains normal for the rest of the pregnancy. So this is a physiological dip in TSH that you get in the first trimester of pregnancy. The peak is at around 10 weeks, but it normalizes by around 20 weeks. If you look at this graph, you can see that the lower value of TSH is actually 0.5. But sometimes in a small subset of patients, it can even go below 0.5. So this is something that we should keep in mind when we are seeing suppressed TSH in early trimester of pregnancy. So what are the other effects of pregnancy on thyroid function? Of course, you're very familiar with the fact that there is increased renal iodide clearance, so you require more iodine supplements, and because of that, there is stress on the thyroid if you don't supplement it. Of course, estrogen has an effect of increasing thyroid binding globulin. That means the total T4 concentrations also increase in patients with both total T3 and T4 concentrations go up during pregnancy. And of course, T4 deiodination also occurs because of placental deiodinase enzyme. All of these factors require that the thyroid gland, steps up and produces more and more thyroid hormone during these 9 months of pregnancy. So if you have a failing thyroid gland, it may not be able to do that, which is why hypothyroidism is much more commonly encountered in pregnancy as compared to low TSH. However, today we will look at specifics of low TSH in pregnancy. So coming back to our patient, of course, for the first time routinely you saw 0.05. What is the next thing you would do? You would repeat the test and do the entire thyroid profile. I've given you a few more details here. The patient does not have any symptoms suggestive of otherwise what you would see in thyrotoxicosis. The only odd thing is the patient has not gained any weight in the last 4 weeks. Remember, she's 10 weeks pregnant now. She does have a goiter. Her heart rate is around 96 per minute. The TSH, as I showed you earlier, is 0.05. You have done a total T4 now, and that is 17 microgram per deciliter, which is higher than what is normal, which is 5 to 12. So what are your treatment options? So may I have a show of hands? How many of you would want to wait and watch, presuming this is an HCG effect? Any takers for that? No. Anybody? Is TSH receptor antibody easily available here? Is it available here easily? Is it a test that you all do? So how many of you would like to do TSH receptor antibody and confirm the diagnosis? Okay, we have one hand. How many of you would like to do iodine uptake scan or technetium uptake scan? Everybody agrees that you don't want to do. How many of you would want to start the patient on PTU at this point in time? Okay, so there's a fifth option which I have not put up here because most of you have not agreed to any of my 4 options. All right, so let's just look at what happens to TSH in pregnancy. Again, here you can see the first picture is essentially, the first graph is essentially non-pregnant women. So here you can see that the TSH, normal TSH, okay, this has gone to the slide, sorry. Okay, so in the first bar you can see non-pregnant. There is 2 different assays, A and B, and you can see in the non-pregnant women or non-pregnant population, the TSH is always what in the normal range that we define as 0.3 and above. So you can see in the first trimester there is a significant drop in TSH in a small subset of patients, which is what we sometimes see in clinical practice. However, when you look at the third and the second trimester, you can see that they've almost always gone back to normal. So this is how normal TSH behaves in normal women with pregnancy. So in the first trimester, you can have a small subset of patients. Now when you look at T4, here you can see that the first bar is non-pregnant, which stands for NP, and you can see that in first, second and third trimester, there is a significant rise in the total T4 values. This degree of rise is usually to the point of 1.5. So remember, how will you define normal T4 in pregnancy? It is not, like I showed you earlier, 5 to 12, but it has to be considered as 1.5 times the upper limit of normal. So you will redefine your upper range for T4 in normal women who are pregnant, and it will, from 12, it will rise to 18, because that is 1.5 times of 12. So keep that in mind. T4 values were elevated in all 3 trimesters compared to controls, and the range is 1.5. We also use free T4 index earlier. Nowadays we don't use it. We will go on to free T4. So there's always a question, should we do free T4, should we do T4? So if you look at free T4 immunoassay, again it depends on the type of assay that you're using. So here I've put out 2 different assays just to highlight the difference. You can see that, thank you. You can see that in the first trimester, the T4 generally slightly rises if it is this assay, whereas in this assay, this is the average. So here and here, this is actually fallen. So T4 depends on the type of assay that you're using. So you need to know what assay your lab is using and how that will change in pregnancy. So technically, if you want FT4 reference ranges for pregnancy, you have to devise your own, because it depends on the type of assay, it depends on the population that you're studying, it also depends on the trimester. See, you can see the first trimester is here, second trimester is here, and the third trimester is here. So there's significant variation in FT4 values between the trimesters as well. And you can see that both second and third trimester, the FT4 values are actually lower than what is seen in non-pregnant women as well. So it is important for us to know these reference ranges, because when you're treating thyrotoxicosis or hyperthyroidism, your target is either total T4 or FT4. You never target the TSH. So it's extremely important for us to know what your normal target should be. So first trimester FT4 assays were either comparable or lower depending on the assay, but second and the third trimester was almost always 65% lesser compared to controls. So the question is, should we order FT4 or should we order total T4 in pregnancy? Usually in pregnancy, total T4 is good enough. You will not have many conditions where you have to really isolate and dig out FT4. The only thing to remember is that total T4 upper limit should not be taken as non-pregnant, but it should be 1.5 times the upper limit of the normal reference range. If you're using FT4, it is ideal that you have reference ranges for the assay that you're using and for the trimester that you're doing. So coming back to our patient, we decided that we will not intervene with her, because remember, her T4 was only 17, and in pregnancy you can go up to 18. So we just waited and watched, and after 5 weeks of observation, you can see that the TSH is beginning to fall. TSH is beginning to rise, T4 is beginning to fall. And this is as the patient was followed up, you can see that the TSH is picked up and has become normal. So what is the learning point here? It is normal to have elevated total T4 in patients when they are pregnant in all 3 trimesters, particularly in the second and third trimester. In the first trimester, the degree may not be truly 1.5, maybe slightly less, but it is normal. We often see prescriptions with normal TSH, high T4 for non-pregnancy reference range, and patients are being started on anti-thyroid agents, which should not be done. A normal TSH with high T4, normal for pregnancy. A suppressed TSH with high T4, we have to investigate a bit further to decide whether this patient needs intervention or not. So this does not warrant any therapy. If TSH is also suppressed, again, relook at the clinical picture to decide whether this is true hyperthyroidism or this is a physiological HCG effect. If you have doubts, one, of course, is you can do the TSH receptor antibody if it's available to you. The second one is that you can always wait and watch, because generally mild hyperthyroidism is well tolerated by pregnancy, as opposed to hypothyroidism where you don't want to really, you want to treat rather than wait, because you err on the side of treatment. Here you should err on the side of observation rather than treatment, because ATDs can be more harmful than just waiting and watching. Of course, it's different if the patient is overtly hyperthyroid. So coming to case 2, here again a 26-year-old lady who is now in 18 weeks of gestation. She, unlike the other case, here has not gained any weight. In fact, has lost 3 kg. So that is really abnormal for pregnancy. You don't lose weight except in the first trimester, where you can lose about maybe 0.5 kgs, not more than that. She does have a goiter. It is soft. There is no bruit. She is having tachycardia with a heart rate of 130 per minute, and her TSH is 0.005, and she does not have any other feature suggestive of hyperthyroid complications. So what are the clinical features that will tell us that there is a patient who seems to be overtly hyperthyroid and will require intervention, and this is not a pure HCG effect? Yeah. So one is, if they have every pregnancy, the thyroid increases roughly by over 30%. But if you have a soft enlargement of thyroid, it is a clinical clue to suggest that this is a hyperactive thyroid. Generally, the degree of elevation, so if you have a large goiter, again, more likely to be a hyperthyroid goiter rather than a simple physiological increase because of pregnancy. Again, you get bruit because of hypervascularity. So pregnancy also is a state of hypervascularity. Still, whenever there is a bruit, probability that this is a hyperthyroid or hyperfunctioning gland is much higher than when you do not have a bruit. Of course, if you have thyroid ophthalmopathy, it's a very clear-cut case of Graves. There is no doubt about it. So these are clinical clues which tell you that I have to intervene in this patient. I'm not going to wait and watch. If the patient is having significant weight loss, and not significant, any weight loss in pregnancy, and of course the patient is having cardiac failure. So these are clinical clues which will tell you that you need to treat this patient and get the T4 to the normal range. Now coming to the causes, the most common cause that you encounter in pregnancy for a pathological cause is Graves' disease. Of course, you can occasionally see toxic nodules. I discussed what HCG-induced gestational toxicosis is. That usually settles by 20 weeks of pregnancy. Another differential that we see in first trimester is molar pregnancy. Because again here, what is driving the reduction in TSH? The HCG. So the HCG is extremely high in molar pregnancy. So here, they generally present with thyrotoxicosis. So these are the common causes that we see. If TSH receptor antibody is available, this is a very useful test to have in your kit, particularly when you're dealing with pregnancy, because like you may have already, you already know, physiological changes in pregnancy and hyperthyroidism, they have a lot of common signs and symptoms. So it's not often very easy to tease out between the two. So TRAB is an extremely useful test for us in clinical practice. Usually it has to be elevated up to 3 times upper limit of normal in the assay that you're using. You can either screen the patient at first trimester, the first visit, if the patient is having suppressed TSH, Or the clinical utility of this is to look for fetal and neonatal thyrotoxicosis in a patient who is susceptible to have TSH receptor antibodies in circulation. So there we use it at 22 weeks of gestation. So how do you manage, for instance, the previous patient that we had, right? So the drug of choice, if you have to treat in the first trimester alone, is propylthiouracil. Starting 13 to 16 weeks, we would like to switch over to methimazole or carbimazole. And this is the dosing. Methimazole roughly is 6 milligrams is equivalent to 10 milligrams of carbimazole, and that is equivalent to 100 milligrams of PTU. So you will have to shuffle between PTU and methimazole during pregnancy, so it is good to know the conversion factors as well. So coming back to our patient, she did have clinical features of hyperthyroidism. So clinically, our suspicion of Graves' disease is high. So TSH receptor antibody test was done, which came as elevated, and her total T4 is also 24, which is also elevated. So what is the preferred management strategy for this patient? All of you will agree that we have to intervene? Good. So the patient, now you've started the patient, let's say on carbimazole. When do you call her back? Should you call her back in 1 week, 2 weeks, 4 weeks? So should we call her back, and what test should we order when we call the patient back? Do you do TSH? Do you do T4? Do you do FT4? Do you do combinations? Any comments? T4, very good. So always remember that your target is either FT4 if you know the normal reference range in for your assay for the specific trimester. If you do not, it is a good practice to use T4 and maintain it at 1.5, the upper limit of the reference range, right? So never target TSH. If you have a patient who's coming back for follow-up with a normal TSH, you can be sure that you're over-treating that patient. You need to drastically cut down the ATD dose. So TSH, let it remain suppressed. You don't have to look at it. We order it, of course, to ensure that we are not over-treating it, but that is not the target. That the target is always total T4. Now, not just the mother, we should also remember to monitor the baby. So TSH receptor antibody, like I mentioned earlier, is what we screen to look for risk of fetal thyrotoxicosis. For risk of fetal thyrotoxicosis, we do this around 22 weeks of gestation. And if at that point it is positive, we again repeat at around 34 weeks of gestation. That is to look for a risk of neonatal thyrotoxicosis. So if you have a positive TSH receptor antibody, then you have to screen the baby for fetal thyrotoxicosis. How do you screen? You do an ultrasonography. So in the ultrasound, what are the things that you look for? You look for fetal tachycardia. Persistently above 160 beats per minute over a period of 10 minutes is suggestive of fetal tachycardia. You look for fetal growth. So they have IUGR, but at the same time they have accelerated bone growth, and they may also have fetal goiter. So it's very easy to pick up fetal goiter on ultrasonography, particularly if it's enlarged, because then if it's enlarged, the baby may not always be able to bend the neck, so it's more easily visible on ultrasonography. So ultrasonography should be done every 4 to 6 weeks if the TSH receptor antibody is high, to look for fetal thyrotoxicosis. So coming back to our patient, this patient was initiated on 10 milligrams of carbimazole. We repeated the value in 4 weeks. The TSH you can see is 0.01 now, and the T4 is 14.5. So at this point in time, what I just wanted to highlight is that you don't continue the same dose, but you can actually reduce the dose if your T4 is well within the target, right? Because your aim is to give the lowest possible antithyroid drug dose during pregnancy to maintain T4 less than 1.5 times the upper limit of normal. So here, we can further reduce the pregnancy, and over time, generally in pregnancy, we end up stopping the ATD. But of course, the patient will require follow-up because postpartum there is likely to be a flare. So one extra case here, this is a patient who is already having Graves' disease, has been on ATD for the past 4 months. Current dose is 20 milligrams of carbimazole, and now has missed a cycle, has done urine pregnancy test, is positive, and has come to you saying, okay, what do we do now? You already advised me not to go for pregnancy, but I've become positive now. So she's got all her tests done. FT4 is normal, T4 is normal, TSH is still suppressed. What should we do? How many of you for switching over to 200 milligrams of PTU? Show of hands. Okay, one person. How many want to stop ATD? Nobody wants to stop ATD. How many wants to repeat TSH T4 for 1 week and continue the same for now, but we'll repeat after 1 week and see? Okay. Anybody for termination of pregnancy? No. So I think none of the above is what all of you have chosen. So what is the answer? Anybody wants to comment on that? Okay. So remember here, what are the times we can stop ATD in a pregnant woman when they come with UPT positivity? So number one, if they have already been on ATD for generally when we start therapy for Graves, we tell patients, please defer pregnancy. We don't want you to conceive on these drugs. Not that it's very harmful, but it's generally safer to complete your therapy and then go. And we always tell them the therapy duration is roughly 18 months. So wait for that much time, plan it in such a way that, but sometimes it's like pregnancy is very high on their list. So again, we tell them that, okay, when you reach a dose of 5 milligrams of carbimazole, it's absolutely okay for you to conceive, because as soon as you become pregnant, what do? We stop the drug. So if your dose of carbimazole is roughly between 5 to 7.5 milligrams per day, it is an indication that you can stop. But when you're taking 20 milligrams, if you stop, it is likely that they will flare and you will have to restart some medication anyway. So in this case, I wouldn't really stop, but I would switch to PTU. The other thing that you can do is do a TSH receptor antibody level. If your TSH receptor antibody level is high, again, risk of relapse is high, so no stopping ATD, switch to PTU. Other clinical clues are someone's TSH is normal today, like instead of 0.008, let's say it was 1.2. I wouldn't do anything. Even for 20 milligram, I would stop and reassess and restart as the T4 increases. And if the patient has taken ATD for more than 6 months, these are all clinical scenarios where you can attempt stopping of ATD. But in a patient like this, we would want to continue. So here, switch to PTU is the right option, but I put none of the above because the dose of PTU is slightly high. So what is the equivalent dose for 20 milligrams of carbimazole? What is the equivalent dose of PTU? Carbimazole to PTU is 10 is to 100, so it's very easy. I mean, 10 milligrams equivalent to 100. So 20 is equivalent to 200, right? So this is the equivalent dose. But remember here, her T4 is only 9.7, right? So, and you want to give the lowest possible dose. So here I would actually give 150, repeat after 2 weeks, and further reduce if possible. So that should be your aim. Your target is T4, keeping in mind that you want to give the lowest possible ATD dose, okay? So target and follow-up, again, I cannot emphasize it enough, do not target TSH, do not attempt to normalize TSH. So one last case, not really thyrotoxicosis, but here is a patient, this is more like hypothyroidism. She conceived spontaneously. She had Graves' disease in the past. She was ablated. She's become hypothyroid. She's on L-thyroxine replacement, 100 micrograms per day. Now she's come to you. She's referred by the gynecologist because her TSH is 5.6 and at 16 weeks of gestation. So how will you manage? Anybody wants to comment? Will you increase the dose of L-thyroxine? What is your target TSH when you're treating in pregnancy? The target TSH is always less than 2.5. So yes, there is a reason here to increase the L-thyroxine, but I'm not talking about hypothyroidism, I'm talking about hyperthyroidism. So anything to do with hyperthyroidism in this patient? Because she had a past history? So what drives hyperthyroidism? What is the antibody that drives hyperthyroidism? TSH receptor antibody, right? So if you treat it, the TSH receptor antibody is still going to remain in circulation. Now the patient is hypothyroid clinically, yes, but the patient may still be happy, and you've ablated the thyroid gland, so the patient cannot manifest hyperthyroidism even in the presence of TSH receptor antibody, but the TSH receptor antibody can cross the placenta and can reach the fetal thyroid and can induce fetal thyrotoxicosis. So at 22 weeks of gestation, for a patient like this that you see, you should order TSH receptor antibody, and if it is positive, monitor for fetal thyrotoxicosis. So just before I conclude, one last mention about lactation also. So after the pregnancy is completed, there is a risk of flare. So keep that in mind and monitor both mother and baby for relapse of thyrotoxicosis. And in breastfeeding, again, the same principle is there. You can use methimazole. We would like to use lowest dose possible in order to reduce amount of drug that is reaching the baby. And also, generally in Graves' disease, we use methimazole or carbimazole as a OD dosage. We give once in the morning. Whereas in breastfeeding, we like to split and give so that it reduces the amount of drug that is reaching the baby. So in conclusion, do not treat high T4 values or suppress TSH in pregnancy. This may be normal, so back it up with clinical evidence. Most pregnant women tolerate mild to moderate toxicosis very well. There is no need to act urgently. You can wait. Use ATD only if indicated. Minimum necessary dose to maintain the T4 in the target range. Never use TSH for deciding dose adjustments. If the TSH is normal, you can be sure that you're already over-treating the patient. Thank you very much.
Thank you, madam, for enlightening on this topic and taking us through from the physiological patterns of thyroid dysfunction to the pathological patterns also. And now the session is open for discussion.
Not conceived. Actually, patient was receiving oral drugs, antithyroid drugs for Graves' disease, and it was not controlled. But somebody has advised ablation treatment. So in that case, can a unmarried patient can go in for ablation therapy? And what about the fertility after this ablation therapy?
So for radio ablation prior to conception is what you're. So in patients who are not controlled, you can ablate them because that is one of the definitive therapy. The problem with ablation is that generally because of the radioactive exposure, we ask the patient not to conceive for 6 months following ablation. So 6 months following ablation is absolutely contraindication for pregnancy. We counsel them upfront. The other issue with ablation is that generally the thyroid gland gets disturbed, but the TSH receptor antibody is always there. Maybe it will actually worsen, which is why thyroid ophthalmopathy worsens after ablation. So similarly, there is risk, and this receptor antibody may be in circulation for the next close to 12 months. So the risk of fetal thyrotoxicosis remains. So it's not an absolute contraindication to pregnancy. After 6 months, they can conceive, but we should keep in mind that fetal thyrotoxicosis may be there. We need to screen them with TSH receptor antibody and monitor them.
If TSH and receptor antibody is not available freely, what we should do? How will you go about?
So if TSH receptor antibody is not available, then you will only, for the mother, it's okay. You can use clinical clues. We have been managing without TSH receptor antibody for so long. It's the fetal thyrotoxicosis that you're going to miss, and the neonatal thyrotoxicosis. So after the baby is born also, you will have some clinical clues. But fetal thyrotoxicosis, since you're not screening, and it doesn't happen before 20 weeks. It usually happens after 20 weeks, which is when the antibodies can stimulate the fetal thyroid gland. So after 20 weeks, scans are also less. You will finish your anomaly scan also before that. So it's usually picked up a little later when they look for baby's growth. So they will have IUGR, they'll have persistent fetal tachycardia, they'll have fetal goiter. Then we suspect it, and then at that time you have to prove it and treat it.
But suppose if the patient has an in vivo thyrotoxicosis you have detected, how are you going to manage that?
Say that again, sir.
In vivo, if you have a patient with a TSH receptor
fetal thyrotoxicosis. So the antithyroid drugs cross the placenta freely. L-thyroxine crosses about 30%. So we give mother antithyroid drugs, which will reach the fetus. So in my presentation, I spoke heavily about reducing the antithyroid drugs and keeping it to a minimum because you don't want it to cross the placenta and cause fetal hypothyroidism. Here you're going to give a large dose in order for it to cross the placenta and treat the fetal hyperthyroidism, and the mother will be rendered hypothyroid. You have to give L-thyroxine supplement to the mother.
Okay, thank you.
Thank you, sir.
Thank you, Belinda ma'am, for delineating and enumerating all the clinical aspects of thyrotoxicosis, ranging from a postgraduate level to a consultant level. This brings the curtain down on our fourth topic. I humbly request our chairperson, Dr. Sunil Anthony, sir, to hand over a token of appreciation to Belinda ma'am. Thank you so much, sir. I also invite Dr. Jose Matthew, Senior Consultant Physician at Kanyadapalli, from the audience to please gift a memento and certificate of appreciation for our chairperson, Dr. Sunil Anthony. Thank you so much, sir. I am sure that every physician during this season has been bombarded by patients to prescribe them antibiotics for their fever. But are we ethically right to do so? More on this by our next speaker, Dr. O.C. Abraham, Professor of Medicine at CMC Vellore, who will help and guide us in the rational and judicial use of antibiotics by presenting case studies. I request the chairs for this session, Dr. T.K. Suma, Principal and Director of the Filariasis Research Center Unit, and Dr. Shahul Hamid, Professor at Believers Medical College, Tiruvalla, to please take their seats on the dais and to introduce our distinguished guest speaker, Dr. O.C. Abraham.
Thank you, Sunil Matthew and the team for the inviting us to this wonderful CME section. As you know, because of the irrational use of antibiotics over the last 5 to 10 years, there is a lot of antibiotic resistance. Apart from the antibiotic resistance, it may produce a lot of cost, and also it may produce these newer antibiotics will have a lot of toxicities, and also hospital-acquired infections like Clostridium difficile infections, and also the resource setting. You are not, once you are utilizing the antibiotics, the correct person may not get out antibiotics because of the lack of the available antibiotics. The topic is going to deliver by the Professor O.C. Abraham, commonly known as O.C., and he's the Professor of CMC Vellore. Over to O.C. sir for the day.
Good morning, friends. Let me begin my presentation by saying thank you very much. Thank you very much to my good friend and classmate Sunil for continuing to invite me to the Pushpagiri CME series. It's always a pleasure and a privilege, Sunil. Thank you very much, and thank you for the wonderful introduction. My topic is case studies on rational antibiotic use. I will highlight on what I call the 3S approach. The first S is about starting antibiotics. Unfortunately, whether we like it or not, a large part of what we do in medical practice is driven by fear. It's a fact. I also do that. And like all things driven by fear, most of our fears are irrational fears. And a lot of the time we start antibiotics just out of fear. So patient presents with fever, patient may request an antibiotic therapy, we may want antibiotics. We prescribe antibiotics based on a high WBC count, leukocytosis. We prescribe antibiotic based on high biomarker values, high C-reactive protein, high procalcitonin values. We prescribe antibiotics for positive cultures from quote unquote dirty sites, somebody who has a indwelling Foley catheter for CBD for a long time, somebody who is being mechanically ventilated has an ET aspirate sent. So these are all may not represent true infections and therefore no indication for antibiotics. So when you start, who needs empiric antibiotic therapy? As soon as the patient comes into the outpatient clinic, to the ward, the emergency department, should we prescribe antibiotics immediately? It should be reserved when we are fairly certain about the diagnosis of an infection. This patient has a pneumonia, this patient has a pyelonephritis, this patient has necrotizing fasciitis. And patient is seriously ill. What do you mean by seriously ill? The definition of sepsis, infection plus organ dysfunction, especially if there is hypotension. That's an urgency. So everybody with fever do not need antibiotics. Some infections, acute bacterial rhinosinusitis or bacillary dysentery in a competent individual, you do not need antibiotics. They are self-resolving conditions. Choose antibiotics active against the most likely organisms. This you will know only if you make a diagnosis. You know, community-acquired pneumonia, most frequent bacterial pathogen is pneumococcus. You know, for pyelonephritis, most frequent pathogen is Escherichia coli. For necrotizing fasciitis, we know it's group A streptococcus. So we need to make a diagnosis. Think of the most likely organism, and you have now Kerala government has published antibiogram for the state. In CMC, every year we have an updated antibiogram, so we know the susceptibility of E. coli or Staph aureus or strep pneumonia in your setting. Choose antibiotics known to penetrate involved tissues. Very important. Lab may report that the Salmonella typhi is susceptible to gentamicin. Please do not use gentamicin to treat typhoid fever. Okay? Patient is an alcoholic with Friedlander's pneumonia. Klebsiella pneumonia in culture, lab may report gentamicin, but gentamicin is not the treatment of choice for Klebsiella pneumonia causing pneumonia. So you have to use the correct dose and route and duration. So pharmacokinetic, pharmacodynamic parameters, the antibiogram, all are important in choosing antibiotics. The second is streamline. That is 48 hours later, 72 hours later, you have reports back from the lab, you know the clinical assessment of the patient. So you should de-escalate or streamline antibiotic therapy, okay? So there is no repeat all for every day when you go on rounds, okay? It's not just for antibiotics. Every drug in the patient's prescription should be reviewed every day. It's a plea to all the house staff here, residents here. So once the susceptibility report is back, please de-escalate, stop unnecessary antibiotics. And last is about stopping antibiotics. So when infection is resolved, we can safely stop antibiotics. So I will illustrate all these principles through a case study. So how frequent is inappropriate antibiotic use? This is a recent study from CMC Vellore, study published by my colleague Dr. Priscilla Rupali, who has been here before. So this study, inappropriate use was 78% in the ICU, okay? And the most common cause of an inappropriate use was clinically not indicated. So we use lots of antibiotics inappropriately everywhere, including CMC. WHO quotes a figure of about 50%. So anywhere like that. So what are the consequences of inappropriate use? The chair had alluded to this. Adverse drug reactions. If you have looked after one patient with a DRESS syndrome, okay, following sulfa or amoxicillin clavulanate, you will hesitate to prescribe antibiotics. So DRESS syndrome is life-threatening, acute liver injury is life-threatening, acute kidney injury is life-threatening. Okay, so antibiotics can, anaphylaxis is life-threatening. So antibiotics can have pretty nasty adverse reactions. They are not harmless. Damage to commensal microbiome. There are trillions of microbes living on our body, maximum in the gut, on the skin, in the oral cavity. And they are good bacteria. Okay, they are involved in nutrition, they are involved in immunology, they are involved in what is called colonization resistance. The good bugs don't let the bad bugs get into the body, okay? So we know that it can take weeks and even months for the normal flora to return after antibiotics like amoxicillin clavulanate. And most important consequence of damaged microbiome is the bad bugs replacing the good bugs. C. superinfections. Already mention has been made about C. difficile, Clostridioides difficile. Again, a life-threatening infection. Okay, C. diff is directly related to prior antibiotic use. Antimicrobial resistance. Okay, the more you use antibiotics, both appropriate, inappropriate, use in agriculture, use in animal husbandry, all antibiotic use is leads to increased antibiotic resistance. And finally, cost. So because of all these reasons, and last but not least, but I have not put up here, you know the antibiotic pipeline today is a trickle. There are hardly any new antibiotics coming out which are effective against gram-negative pathogens which are resistant. So we are past the golden age of antibiotics. So every reason to use them judiciously. Now let's start with this case. So this gentleman is seen in emergency department of CMC Vellore a couple of weeks ago, end of November. So he's a 65-year-old. He has type 2 diabetes. He's not very regular on therapy. His HbA1c has always been around 8.59. His COPD goal 2, moderate COPD. He has cut down drastically on his smoking, but still smokes. So he presents to the ED. He's quite ill. Abrupt onset of fever, chills, rigors, right-sided pleuritic type of chest pain, cough with sputum, which was initially rust-colored and then yellowish for 1 day. So very abrupt onset of symptoms. He appears unwell. Is coughing a purulent sputum, constantly coughing, febrile, tachypnic. His SpO2 on room air is only 86%, tachycardic, and blood pressure is only 90 systolic. There is impaired notes on percussion, bronchial bed sounds, and crackles over the right hemithorax anteriorly, and this is his chest X-ray. So these are the choices. How will you manage? We'll have a quick show of hands. So those who are in favor of option A, more than one option also you can vote for. Order sputum and blood culture. Who is in favor of that? Please put up your hands. You can go up, no problems. Okay. Order multiplex PCR respiratory panel, biofire panel for. Okay, 1. Start empiric antibiotics. Okay. Okay. Very good. perform BAL? Okay. Anybody for multiple options? Yeah, you should order. Actually, there are no studies showing that. Remember, the standard of care in community-acquired pneumonia management is empiric therapy. Okay, there are no studies supporting that those who had a microbiological confirmation and then you used antibiotics, the outcomes are better. There are no studies, unfortunately. But even the recent ATS CDC guidelines, if the patient is sick enough to get admitted to the hospital, you should aim to have a microbiological diagnosis. And I'm an ID physician. In ID, we always like targeted treatment, So I would like to know the bug, the microbe responsible for this condition and the antimicrobial susceptibility testing. So order sputum and culture and start empiric antibiotics. Remember, this gentleman is sick. His blood pressure is only 90 systolic, okay? He's tachycardic, he's tachypneic, he's desaturating, okay? So he has sepsis, organ dysfunction. This is an emergency, you should start. So we made a diagnosis, right upper lung lobe consolidation, community-acquired pneumonia, severe community-acquired pneumonia in a gentleman with significant comorbidities, poorly controlled diabetes and COPD. So you need order appropriate microbiological studies and start empiric antibiotics. Now, which is the most appropriate empiric antibiotic? So most appropriate and empiric. So this is, we have to start antibiotics within the ED. So we don't have time for the patient to reach the ICU. So those for A, vancomycin plus meropenem. Show of hands, please. 2. Ciprofloxacin and metronidazole. No one. Okay, I'm preaching to the choir. Ceftriaxone, azithromycin and oseltamivir. Okay, most of you. Piperacillin, tazobactam and linezolid. Okay. So what's the most likely microbial etiology in community-acquired pneumonia? Yeah, most studies across the world have shown that the most common bacterial etiology is Streptococcus pneumoniae. But we know that viral pneumonias are now becoming more frequent. We just came out of the SARS-CoV-2 epidemic. I said this is November in CMC Vellore. This is the time when we see influenza outbreak. Remember, influenza in tropical countries is sporadic, occurs around the year, but there are defined peaks. In this part of the world, it's following monsoons. So in Vellore, we see it, we have northeast monsoon. We don't have so much of southwestern monsoon. So we see, so we need to cover for, and then although the classical teaching is lobar pneumonia is not viral pneumonia, it's bacterial pneumonia, it's not 100% true. We always see SARS-CoV-2, we saw it, influenza, we see this. So we should cover pneumococcus, we should cover atypical organisms. There are no randomized control trials again, but again, retrospective studies have shown that macrolide therapy in hospitalized severe pneumonia improves outcome, lowers mortality. Okay, not the best evidence, less certain evidence. And oseltamivir, because we are in the middle of a flu season. Meropenem, vancomycin, okay, meropenem will cover, and vancomycin will cover pneumococcus, but it will not give the other covers. Okay, so that's the most appropriate initial antibiotic therapy. See, remember, all patients with fever and cough do not have pneumonia, and they don't need antibiotics. Okay, how do you distinguish pneumonia versus bronchitis? So you look at vital signs, auscultatory findings, and if you order tests, chest X-ray and CRP. Not everybody needs chest X-ray and CRP. So patient with pneumonia, vital signs are always abnormal. Somebody has normal pulse, blood pressure, respiratory rate, saturation, everything is normal. Very unlikely the patient. Negative predictive value is very high. So then classical findings of consolidation, while auscultation is normal in bronchitis, chest X-ray will be abnormal. We now know that HRCT thorax is much better than plain chest X-ray, but it's not feasible to get HRCT for everybody. And C-reactive protein is high in pneumonia, while it will be normal in bronchitis. So bronchitis is a viral syndrome. You need only symptomatic therapy. Next is streamline. So this gentleman went into the ICU. He was started on ceftriaxone, azithromycin, ceftriaxone IV, azithromycin IV, oseltamivir orally. His influenza PCR came back as negative. Sputum, beautiful picture. This is from up to date, not these patients. Many inflammatory cells and this beautiful gram-positive diplococci. and culture of the blood and sputum grew, strep pneumoniae, susceptible to penicillin and ceftriaxone. So what will you do now? How many for option A, continuing all the 3 antimicrobials? Patient is getting better. His oxygen requirements have come down, antibiotics have been weaned off. In fact, the ICU team said that he is ready for coming back to the ward. How many for continuing all the 3 antimicrobials? Okay, only one. Stop, option B, stop oseltamivir, continue ceftriaxone, azithromycin. How many? Okay. Continue ceftriaxone only. How many? Okay, most of you. Change to amoxicillin. Okay, this is what is called streamlining or de-escalation. Okay, basically you are getting rid of redundant antibiotics. So patient is on broad spectrum, you change to a narrow spectrum. If it is susceptible in vitro, the patient is on multiple antibiotics, initial regimen empirically, you tone down to monotherapy. Remember, although theoretically there are many advantages of combination antibiotic therapy, unfortunately all randomized controlled trials have not shown benefit of any improvement in outcomes with combination antibiotic therapy. There are notable exceptions. Tuberculosis is a wonderful example where combination therapy. HIV infection, wonderful example, combination therapy is better than monotherapy. Infective endocarditis, especially if there is a prosthetic valve, okay, combination therapy. Otherwise, pneumonia, bacteremia, pyelonephritis, meningitis, monotherapy is as good as combination therapy. So change from a broad to narrow spectrum combination to single agent. This reduces ecological impact, and there are multiple studies which have not shown any adverse outcome. Patient's hospital stay is lower, stay in ICU is lower, patient gets discharged earlier, patient's mortality is now different from patient continued on broad spectrum. So I will, because it's only streptococcus pneumoniae, susceptible, you can change to ceftriaxone. If the patient is able to swallow orally, okay, you can even consider changing to oral amoxicillin. Okay, if the patient is still nauseated, vomiting, still has a Ryle's tube, still not fully conscious, I will continue IV only. So depending on the patient's clinical status, either ceftriaxone or amoxicillin are okay. Okay, certainly you can stop oseltamivir. Then since we know the pathogen and susceptibility report, most appropriate one will be ceftriaxone. Remember, when penicillin was introduced, there are studies where they use single dose of penicillin to treat pneumonia. Okay, so it is like hot knife to butter. Now stopping antibiotics. So patient is now back in ward. ICU said, okay, take him to the ward. On day 4, he has reached the ward. Patient is sitting up. When he went on rounds, he is having his breakfast of idli and sambar. So, and wife asked, sir, when can we go home? So how long will you continue the antibiotics? How many for option A? 5 days. Remember, this is a severe community acquired pneumonia who needed ICU care, and blood and sputum has grown, strep pneumonia, susceptible state. How many for option A? Show of hands. Nobody. Okay, one in the back. How many for 7 days? Okay, few hands. 10 days, option C. Okay, most are for 10. 14 days. Okay, Joseph, John and Sunil. Okay, how many for none of the above? Okay, remember, although we all been taught about duration of antibiotics and completing the course, very few infections we know the course of antibiotics is systematically studied. It's arbitrary. Okay, so if you are interested, in lack of time I didn't put it in, Dr. Paul Sachs is the chief of ID at Harvard General Hospital. He has a ID blog. So just type in Paul Sachs and course of antibiotic therapy. Very humorous take on how we arrived at either multiples of 5 or multiples of 7 is the course of antibiotics. You will hear about 5 day, 10 day, 20 day, 30 day, 7 day, 14 day, 21 days, 6 weeks. Okay, hilarious. Wow, how did we reach here? We have no clue, because Emperor Constantine said a week shall be 7 days. Therefore, it is always in multiples of 7. Very few are studied systematically, and we know that we need X number of days. So most of it is arbitrary. So how long is long enough? Okay, let's look at the principle first. Number 1, you want a relapse-free cure. This gentleman gets cured. He's out of ICU now. He's ready to go home. he's having his breakfast of idli. So he's cured, but you don't want the pneumonia to recur. He is already a frail individual, 65, poorly controlled diabetes, COPD. You want minimal damage, or no damage is not possible to commensal flora, as has been highlighted by our chair. And you don't want the antibiotic course. It wants to benefit the patient. At the same time, you want to benefit the community also. You want to, don't want to promote emergence of resistance. So I will draw your attention to this particular clinical trial done in France, published in JAMA Internal Medicine a few years ago. This is a trial among hospitalized patients. So it's not outpatient therapy, hospitalized patients with community-acquired pneumonia. If the patient was clinically stable, persistently febrile, stable vital signs, and was fully conscious, on day 5, they randomized either to stop antibiotic therapy completely or continue till the primary team decided however long they wanted. So intervention was stopping antibiotics at 5 days. Control was continuing as per the primary team's interest. And they looked at clinical success at day 10 and day 30. So hospitalized patients with community-acquired pneumonia. There is no significant difference in clinical success on day 10 and day 30. 48 and 56%, 88 and 92%, 89 and 90%. If at all, the intervention group, the shorter antibiotic course, numerically was better, but this was not a statistically significant result. They looked at pneumonia severity index class 4 and 5. These are severe pneumonias, okay, moderately severe. In class 4, the mortality is around 10%. Class 5 is about 20%. Look at them. Intent to treat analysis on day 10 and day 30. No difference at all. Again, if at all, there is a significant result favoring the intervention group, that is a short course therapy. Okay, but then you're doing multiple comparisons. We don't know what that p-value means. And if you look at radiological resolution, in hospital mortality, 30-day mortality, recurrence, readmission, there was no difference at all. Summing it all up, clinical success on day 10, day 30, clinical success on day 10 and day 30 in class 4 and 5, the severe pneumonias, mortality, readmission, chest X-ray resolution, there was no significant result. So what does it mean? 5-day antibiotic course is as effective and safe for community-acquired pneumonia. Antibiotic can be stopped if patient is febrile and is clinically stable, stable vital signs, not on oxygen, not hypotensive, not on pressures, is awake and alert. Symptoms, signs, X-ray changes can persist. So when you discharge a pneumonia patient, tell the family, cough can persist. It does not mean therapy has failed, okay? Chest X-ray changes can persist even up to 6 weeks, okay? Don't repeat chest X-ray if the patient is doing well. Patient is not doing well, you want to look for abscesses, you want to look for empyema, etc. This is not just one. There are 5 RCTs from 2003 to 2021, okay, done USA, Netherlands, China, Spain, France, and a variety of antibiotics, quinolones, beta-lactams plus atypical cover. Whenever they compared a shorter course with longer course, there's no difference at all, no difference at all. So multiple RCTs, randomized controlled trials, have supported the fact that shorter courses are as effective as longer course in terms of resolution, mortality, readmissions. Lower rates of AMR. There's a study in children, a short course antibiotic therapy for community-acquired pneumonia. They used sequencing to look at the gut microbiome and looked at resistant genes. Patients, children who received the shorter course had less number of prevalence resistant genes in their microbiome, less, okay? So longer course had higher resistance, the presence of resistant mutations. And shorter course always reduces antibiotics use, cost, and ADR. So shorter is better, okay? So the clinically it's all the same, but additional advantages are all there. So to conclude, as clinicians, we need to be excellent diagnosticians and parsimonious prescribers, okay? When you reach for your pen, or if you are in like place like CMC where you have EMR, you open your pharmacy prescription, think, does this patient need an antibiotic? Does this patient have an infection? If answer is yes, does he need immediate antibiotic therapy, or can I wait for the gram stain to come back, the culture to come back? If you're sure there's an infection and patient is looking sick, please start. Parsimonious prescribers. Streamline empiric therapy, always streamline empiric therapy. So starting and then streamlining. And finally, use the shortest effective course, stopping antibiotic therapy. So this is the summary of the 3S approach. I use pneumonia as a model, but the same is true for acute pyelonephritis, necrotizing fasciitis, perforation peritonitis. Okay, those who, if you have an intra-abdominal infection and you have good source control, you can treat with 5 days. Again, that STOP trial published in NEJM a few years ago. Patients who don't have good source control, patients who are immunocompromised, patients who have osteoarticular infections, patients who have endocarditis, those are the ones you will think of longer courses. And finally, less is more when it comes to antibiotic prescription. Okay, remember we have to question. These are all dogmas entrenched in medicine. Alexander Fleming said, if you take penicillin, take enough. This was part of his Nobel lecture. Okay, so but this was interpreted as you should complete the course. What he said that make sure you take the adequate dose. So pharmacokinetics and pharmacodynamics. Okay, that became an entrenched dogma that antibiotic course should be at least 7 days. There is no proof. We can use shorter courses. So that's thank you all for patient listening, and thank you, Sunil, once again for the opportunity. And please join CITS, okay, Clinical Infectious Disease Society, pitch for my society. Thank you very much.
Thank you, Professor O.C. Abraham, for the excellent and clear presentation as usual. So we know that it is antimicrobial resistance is a very important topic, and last week, that is from November 18 to 24, the World Health Organization and CDC have observed the antimicrobial resistance awareness period, and every year we do that. So this is an excellent demonstration of how to avoid this antimicrobial resistance. I think as a slogan, we should use the 3S. That is start, how to start, and how to go about, then streamline, and also stop. We should remember the stopping rules also. Now the topic is open for discussion. Dr. Yusuf.
Thank you, sir. Wonderful talk. Few questions. One is using procalcitonin as a guide, that's one. Second is you are quite liberal on using azithromycin upfront. And what proportion of patients do you think that atypical could have been the cause, because you wanted to cover that? And what if you did not get a culture positivity?
Yeah, good question. Thank you, Joseph. Procalcitonin should not be used as a diagnostic tool, period. Okay? We have enough evidence that it works poorly as a when somebody is critically ill. Is this bacterial sepsis or not? Poor choice. But serial procalcitonins can help you as an adjunct in stopping antibiotics. So if you have procalcitonin done daily or every other day, 80% drop, or an absolute value less than 0.125, that's you can look up. You can stop, but again should not surpass clinical judgment. So if procalcitonin has any role today, it is about antibiotic stewardship, stopping. It's an adjunct. But then again, cost is, so you have to do serial, so in the ICU. So it does not surpass, so patient is doing very badly. Even if the procal is coming down, you should be careful about stopping. Second question is about azithromycin. Yeah, again I said, if you look at outpatient treatment of community acquired pneumonia, there are randomized controlled trials, outpatient therapy where microbiology is not usually done. Routinely adding atypical cover to beta-lactam does not make a difference. Okay? Even among hospitalized patients like this gentleman, there are no randomized controlled trials showing that addition of azithromycin routinely makes a difference. But retrospective studies, about 15% reduction in mortality in severe pneumonia. This is when the therapy is empiric. So the standard, all guidelines are standard. Beta-lactam plus macrolide is for serious, severe pneumonia hospitalized. But once you have culture report back and it's pneumococcus, you can safely streamline, quote unquote, de-escalate like that. How often do you find atypical pathogens? The studies, there have been, I think, 2 or 3 MD dissertations, very rare in CMC. First of all, these are difficult, meaning hospitalized patient is very rare. If at all any atypical can cause severe pneumonia leading to hospitalization, it's Legionella pneumophilia, which is very rare. Chlamydia, all that mycoplasma we do see, but that's mostly the so-called walking pneumonias, outpatient therapy. So initial empiric therapy should have macrolide because of the data, and it's part of all guidelines again. Again, the evidence is weak, so it's up to your judgment. And once you have like this patient, you have a definitive etiology identified, you can de-escalate. If you didn't get, you will continue both. In somebody like him. Yes, yes. 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 Yes.
We have to think of the fear factor. Fear is the key, in fact. So that is why most of us are driven by, we have to give some antibiotics. And regarding you said about pneumonia, you said a patient is safe, you don't have to. We all agree that the X-ray chest clearance takes almost 5 to 6 weeks. But we had a case, everything was fine. We put him in the ICU, was in shock. As I said, we went with meropenem and vancomycin or linezolid. The patient was fine, but pre-discharge we just thought of it. So there was encysted effusion there, encysted empyema there. It had encysted, but patient was afebrile because patient was on a high dose of meropenem and all those things. So if we leave such patient without taking an X-ray, we will be in trouble in that situation. It may be good for CMC, but it may not be good for the peripheral hospitals. The fear is always the key. As in one Alistair MacLean novels, the title, fear is the key. So basically, fear is the key where we have to give the antibiotic. We cannot let, we all agree to that.
Can I just make it, your patient had an empyema thoracis.
Yeah, empyema. Yes, he had a localized empyema.
Of course, empyema thoracis needs antibiotic therapy.
Yeah, the patient came with a pneumonia, and we treated with all those antibiotics. Standard, he was in shock. We went with a septic shock management. At the end of the day, patient looked all right. And at the time of discharge, we took an X-ray. And then we had to take a CT.
So, yeah, community-acquired pneumonia can have complications, metastatic infections, and empyema thoracis. So, patient is not responding to empiric therapy. You do 3 things. Number 1, you revisit your initial diagnosis. Second, you look for complications of the condition. Third, you look and see whether your antimicrobial therapy is appropriate. So, if the patient with community-acquired pneumonia is not responding, empyema is, and then there the treatment is drainage of the empyema.
He became totally asymptomatic at the time of discharge. By chance, we took an X-ray, we found he was asymptomatic because the fluid was sterile, probably because of the whole antibiotic we had given. And the first part, as I said, leptospirosis it's not uncommon in our part. And we are very likely to miss the diagnosis on the first day of fever. So there's no harm in giving an antibiotic, a smaller antibiotic. So your first line remains valid. Fear is the key. Thank you.
Okay. Let me tell you the CMC story about acute febrile illnesses. What we see in CMC is scrub typhus. So does this patient need an antibiotic? Of course the patient needs an antibiotic, but it's not meropenem and vancomycin. We just now concluded an RCT, my colleague Dr. George Verghese. It's been submitted for publication. IV doxycycline or IV azithromycin. So if the patient has scrub typhus and is admitted, it is not vancomycin and meropenem. So that's why patient is sick. 60% will have an eschar or the serology will be positive. There the treatment is antibiotic. So making a diagnosis. So somebody coming to you in the outpatient, you are in the middle of a flu season, fever, runny nose, sore throat, cough, body ache, fatigue, poor appetite. Does that patient need an antibiotic? There, no. Okay. Leptospirosis in Kerala, certainly. You have severe monsoons. Patient is wading through this one, coming with fever, myalgia, subconjugal hemorrhage, all those things. Please go ahead and start the thing. So make a diagnosis. So my thing was that just fever alone, or high WBC count alone, or high CRP or procalcitonin, that is not an indication for therapy, or culture from random sites, not blood culture, of course, like that. But your point is, make a diagnosis. Absolutely agreed. I fully support that. Always make. I said be a skilled diagnostician.
Sir, I'm Dr. Manju Matthew. Here.
Yeah.
I'm Dr. Manju Matthew. I'm a critical care specialist in Pushpagiri. My background is pulmonology and medicine. So thank you very much for the very beautiful talk. Just revisiting the case that you first showed, the COPD patient who's having a lobar pneumonia and comes in septic shock. Blood cultures will take at least usually 3 days, and sometimes in pneumonia it is negative. So So when I did my pulmonology 2 decades back, like we had the same guidelines, antibiotics, ceftriaxone, azithromycin, and we have to include the few gram negatives. But over the last 2 decades, as you know, Klebsiella is much more common now. And compared to the Western world, we have much more gram negatives. I agree that we don't have to add vancomycin, we don't have that many MRSA, but shouldn't we cover the Klebsiella and ceftriaxone, as we know, doesn't cover ESBL. We have around more than 60% ESBL in the community. So somebody who is 60, COPD, comorbidities, and septic shock, what if it is not pneumococcus?
Very good point. So that is why you should have your antibiogram for your hospital. So if your number one cause for severe community-acquired pneumonia is Klebsiella pneumonia, this antibiotic cover, of course, is not sufficient. But there are clinical clues. Patient has history of alcoholism, COPD, patient has bulging fissures, usually in septic shock, and the gram stain will not take any long time. In 3-4 hours, you will see the gram-negative bacilli, Friedlander's pneumonia. If that is the case, and you are in India, you have to include meropenem in your empiric cover. So that is why you should have an antibiogram. Kerala government has published an antibiogram for the state. I have not seen it personally. So in your center, most of the severe community-acquired pneumonia is caused by Klebsiella pneumonia. Please add, Vinila, what's our data in our ICU? Dr. Minla Chako is head of our critical care division. What's the common bacterial pathogen we see in community-acquired pneumonias? Those who are in the ICU?
I think for us it's still strep pneumo. Honestly speaking, we see a lot of secondary infections like nosocomial infections which come in. Those tend to have more gram-negative, but I think still we are seeing a lot of strep pneumococcal infections.
One point is about the antibiogram by Kerala government. Kerala government has done a lot of work on antimicrobial resistance. Initially, there was a development of the strategies, the 5 strategies for managing this one. And also, this is the second limb of that 5 strategies for the surveillance. So all the medical colleges, both private as well as government medical colleges, were included in that, and the results were being sent to the central, that is at Trivandrum Medical College, and from that analysis that the antibiogram has come out. So based on that, the other ASP, antibiotic stewardship program, and also will be further done on that, just to note that on point. Any other questions? Want to make a comment?
So the way the physician is the fancy to antibiotic use with the number 3, 7, 10 like that. So the OCSR has well highlighted that when the patient is clinically settled and the other parameters are within normal limit, we can discharge the patient without any oral antibiotics. Is it right?
Thank you. Yes, correct. Thank you for highlighting that point.
Thank you very much, sir. Just for the postgraduate students, I would like to say that Professor O.C. Abraham is the professor of infectious disease also, and he was the founder secretary of Clinical Infectious Disease Society and has achieved, awarded the Lifetime Achievement Award also. So you can now understand that how experienced the person is talking to you, and just to thrust upon what I was telling in the initial part for the postgraduate students to attend these conferences or CMA program. Here it is thanks to Sunil Matthew, Abdul Khader and the team. Thank you for the excellent presentation and the discussions also.
Thank you so much, sir, for that informative talk. I'm sure we have our priorities set straight when it comes to antibiotic resistance after this session. I'm sure we will all strive to deliver the best care and management that our patient requires. I request our very dear chairpersons, Dr. T.K. Suma ma'am and Shahul Hamid sir, to please deliver a moment of appreciation to convey our gratitude and to show our respect for Dr. O.C. Abraham sir for his participation in this conference. I also request Dr. Anthony, Senior Consultant Physician at St. Thomas Hospital, Chetipura, to please hand over these certificates and gifts to our chair people, Dr. Suma ma'am and Dr. Shahul Hamid sir. Thank you so much, sir. Thank you so much, ma'am. We have two more topics before we break for lunch. The penultimate topic before the afternoon break is a clinical situation we face in way too many patients admitted in our ICUs. Yes, you've guessed it right, the ever enigmatic acute kidney injury. So often we fail to recognize what precipitates it, and once AKI presents, we are at a loss to gauge what the next step should be. But fret not. To offer us some relief and respite, here we have Dr. Binila Chako, Professor and HOD of Critical Care at CMC Vellore. I sincerely request Dr. R. Lekha, who is a retired professor from MCH Alapi, currently working as professor and HOD at Travancore Medical College, Kollam, and Dr. Udayama, professor at TD Medical College, Alapi, to chair this session. I request you to kindly come forward and occupy your seats on the dais. I also request you to kindly introduce our speaker.
At the outset, let me thank Dr. Abdul Kader, Dr. Sunil Matthew and his team for inviting us to chair this important session. As you know, acute kidney injury is on a rise in developing countries, and the percentage is nearly 3 to 30% in hospitalized patients and nearly 60% in critically ill patients. And AKI may be community acquired or it may be hospital acquired. And you find that with vector-borne diseases like malaria, dengue fever and scrub typhus, AKI is very common. Also in the case of other infections like leptospirosis, AKI is seen commonly. And you find that in patients who have a snake bite and envenomation and also toxins, AKI looms up. You take obstetric complications like puerperial sepsis, septic abortion, and eclampsia with hypertension. Also, AKI is on a rise. Also, in patients with diarrheal diseases, pre-renal AKI is common. I will ask my co-chairperson to introduce the speaker.
At the outset, let me thank the organizers to chair this session, give the opportunity to chair us the session. So, to talk on this topic, we have Dr. Binila Matthew. She's a professor and head critical care and CMC Vellore. She is the Deputy Director of Quality. She took his MDM from Mr. MGR Medical College University and FCICM from Australia, and she has a number of publications. Over to you, Dr. Binila.
Good afternoon. It's always very difficult talking pre-lunch when the food is, you can get the smell of the food just outside as well. I'd like to thank Dr. Sunil Matthew and the other organizers for inviting me. It's also very difficult to talk after Dr. O.C. Abraham with, as the antibiotic discussion goes on to kind of get past that. So in today's session, I will be discussing the approach and management of acute kidney injury with the help of some case discussions. For the trainees who are here, why is this topic relevant? Ma'am has beautifully summarized it. But in the ICUs, this is the largest international cross-sectional study, over 97 ICUs. It was found that close to 60% actually developed acute kidney injury at various stages, and a fourth of these patients went on to require dialysis. 25% of them actually died, much higher mortality in the group which had acute kidney injury. Keeping this background in mind, my session is essentially going to focus on these three aspects: prevention, recognition, and response. Let's start with prevention. This is the initiative brought out by the International Society of Nephrology. the 0 by 25 initiative, where their main goal was to ensure 0 deaths by the year 2025 because of acute kidney injury. So we are almost close to the end of 2022. 2023 is a month away, and I don't think we are close to this goal at this point of time. So this group proposed a very systematic approach, just like Dr. Osi talked about the 3S. This is the 5R approach, which focused on risk assessment, recognition, response, renal support, and rehabilitation. All these need to be addressed in order to improve care and optimize patient management. Starting with risk assessment. Now, this is something which I believe every clinician needs to know, not just the intensive care physicians, but everybody needs to know that episodes of acute kidney injury are preventable and amenable to detection as long as we know how to detect it. And it's very important to identify the patients at high risk, not just because of their underlying illness, but because of exposure to nephrotoxins. So who is the high-risk patient? I'm sure many a thesis would have been done on this aspect past 2 decades, lot of literature which is available on risk factors for acute kidney injury. So patients, essentially it boils down to chronic factors and acute factors, chronic kidney disease, chronic heart failure, chronic liver failure, hypertension, and acute problems like sepsis, metabolic acidosis, use of nephrotoxic agents like contrast or vasopressors. All these are risk factors for a patient to develop acute kidney injury. But will every patient with these risk factors develop acute kidney injury? This is where the risk prediction scores come into the place. And this is the largest group scoring system which has come out from a US group and validated in Mayo. They found that a score of more than 5 had the highest area under the curve of 0.81. So will this actually help? In ICUs, a lot of ICU studies, you see a lot of scoring scores which have come up. Do we practically use this at the bedside? Very, very difficult unless you actually have an electronic medical recording system. So in situations where you have electronic databases, do these scoring systems actually help the clinician in predicting the patient who's at risk for acute kidney injury? This study, which looked at contrast-induced acute kidney injury, where they studied electronically, they put their risk factors in. The alert group actually had a lower incidence of contrast-induced nephropathy, so there may be a role for these scoring systems once electronic databases are in place in the ICUs. Now, before I go into the case studies, I thought I must mention about bundles. Bundles is something which a lot of critical care groups talk about. You've got the VAP bundles, the CLABSI bundles for decreasing nosocomial infection. Can you have a bundle approach to decrease acute kidney injury? This is the PREV-AKI study, which actually looked at post-cardiac surgical patients, where they identified patients who were high risk for acute kidney injury by using urinary biomarkers. So they studied the ratio of urine TIMP to the urine insulin growth factor binding protein. If the ratio was more than 0.3, they focused on optimizing volume status, avoiding nephrotoxic agents, and preventing hyperglycemia. Now, honestly, to me, this is what we follow every day in the ICU. We try and do this every other day, but do we need to make a bundle out of it? Maybe in setups where they're not focusing on these aspects, it may make a difference. As in this study, they actually found that the patients who had the bundle, they actually had a significantly lower acute kidney injury. Even the severe acute kidney injury was much lower in the intervention arm. So moving on from prevention to recognition. So this is where the case studies come in. A lot of diagnostic criteria have come up from 2004 onwards, from the RIFLE criteria in 2004 to the latest criteria, which is the KDIGO criteria in 2012. Now, despite these diagnostic criteria being in place, this study from the UK, which actually is a mortality audit, found that 43% of patients actually had a delay in diagnosis of AKI, and a subsequent study in the UK about 10 years later found that 25% of acute kidney injury were not recognized. So keeping this in mind, it is very important for all of us who are sitting here to be able to diagnose acute kidney injury at the right time. Okay, so to diagnose acute kidney injury at the right time, you need to know the criteria. So this is the KDIGO criteria. Remember that you cannot make a diagnosis of acute kidney injury unless and until you have actually corrected reversible factors and optimally hydrated. Only after doing that can you actually go into the staging. Now, patients are classified according to the highest possible stage where the criteria is met, either by increase in creatinine or by the drop in urine output. The creatinine criteria that we're talking about is essentially an increase in creatinine of more than 0.3 milligrams per deciliter within 48 hours, or at least more than 50% from the baseline within 7 days. As the percentage increase in creatinine goes up, the patient goes from a stage 2 to a stage 3. The moment the patient has need for renal replacement therapy, the patient is a stage 3 AKI. Similarly, urine output, it's much easier to monitor in ICU because patients have catheters, urinary catheters. And so in that setting, urine output criteria can be looked at. You're looking at the hourly urine output, less than 0.5 ml per kilogram per hour for 6 to 12 hours is stage 1. As the duration goes on from 12 to 24 hours, it's a stage 2. And if the patient is anuric or oligoanuric, 24 hours, the patient goes on to a stage 3. Now, why is it important for you to pick up these stages? I think it's important that if you pick a patient up in stage 1, you can make sure that you initiate or try and find out what the cause is. ICU is not just about supporting patients' oxygenation and ventilation. We have to find out what's actually triggering off the acute kidney injury and try and treat that to prevent the patient from going to a stage 3. So this is a patient who had come to us many years back, a 35-year-old man who was being treated for a PCP pneumonia. He was, at this point of time of the testing of creatinine, his oxygenation was much better. It was day 9 of therapy. And his hemodynamics were also good. He had no drop in urine output. These are his creatinine values that you see here. Okay, so 0.7, 0.9, 1.4. Okay. So what I'm trying to highlight in this case is a flaw in the criteria that we discussed earlier, the KDIGO criteria. One of the biggest flaws or the problems in the KDIGO criteria is the use of serum creatinine. I'm going to tell you the reasons why it is not the most perfect criteria. I think all of you will know that serum creatinine is a test which lacks sensitivity, specificity. Many factors can affect the values. Most importantly, the level depends on not just elimination but also generation. So if you have, we know that creatinine comes from the muscle, and it then gets metabolized. So the level of serum creatinine depends on the muscle mass, and it also depends on the metabolic biotransformation. Volume of distribution. Now we talked about stages of acute kidney injury where we're looking at this elevation, percentage elevation. All ICU patients have an increased volume of distribution, and this can offset the increase in serum creatinine which we see in the different stages. And the last point, which is applicable to the case that we discussed earlier, drugs affecting tubular secretion. Okay, so commonly, if this creatinine drug interferes with creatinine secretion into the tubules, creatinine can be falsely elevated. Drugs which we commonly use are H2 receptor blockers, and the drug that we saw earlier, trimethoprim, Bactrim. It can actually cause a false elevation in serum creatinine. The patient actually does not have acute kidney injury. So this is one of the flaws with the KDIGO criteria. Moving on to response and renal support. Again, I will cover these aspects with the help of another case. Okay, so I think the focus always is you need to remember it's not just supporting the patient with dialysis. It's not just monitoring the patient. We need to identify the cause. I'm going to discuss some aspects about fluid therapy, blood pressure targets and inotropes, the role for diuretics, dosing of antibiotics, and timing for dialysis. So this is a patient, 64-year-old lady, ideal body weight of 75 kilos. I'm giving the weight essentially for you all to just think about the urine output criteria which we discussed earlier. She's in the ICU following an abdominal aorta aneurysm surgical repair, and she had failed an angiographic endovascular repair 12 hours before surgery. So she received contrast here. Her urine output was 20 ml per hour in the first 6 hours following ICU admission, and it wasn't getting any better. It was still low. Her baseline creatinine a week before surgery was 1.8 milligrams per deciliter. At the point of these results, which I'm going to show up in a few minutes, her blood pressure was okay, and she didn't actually have any shock. She was pretty hemodynamically stable, and oxygenation was fine when she came to the ICU. She was not on any vasopressors. So these are her reports. What you can see here is there is a hyperkalemia, creatinine is elevated, urea is also up, and so is the phosphorus, calcium is low, and you've got a very high SGOT and also highish SGPT, but SGOT is more than SGPT. So, if I asked you all, or if you can just take a few seconds and just think about what are the causes for this patient's worsening renal function, okay? I think, as trainees and as physicians, one thing to remember is always think about it in these three categories. Is there a pre-renal trigger? Is there a renal cause? Or is it post-renal? Very, very important to think about it in this aspect. In this particular patient, I'm not going to read all this, but these are things which just for you all to kind of think about when you see a patient. Many things in ICU are multifactorial, okay? There may be all these points that I have written here for, you know, the pre-renal and renal and post-renal. Any of these points could have resulted in this person's worsening of acute kidney injury. So why do we go through this headache of actually finding out, you know, these triggers? I think our purpose again is to find something which we can treat. Can we treat something? Can we identify a factor which we can, put in place and hopefully prevent the patient who was in the previous case a stage 2 AKI from going into a stage 3 acute kidney injury. So keeping in mind the causes and the results that we saw earlier, I'm just going to show the results once more. This patient most probably had a rhabdomyolysis, which was confirmed with a CPK. And the justification for the same is because the patient had hyperkalemia, hyperphosphatemia, hypocalcemia, and a disproportionately high SGOT as compared to SGPT, okay? So it is important now, by treating this or by trying to get the CPK level down, we may actually prevent the patient from going from a stage 2 to a stage 3, okay? How do we go about that? You know, we know that we need to ensure optimal hydration to make sure that the urine output is more than 2 ml per kilogram per hour. And there are reports that alkalinizing urine with soda bicarb to make sure the urine pH is more than 6.5 tends to prevent and decrease the amount of acute kidney injury because of the ferrihemate. Ferrihemate is one of the byproducts which comes up from the myoglobin. That is what is toxic to the kidneys. That tends to come down. So these are the principles of halting the progression of acute kidney injury. So I'm going to now focus on this aspect of hydration. How do you actually hydrate a patient with acute kidney injury? How many of you all for crystalloids? Crystalloids, colloids? Okay, there's some for crystalloids, nobody for colloids, but many people didn't answer, so I don't know what that means. So, there are a lot of studies in ICUs, in the ICU patients, which have looked at crystalloids versus colloids. It's not in acute kidney injury, but in general, in sepsis, in the post-surgical scenario. This was as recent as 2020. But the gist of all these articles is that there was no benefit of colloids. In fact, colloids had an increased tendency to harm, increased mortality, increased need for renal replacement therapy. So you use crystalloids. My next question to you all is, which crystalloid do you want to use? There's this favorite entity of balanced crystalloids. Any of you heard about balanced crystalloids? Yeah, the people keep on talking about that. The reps will come to you and promote, use this balanced crystalloid, this is going to be better. Okay, how many for saline? How many for balanced crystalloids? Few hands going up, okay. So I just want to, just for the trainee's sake, just to kind of give a very brief thing about what is a balanced crystalloid. Now if you look at saline, the sodium level is 154, chloride is 154. We talk about something called strong ion difference, which is the difference between the sodium and the chloride, okay? Normal value is around 36. As the value drops, it pushes the patient into metabolic acidosis, okay? So sodium chloride has a SID of 0, very high chance of pushing the patient into hyperchloremic metabolic acidosis. So a balanced crystalloid is a crystalloid which has a strong ion difference close to 24 milliequivalents per liter. The electrolyte composition is as close to the plasma as possible, and the chloride level is lower than 110. So this is what a balanced crystalloid is, okay? Again, a lot of recent literature which has come up by very interesting names. So split trial, smart trial, salt trial, basics trial, none of them have shown a benefit of balanced crystalloids. Not even one study has shown a benefit of balanced crystalloids, okay? Now I'm going to change that scenario a little bit. You have hydrated that patient aggressively with normal saline, okay? The rhabdomyolysis patient. The chloride level is now 124. Will you change? Will you change? The base excess, the bicarb level is falling, the base excess is minus 8. Kidney function is more or less getting better, but you know, these chloride levels are going up. Will you go and choose a fluid like this? Now these what I've highlighted are what we call the balanced crystalloids: ringalactate, ringacetate, Hartmann's, plasmolite. The reason why I've just highlighted the potassium, okay, is usually a hesitation. Usually a hesitation. How many of you all have a hesitation in using ringalactate for acute kidney injury? Okay, the worry is always about the potassium and will that push the potassium up, okay? But one thing to remember
is there is evidence to suggest that in patients who have this hyperchloremic metabolic acidosis because of saline, those patients tend to have a much higher potassium because of the acidosis than when you use these fluids, okay? So when the chloride level goes up, patients has a hyperchloremic metabolic acidosis, there is no harm in switching to ringer lactate, which is another cost-effective balanced crystalloid which we have available. This potassium will do nothing to the serum potassium that you measure. Most of the potassium which we have is intracellular. This has not been shown. In fact, the potassium elevation with this is much less than with saline. So the option would be to switch to a balanced crystalloids, possibly something like ringer lactate, which is much cheaper than Plasma-Lite. Most of the studies have been done on Plasma-Lite. What about fluids? How much do you give? So in a patient with rhabdomyolysis, you'll give enough fluids to get that urine output of 2 ml per kilogram per hour. But in other patients with acute kidney injury, the evidence actually shows that you need to kind of have a conservative fluid approach, okay? So there's enough evidence from these trials to say that if you de-resuscitate patients, you make them maybe a neutral fluid balance to a negative fluid balance, their outcomes in terms of need for renal replacement therapy is much less, okay? So you want to de-resuscitate the patient. The patient's creatinine is 2.5, okay? You want to give furosemide. Should you give or not give? How many for give furosemide to de-resuscitate the patient? How many want to give furosemide? I'm only asking these questions to wake you all up. Furosemide, no furosemide? I don't know. Okay, so no furosemide had more show of hands. Furosemide, everyone was a little hesitant. I'm going to just take you through again for the physiological benefits of furosemide. Furosemide actually decreases the oxygen consumption at the loop of Henle by its action on the sodium potassium 2 chloride receptor. And it's actually got a theoretical increase in renal blood flow because of inhibition of prostaglandin dehydrogenase, and a possible benefit of flushing out necrotic debris. But the points against, which I think is the reason why many people didn't raise their hands or nobody raised their hands for using furosemide, is because of the concern of aggravating pre-renal injury because of volume depletion, interference with glomerulotubular feedback. We all know that if you have inhibition of sodium potassium 2 chloride receptors, you've got a lot of sodium sitting there in the loop of Henle, and that can interfere with the glomerulotubular feedback and worsen the blood flow. The evidence which we had earlier on did not support the use of furosemide. In fact, it said that furosemide did not decrease the need for requiring renal replacement therapy, did not decrease the hospital mortality. But I just want to bring your attention to this recent publication. It's published, I think, you can't see the date, but it's about 2020, where they actually studied electronically. They have a MIMIC3 database, which is actually a European database, which has a set of electronic records of patients. And they actually studied, will furosemide administration actually affect outcomes of critically ill patients with acute kidney injury? And interestingly, what they found is whatever the stage of acute kidney injury was, the use of furosemide actually decreased the mortality. Now, this is electronic database records, okay? So this is not an RCT, and the impact was seen more in patients with the urine stage 2 or 3. Okay, so does furosemide have a role? Does it need to be studied further? I think it does need to be studied further in the ICU. I don't think we can rule out its use. The most important thing is, you need to make sure you're not over-diuresing the patient. So let's say the nephrology registrar has read this paper, okay? And the patient has a stage 3 AKI. So stage 3 AKI is patients not yet required renal replacement therapy if the creatinine has gone up tremendously. And the referral registrar, you've called the nephrology registrar and said, come and dialyze the patient. Nephrology registrar said, no, try Lasix. I don't know how many of you face that. We face that every day in the ICU. They'll say, no, try Lasix, give 24 hours. And we'll have our patients, like borderline acidotic, and we're not able to get the nephrologist to come and dialyze. So one quick suggestion which I have is, instead of trying a Lasix infusion, you can try the furosemide stress test. This is if the blood pressure allows, which is a 1 to 1.5 mg per kg, depending on prior furosemide exposure. It has been found that if you have a urine output of less than 200 2 hours after the furosemide stress test, it's a very high chance of the patient going into a stage 3 acute kidney injury. There's still a lot of answers to be got in terms of the role of other diuretics like torsemide, and we should actually standardize this test for patients with advanced stage 3 disease to avoid delay in initiation of dialysis. Okay? So the final word is, it may have a role in conservative fluid strategy, but you must keep a watch on renal parameters, and any indication that you may be exacerbating pre-renal injury, like let's say the sodium going up, the urea going up, you must stop. But this should not delay dialysis initiation. Suppose the blood pressure goes down, should we target a higher MAP? Which vasopressor should we use? Okay, so as of now, the current evidence in critical care from the sepsis PAM study and the 65 trial have shown that a MAP of 65 to 70 is no worse than a MAP of 80 to 85, okay? But having said that, I would say that, you know, when you're targeting a MAP of 65 to 70, make sure you're monitoring the patient. If the patient has any evidence of compromised tissue perfusion, like lactates going up or sensorium going down, you may need to titrate a slightly higher MAP. There's been an interest in vasopressin as a vasopressor of choice for patients with acute kidney injury. As of now, the evidence does not, which we have from 2 big RCTs, does not support its routine use. Vasopressin, the principle by which it acts is by constricting the efferent arteriole and thereby increasing the glomerular filtration rate, but there's no evidence of benefit. A long time back, there was this entity called renal dose dopamine. Okay, it's still being used by some ICUs, where you use a low dose dopamine of 0.5 to 3 mics per kilogram per minute. It does, when you start dopamine, it does increase your urine output. But does it increase urine output by increasing GFR? No. It increases urine output by acting like a diuretic. There's no evidence that this decreases mortality or decreases the need for renal replacement therapy. So let's say now the same patient who was with rhabdomyolysis has a develops breathlessness, and you have a clinical suspicion of pulmonary embolism. And the intensivist has gone and done a CTPA for the patient. The creatinine, which is actually coming down, worsens over the next 48 hours. Could this patient have contrast-induced nephropathy? Yes, very much possible. As Madam was talking about nosocomial AKI, this is one of the most common causes of nosocomial AKI, and this is defined as AKI within 48 hours of IV contrast, which is not attributable to any other causes. A rise in serum creatinine by more than 0.5 milligrams per deciliter or 25% increase from the baseline is how you diagnose a contrast-induced nephropathy. The most important thing to decide to decrease the risk, I think the first most important question whenever you want to do a contrast is always ask yourself, is the test necessary? Is it going to change my patient management? If it's not, don't do the test. Refuse to do the test. Currently, our contrast mediums are quite safe, and both isoosmolar and low osmolar is what is used in most radiology units, and hydration is the key, okay? Even though you may say, why hydration? There's this trial, which was the amazing trial, which looked at hydration versus no hydration. This actually found no benefit. Okay, contrast-induced AKI was the same in both the arms. It was an RCT. Okay, but the thing to remember is this was done in elective patients, not in the emergency settings, and ICU patients were excluded. In patients who had an emergency need for contrast, there is clear benefit of decreasing AKI, of decreasing the need for mortality as well with patients with intravenous hydration. There's also this interest about isotonic bicarb and NAC for decreasing contrast-induced nephropathy. Big trial which was published, a factorial design, preserved trial group, no evidence of benefit of giving isotonic bicarb or N-acetylcysteine. Prophylactic dialysis, is there any role? There's a theoretical role. It does remove the 60 to 90% of the dialysis, but there's no evidence that it will actually help in decreasing your risk of contrast-induced nephropathy. But who would I choose to dialyze? I would choose to dialyze a patient who's got CKD, okay, who needs the contrast, okay? There may be some residual preserved nephrons which I want to take care of. In that patient, I would dialyze after giving the contrast. In terms of timing for dialysis, usually the nephrologist, if any nephrologist here, they would say that intensivists are very aggressive and they want dialysis as soon as the patient's urine output falls. But I think this study has helped guide us intensivists in saying don't be too aggressive. You follow the same standard criteria that you would employ for any AKI study, any AKI patient. Only the standard criteria is needed. You don't need to be aggressive in terms of your approach. Then this is the last section on my study, which is linked to Dr. Osi's talk also a little bit. One concern for us is always dosing of antibiotics. And you know, there's this entity called augmented renal clearance, which we see so often, and we think we see so often in patients with sepsis. It's where the creatinine clearance is more than 130 ml per minute body surface area, and it's been reported to be very high incidence in patients with sepsis, trauma, burns, hemat malignancies. And we all know that if you have such a high augmented renal clearance, it can affect your drug concentrations, okay? So the antibiotics that you give for sepsis, is it actually reaching adequate levels? We don't know. It can affect both concentration-dependent antibiotics and time-dependent antibiotics, and all these antibiotics which we use or abuse or misuse in the ICU are actually affected in terms of their drug dosages. And the only way to know whether we are giving antibiotics at the right dose is if we have therapeutic drug monitoring, which is not available, unfortunately, for all antibiotics. But in general, I'm just going to give you 2 guiding principles. If you have a patient with sepsis, irrespective of what the creat clearance is, whether they have augmented or decreased, we give full dose antibiotics for the first 24 hours. Full dose, okay? Preferably, we give infusions, and you dose adjust subsequently after 24 hours. The disadvantage we have in the ICU is this maintenance dosing. We are doing the drug dosing based on data from chronic CRF patients, on patients who are on intermittent hemodialysis. We don't know whether this affects, whether this dosing is adequate, whether it's enough, whether it's too much for patients on sustained low efficiency dialysis, or if a patient is on ECMO and needs antibiotics, are we giving the right dose? So in conclusion, I would like to state that the most important aspect from all of you all, and which I would request you all to, to passionately look at whether you're in the ICU or out, is prevention, okay? You need to make sure that you are not putting your patient at risk for acute kidney injury. You must know the diagnostic criteria to ensure that you're diagnosing your patients at the right time, okay? Know the KDIGO criteria and make sure once you make a diagnosis that you must try and initiate measures to prevent progression. In terms of resuscitation and renal support, there's no specific map. Keep a lowish map, it's okay, but monitor the patient to make sure there's no any other signs of compromised organ perfusion. In terms of fluids, use saline, but if there's hyperchloremic metabolic acidosis, don't be scared to use ringer lactate, nothing will happen. In terms of vasopressors, no specific vasopressor of choice. And in terms of drug dosing, I think we still need therapeutic drug monitoring and more research on this aspect. Thank you.
Thank you, Dr. Binila, for the excellent talk. Let me ask you one question. On follow-up of these patients with AKI, how many % go in for a CKD?
So based on the evidence that we have, there's a 9 times higher risk of patients with AKI going on to CKD. It's a very, very high risk. So it's not just the mortality in ICU, they go on to develop CKD, 9 times higher than a patient who does not have, who doesn't develop AKI. So it does pose a very major economic burden on the patient and on hospitals if they're supporting patient care.
What is your experience with snake envenomation, especially viper bite, going in for AKI?
So we do see that quite often in the ICUs, snake envenomation coming in with acute kidney injury or developing acute kidney injury. I think there the main role is supporting them through that crisis, which will be most of the time with dialysis. So I think when you know the cause there, what has actually caused it, we must make sure that we prevent aggravating factors for such a situation where you know the cause.
Okay, but what about the gadolinium, which use the MRI?
Yeah.
Because it's also, I think it's...
Yeah, so there is this entity called nephrogenic sclerosis, which you're talking about, with gadolinium, okay, gadolinium induced. Actually, that is, even gadolinium, it gets removed, just like how I talked about IV contrast, which gets removed with dialysis. Gadolinium is also removed to a very great extent by dialysis. But even doing a dialysis post-MRI gadolinium to prevent contrast-induced nephropathy in a routine patient has not been found to be beneficial. But as I said, in patients with CKD, it may make a difference. But in general, the recommendations are avoid gadolinium in patients whose creat clearance is less than 30 ml per minute per body surface area. 30 to 60, you may consider dialyzing them after you give gadolinium.
10 to 20% of the cases, systemic diseases like vasculitis can cause AKI. Then how will you proceed in that case?
So I was contemplating putting it in, but the presentation was becoming too long and too vast. There are, if we had to look at different aspects, so when we have an ANCA-related vasculitis coming in, there may be a role for giving them plasma exchange as well to help them. but and giving them their routine immunosuppression, but it's not a class 1 indication. If you have a diffuse alveolar hemorrhage as a result of an ANCA-related vasculitis, that would be an indication for plasma exchange. But essentially, again, I urge all of you all to look for the cause. So always, when you see a high creat, try and figure out what is actually causing the high creat. Whether it's a vasculitis, then you have to treat the vasculitis. If it's an infection, you need to treat the infection to prevent progression.
Any question? The 3 drastic changes that has come into the literature during the last decade is, one is fluid restrictive strategy in AKI. Fluid liberal strategy has increased incidence of acute kidney injury in ICUs, 1. Second, there is no role for furosemide unless there is fluid overload. Third, AKI should be considered as a renal success from the part of the patient in order to prevent its own injury. It is hibernating by itself. And so you need not support unless there is a classical indication for dialysis. That may produce more injury than a patient not on dialysis. These are the 3 drastic changes that has come over the last decade.
That's true. But I think the thing about de-resuscitation and role for furosemide, I think still there is some scope for research in that area. But it's essentially for de-resuscitation. Don't have to use it if it's not needed.
Srilata Madam, thank you for your 3 comments.
Any questions? If no more questions from the floor, we can wind up this session. Thank you, Dr. Binila, for the excellent presentation. Once again, thanking the organizers for giving us the opportunity to chair the session.
Thank you so much, Vinila ma'am, for your wonderful and brilliant presentation, which highlighted all the do's and don'ts when it comes to AKI. I humbly request our chairs, Dr. Lekha ma'am and Dr. Udayama ma'am, to please present Binila ma'am a token of our appreciation to convey our gratitude and love. Thank you, ma'am. I also hereby call upon Dr. Anthony, Senior Consultant Physician at Changanasheri, to please deliver the certificates of appreciation to Lekha ma'am and Udayama ma'am for their enthusiastic participation.
Thank you, sir. Thank you, ma'am. This marks the end of our forenoon scientific session. Now is the time we have all been looking forward to since the beginning of the CME, the scrumptious lunch prepared for us with love by Hotel Elite. Let us break for lunch and we shall meet again soon in 30 minutes for the next session with more exciting topics and even more exciting speakers. Lunch will be served in the adjacent room and Ambassador Hall in the 2nd floor. Kindly note, for all the 10 speakers, lunch has been arranged in the boardroom in the 2nd floor. 2nd floor boardroom for the speakers and the room adjacent to our main hall and the Ambassador Hall in the 2nd floor for all of us. Thank you. Lunch will be served at 3 venues. The room adjacent to the main hall and the Ambassador Hall on the 2nd floor. For all the speakers, kindly proceed on to the second floor boardroom. Welcome back. A very good afternoon to everyone. I am sure we are all satiated and relaxed after that scrumptious and delicious meal. After a heavy meal, I'm sure everyone wants to doze off. But fear not, for we have arranged a topic for you that will surely awaken you. And it is to be brought to us by an even more energetic speaker. We have with us Dr. Deepak J. Jumani, who is a senior sexual health physician and counselor at Grand Medical College, Mumbai, presenting and delivering a class on erectile dysfunction, how to evaluate and manage. He also comes with practical tips for physicians. With these intriguing headline for the next topic, I request all of you to join your hands together to welcome Dr. Deepak Jumani, sir. To chair this interesting session, we have Dr. Jacob Cherian, a senior consultant physician at TMM Hospital, Tiruvalla.
Warm good afternoon to all of you. May I request all the delegates to please return to the hall. Actually, today afternoon's topic has been very tastefully selected so that people don't sleep. Dr. Sunil Matthew has decided to select a very spicy and a juicy topic. Anyway, and it's one that is very essential for all of us. We have Professor Deepak K. Jumani, a senior sexual health physician and counselor, to take the session for us. And the topic that has already been announced is actually about erectile dysfunction, how to evaluate and manage, practical tips for physicians. Professor Jumani is a diplomate American board certified clinical sexologist, fellow of American College of Sexology, AESCCT certified sex therapist, and attached to Sir JJ Group of Hospitals and Grand Government Medical College, Mumbai Police Hospital. And he's also course director and mentor fellowship in clinical sexology and is editor of Journal of Psychology and Counseling, co-chairman of IMA's Initiative for Sexual Health. I think the list is very long. We all know him. We have heard him before. And just want to welcome you, sir, for this gathering. And erectile dysfunction is a very important topic. Most people suffer silently. And many times they're not willing to share this concern with their physicians. But I think as primary care physicians, we need to inquire into this aspect of male sexual dysfunction and female sexual dysfunction. But then I think it will predominantly be directed towards the male sexual dysfunction. So without wasting much time, I would hand over the session to Professor Jumani.
Thank you very much, sir, for that sexy introduction. Around the world, people love. They sing for love, they dance for love, they make monuments for love, they kill for love, they die for love. And in fact, we all are victims of love. We are all born out of love. But we don't talk about it. Sex is not talked about it. Patients don't talk about it, doctors don't ask about it, and they suffer in silence. In this next 30 minutes, I'm going to give you some nuggets of wisdom to increase your understanding about this common sexual dysfunctions in males and make your understanding a little deeper so that you yourself can evaluate and try and manage these patients. Why we should do that? Because enough evidence exists today that the common male sexual dysfunction, erectile dysfunction, is the earliest marker of myocardial ischemia. So if you diagnose erectile dysfunction in your patients with metabolic syndrome as early as 27, 28, 30 years, you have a window period of at least 3 to 5 years till clinical events of ischemic heart disease develop. So in this 3 to 4 years, you can counsel your patients, you can change his lifestyle, cut off his smoking, alcohol, all other risk factors which affect the endothelium, and retard the onset of critical events in his life.
Gurur Brahma
तस्मै श्रीगुरुवे नमः तस्मै श्रीगुरुवे नमः तस्मै श्रीगुरुवे नमः
My teachers, Dr. O.P. Kapoor, Dr. Prakash Kothari, and Dr. Sashank Joshi, and I beseech them to bless me always. I have some disclosures. I am not from any political party like Congress, BJP, or Aam Aadmi Party. I am not a follower of Asharam Bapu, Ramdev Baba, or Radhe Ma. I am not married to Indrani Mukherjee. I am a staunch Indian Medical Associationite and have passion to educate the masses on the ethical science of sexuality. Mitro, look at our Prime Minister, his hands are down because he offered us GST and lockdown. He had no other choice. Then he told me, Deepak, I said, I will also offer something. So I shall offer unlockdown and my GST. And my GST to all of you is great sex therapy. Is sex secret? Who doesn't know what is sex? We must realize and understand that sex is not secret. It is sacred. It is God-made. Avoiding it is human-made. And intimacy is ageless. But to ignite intimacy, you need to have strategies for mind and body to get optimum sexual pleasures. There is a sexual health tsunami across the globe. Every male and female today have some or the other bedroom woes. 40% of men across the globe are not satisfied with their sex life. 62% of women admitted that they were not satisfied with their sex life. Impotence has been one of the common causes of divorces in India. Struggle with erectile dysfunction. 80% of men struggle in silence. 50% of married men across the developed countries like Japan are staying sexless, sex-starved. So it's a big problem. It affects the individual and the partner, and there is definitely a dent in the relationships. I'm supposed to give you some practical tips as to how do you come to a diagnosis. So to that, the 4 cardinal events which are involved in any sexual act in a male or a female are desire. Students who are here, doctors who are, understand that desire is purely hormonal. If there's a desire discrepancies, it's either low testosterone or low hormones. Erectile issues, which can be vasculogenic, neurogenic, hormonogenic, and many other causes. Ejaculatory disorders, and of course satisfaction or orgasms. Today I'm going to deal only with erectile dysfunction in men. Many people struggle with taking a history of it. So my friend John Malal from Sloan Kettering, he developed an algorithm called Allow algorithm. First is, allow is A, ask your patients, do you have problems in making love? It's not a vulgar question. It's a very simple thing. Then second letter is L, legitimize the problem. Tell them that most of the diabetics across the world have some issues of erections in their bedroom with their partners. And we have solutions for it today. Every patient who's got hypertension, who's got obesity, dyslipidemia, or a smoker have some issues in their bedroom, and today we have the solutions for it. And in case if you have it, we can try to help you out. Then if you cannot, suppose he says, oh, I've got ED, you don't understand, so you refer them if you have limitations. But if you can understand, if you are capable of it, which you will be after this lecture, open up further discussions and evaluate the whole thing and work together to develop a comprehensive treatment plan. Because sexual dysfunction is not just domain of an endocrinologist or a physician or a dermatologist or a psychiatrist. It needs a holistic approach. Our first data from KM Hospital, 56,000 patients. Most of the males had erectile dysfunction, early ejaculation, and low desire. And the women had low desire, and depression in diabetics was seen the most common symptom. It's highly prevalent in India and China. Diabetes, in fact, China is the diabetes capital of the world, closely competing to India. India might win this. So I call Chindia, China and India are the diabetes capital of the world. And erectile dysfunction is the commonest complication of diabetes in men. So Chindia are the erectile dysfunction capital of the world. So what is erectile dysfunction?
Erectile dysfunction, or ED, is the inability of a man to achieve or maintain an erection sufficient for his or her partner's sexual needs. Most men experience this at some point in their lives, usually by age 40. Incidence of the disorder generally increases with age. ED affects about 5% of men in their 40s and 15 to 25% of men by the age of 65. 50% of men over the age of 40 may experience transient ED and inadequate erection. Physical or psychological stimulation or arousal results in significant blood flow to the penis. The arteries in the penis supply blood to erectile tissue, which becomes engorged and expands as a result of the increased blood flow and pressure. This constricts the fibrous elastic sheaths, or tunicae, that cinch to prevent blood from leaving the penis during erection.
So it has to be there for at least 6 months, and there has to be enough clinically significant intrapersonal distress, and it should not be due to any mental disorder. So the causes are psychovascular, neuro, hormonal, iatro, and genetic causes. They have found a special loci on SIM1 on chromosome 6, which indicates that these patients could be having severe erectile dysfunctions. Of all the causes which I just mentioned, please remember, nerves stimulate, vessels circulate, muscles facilitate, and hormones regulate. We see if he does not have any of these causes, aging also produces reactive oxygen species. There is nitric oxide inactivation, leads to endothelial dysfunction and all the vascular complications which we have. The dynamics of erections are threefold. There has to be neurologically mediated increase in the arterial inflow into the penis. Then there is a relaxation of the smooth muscles, so the blood is remaining inside, and there is a restriction of venous outflow, so the penis remains rigid. If anything goes wrong in the blood flow, he's got erectile dysfunction. I call it penile attack or penile angina. And the 4 deadly quadrant of patients are diabetics, obese, hypertensive, dyslipidemia. So if you students see these 4 patients, surely he has some degree of erectile dysfunction. Let me give you a little deeper perspective. This is a schematic diagram of a corpora cavernosa, and this is the endothelium. A normal vascular endothelium or a neuronal endothelium will produce enough endothelial nitric oxide synthetase. This enzyme makes the nitric oxide, which is the chemical signaling molecule or a miracle molecule, which diffuses inside the corpora cavernosa smooth muscle cell, converts guanosine triphosphate into cyclic guanosine monophosphate with the help of an enzyme called guanylyl cyclase. This cyclic GMP, through various mechanisms, relaxes the smooth muscles and the blood flows inside. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5. So looking at this, if you need to know what should we give at what level and what we have today, we have only this PDE5 inhibitors in the form of sildenafil, tadalafil, sildenafil, vardenafil, and now new kid in the block is avanafil. But basic cause is the endothelium, where endothelial nitric oxide synthetase or nitric oxide needs to be there to have good enough sex. So if at all you want to cure erectile dysfunction, you need to cure the endothelium. You need to restore the endothelium into normal. Hence, erectile dysfunction, friends, is an endothelial dysfunction. When we look at diabetes, increased advanced glycated end products and the other things ultimately lead to cavernosal dysfunction and endothelial dysfunction. So diabetes and erectile dysfunction definitely have a link. It is beautifully said that you are only as old as your endothelium. But why should we be worried at the age of 40, 50 about erectile? What is it? Does it have importance? Yes. It's a red signal for impending disasters in a man's life. It's easily said and proven that erectile dysfunction is the earliest marker of myocardial ischemia. Montessori beautifully proved this with the artery size hypothesis. Penile artery is the smallest artery. Coronary artery is slightly bigger. Internal carotid is bigger than coronary artery, and femoral artery is the largest. So when atherosclerosis sets in, and if the 50% of the penile artery, which is the smallest artery, gets blocked, these patients get symptoms of erectile dysfunction. But the same amount of atherosclerosis, we know it's generalized, does not occlude 50% of the coronary artery or 50% of the internal carotid or femoral artery to produce symptoms of the blockages of those arteries. So here is the clinical acumen of a brilliant physician lies, that this amount and this duration between this is definitely 3 to 5 years. And if you diagnose this and retard the consequences of further atherosclerosis, you can save his life. So the relationship between erectile dysfunction is nothing but it's equivalent to subclinical cardiovascular disease, and the duration is around of onset of coronary artery disease around 3 to 5 years in most of these patients. So you can equally call it penile attack in future is going to lead to heart attack. So how do we manage erectile dysfunctions? He inside she, man inside woman, lad inside lady. The point here is the problem may be with the man or a woman, but the solution always lies in the couple. So couple counseling or calling both of them together will definitely aid in treating earlier. You may be having menopause or andropause, but should not be a couple pause. Couples should be counseled together. We have two beautiful validated questionnaires available, IIEF 15 and SHIM 5. They can easily tell you, ask questions on these and give you a diagnosis. Most important to start the therapy, rule out the psychogenic causes of it, because most of them have psychogenic causes. Ask a very simple question. Then last 15 days or 1 month, did you get up in the morning with an erection? If he says yes, he has got psychogenic or situational erectile dysfunction. He does not have any organic cause. So he does not need any PD5 inhibitors. He just needs counseling. What else we do is we advise them on smoking, diet, exercise, blood pressure to be brought under control, lipids, HbA1c to be less than 7, eye, feet and oral hygiene to be examined every time when your patient comes to you. Don't go by the recommendations, the American, Europe. Don't, every time he comes, look at his retina, look at his feet, look at his oral hygiene, put them on guardian drugs, work them up for heart. The other test we do is testosterone free and total, sex hormone binding globulin, hormones. We do a sonography of the scrotum and Doppler studies. We do a digital rectal examination, and we also do a new test called RegiScan. But what all physicians who want to treat erectile dysfunction need today is the skill to ask questions. If you learn the skill, you have mastered the whole thing. So you need to be educated to learn the skill. What are the different markers of erectile? Beautiful markers. Even if you are embarrassed to ask your patients about their sex life, just look at these markers. Obstructive sleep apnea, definitely an indicator of erectile dysfunctions. Chronic gum disease, periodontitis. Salivary tumor necrosis, just take a biopsy or just take a swab. You will see this necrosis. Vitamin D deficiency, uric acid, excess of uric acid. Novel predictor now is HSCRP. Beautiful. Just to HSCRP, if it is high, he could be having erectile dysfunctions. In diabetics, we know there is advanced glycated end products, and we have got a beautiful age reader. Just keep the hand on it and you get a severity of erectile dysfunction. CT thorax, beautiful CT thorax. How does it help? In most of these patients, there's a decrease in glutathione perioxidase activity, endothelial dysfunction, which is caused by nitric oxide, an increase in heparin sulfate levels in the basal membrane, and accumulation of collagen and elastin in the alveolar walls may occur in patients with diabetics. So you can easily diagnose, these radiologists can easily say, whatever be these psychological or hormonal causes, but morphological and functional impairments in the lungs can also give you this. Endocan, simple blood test, 20 rupees is the cost, we can do it. Beautiful test. This is a take-home message. Do CBC of your patients with erectile dysfunction, and if you find the platelet and the lymphocyte ratio, if it is more than 105, he's got mild erectile dysfunction. If it is more than 116, he's got moderate erectile dysfunction, and if it is 136 and more, he's got severe erectile dysfunction. CBC doesn't cost much, and we do this CBC for everybody. Do a mental calculations and then confirm and confront with your patients. Your patients will call you Sai Baba. How did you know about it? I didn't tell you, doctor. So this is the beauty of this simple test. Even neutrophil lymphocyte ratio, if it is more than 3, he's got severe erectile dysfunction. We saw it in COVID. So many patients who had COVID had erectile dysfunction. So it's proven. Hand dynamometer, just this a simple gadget. Ask him to pull it. If he's not able to pull to 80 millimeters of pressure, he's got erectile dysfunction. I work for Bombay Police and I look at the belt sign. The dipping belt sign is an indication of erectile. I don't have to talk to him. I can just see him. He's got it. It's finished. So, and all diabetics are hypogonad. Low testosterone. Definitely they are going to have erectile, low libido, low erectile dysfunctions. So hypogonadism and erectile dysfunction are definitely. Many youngsters today go for, they go to dermatologists and they take finasteride for hair growth and hair loss. So post-finasteride syndrome, they lose erections. This is a bad thing, very sad thing which we are seeing. Kids are watching porn at the age of 12, 14. What are they getting? They're getting this aggressive sex in their mind and they're getting hardwired with it. And when they go and get married, they are not having that same situation in their, what they saw when they got aroused watching porn, and they develop delayed arousal or erectile dysfunction. Porn-induced erectile dysfunction is very, very common. Cigarette smoking, so common. Girls, boys, all are smoking today. Drugs, so many drugs are causing. So we have so many causes of it which you can easily come to know. So diagnosis should not be difficult even if you're not asking your patients for it. How do you treat? Oral drugs, counseling and lifestyle measures. If the oral drugs don't work, give them injections of papaverine in the intracavernous tissue, vacuum therapy, intraurethral prostaglandins, counseling and lifestyle. And if these fail, send them to urologists or androsurgeons who will do implants or anastomotic surgery. But friends, please remember, the basic mainstay of treatment is counseling and lifestyle measures. If you don't do this, they will never improve. We have 4 PDE5 inhibitors, sildenafil, vardenafil, tadalafil. Amongst them, tadalafil has a very long onset of action, around 16 to 17 hours. They all have side effects of headache, nasal congestion. The only contraindications I want you all to remember is the use of nitrates. If the patient is on nitrates, please do not give them PDE5 inhibitors of any sort. For every diabetics, 12 weeks of tadalafil, low dose, 5 or 10 mg, irrespective of whatever is this HbA1c, hypertension, prostatic hypertrophy, or even dyslipidemia, works fantastic for them. Tadalafil is the only drug which improves endothelial dysfunction, gives the man erections, reduces the lower urinary tract symptoms, reduces the congestion of prostate. It's very well known. My friend Dr. Jyoti De from Trivandrum put diabetics on insulin pump and he found 83% improvement in their sexual dysfunctions. Metformin is a golden drug now shown and proven to improve the endothelium. SGLT2 inhibitors, because of the class effects, loss of weight, euglycemia, then less hypertension, less dyslipidemia, the class effects of the drug itself, along with metformin, reduces the vasculogenic causes of erectile dysfunction. So they don't need additional drug like PD5 inhibitors or sildenafil. So the pill burden has been reduced by that. Buried penis syndrome, so common today. Just put them on L-arginine gel, sesame seed oil, which has got androgenic properties, and 1 gram of metformin. In less than 6 weeks, they improve. We have novel therapies like low-intensity extracorporeal shockwave therapy and platelet-rich plasma, PRP. Very, very good, but we lack robust evidence. Now, let me give you a newer perspective. We have been treating patients for last 25 years, but we haven't found any cure for these patients. Why? Because we know the cause is something else. So we have emerging tools for treatment of, and there's a role of regenerative medicines. We have stem cells. 7 diabetic men with stubborn ED who didn't want to go for surgery but didn't improve with any of the treatments besides surgery. They were given 15 million human umbilical cord cells, and 6 out of 7 regained morning erections. They didn't need PD5 inhibitors. L-arginine, which is a metabolic potent amino acid nitric oxide donor. Dr. Louis Ignarro and his colleagues got Nobel Prize for discovering all these things, has been a boon to these patients. If you combine that with fenugreek in a saponized form for all diabetics, it's amazing. Fenugreek has a chemical composition similar to testosterone. So what's new in medical line of treatment today? All should remember, now we have a very good drug called Avanafil, 100 mg and 200 mg. It's got the fastest onset of action. In just 15 minutes it starts acting. It's got less side effects, and it's got a half-life of only 5 hours. So if your patients are on nitrates, skip the nitrates on that day, give him Avanafil, let him have a good enough sex. This drug will wash out from the body in 5 hours, and next day again he can start his nitrates. So this is the only PD5 inhibitor which can give it to patients who are on nitrates. Only caution is skip the nitrates on that day. We have so many newer molecular targets for treatment. All are still in the pipeline. But what we have done today, up till now, what I have told you is nothing but how to get erections. When we look at the male sexual response begins with the desire. It leads to arousal or erection. So we've done nothing for the desire. And so there exists a therapeutic gap. She has a desire and he does not have a desire. And the desire is mainly due to testosterone. It's the free testosterone. And all diabetics are testosterone deficient. It is the albumin and the free bound testosterone which is responsible. So let us think far, think wide, and think high. We know ED is nothing but endothelial dysfunction. So we need to focus our concentration and our clinical acumen on treating the endothelium. Because the risk factor of all the risk factors we all sitting here is nothing but endothelial dysfunction. And endothelial nitric oxide is proven to be anti-atherosclerotic and anti-thrombotic molecule. And we have got beautiful pharmacological remedies to prove this. So what's new? We need to understand the science behind nitric oxide. It expands the blood vessels by 26% of most of the vital organs like brain, kidney, penis, and the heart. Enough studies to prove that L-arginine, which produces nitric oxide, improves erectile dysfunctions. Phytonutraceuticals like L-arginine and fenugreek combinations are fantastic. 17 years of our clinical experience have found nothing as cutting-edge therapies for these solutions. So what do? We know that these are very good, but adherence is the problem. Patients don't adhere to the treatment for it. So my friend Dr. Paresh Dodona from Buffalo tried to treat these patients with testosterone therapy for 2 years. And he found in these diabetics there was improvement in insulin resistance, libido, sexual functions, etc. Dean Ornish proved long time back that with intensive lifestyle changes, he can reverse the coronary artery diseases. It's proven beyond doubt and published also. So nutritional intervention, intensive lifestyle modification is the gain. We all have bad genes. Our parents we have those genes. But these genes get activated only when we spoil our lifestyle. The trigger is the erratic lifestyle which we have. And most of the modifiable factors today are what? Smoking, sedentary lifestyle, and diet. We need to control all these things. It's in our hands. These are not voluntary, involuntary. These are all voluntary things. Cleveland Clinic beautifully in their study said that nutritional intervention in their study not only halts but even reverses the coronary artery. Look at this huge plaque. completely opened up just with nutrition, no statins, no aspirin, nothing, no plasties done. So we have so much of evidence to prove. So Thomas Edison long time back said, the doctor of the future will no longer treat human frame with drugs, but rather will cure with and prevent disease with nutrition. We have so many things to give to our patients to restore the endothelium. We have statins, we have ACE inhibitors, antioxidants, L-arginine. 4 weeks of L-arginine therapy improved the sexual functions. Like my teacher, Dr. R.D. Lele, way back in 2007, showed us so many successful strategies to restore the endothelium. So what is the secret of sexual fitness? Love yourself. Don't think that you are bad. You are good. Avoid salt, oil and sugars in excess. Take a Mediterranean diet. Give a U-turn to your metabolic imbalance. Have a regular rhythm of sex life. Sex is our body's normal and natural functions like urination, passing stools, eating food, breathing, etc. All these other functions have a rhythm. You pass urine 5 to 6 times a day, you pass stools 1 or 2. But do you have a rhythm of sex life? No. Imagine 2 days if you don't pass urine, what will happen to you? So you need to have a regular rhythm of every normal and natural functions. Romance, I find after 40, men are not romantic at all. Why? There is no GST on romance, nothing. Touch, hardly couples touch each other. So it's a shame for a man to grow old without seeing the beauty and the strength of which body is capable of. Socrates said long time back, try and hug your partner every day. Hugging is very good. It's embracing, it's touching hearts, you know. Increase the romance. There is no GST on romance. Yeah, what are you losing? Imagine those days when you were romantic, how good it was, how longing you were for each other. Husbands watch porn, wife is working in the kitchen. What is the signal the husband is giving to the wife? He's giving her a signal that he likes the girl more in the movie than her. What a wrong thing to do. Instead, watch the porn together. And the husband should criticize the girl in the movie. That's very important. Improve your bedroom. Bedroom is used for everything else today, except sex. You have your TV, you have your mobile, you have a laptop, you sing, you do everything, but no sex. Bedroom ethics is bedroom is only for sleep and sex, nothing else. Husbands ejaculate, turn themselves on the other side and sleep. Mera kaam ho gaya. There's no concept of afterplay. But what a wrong thing. Once a man ejaculates, he should hold her partner tight, hug her, thank her, compliment her, tell her she was awesome, she was beautiful, and do everything what he did during foreplay. But he should compliment her. Because if you look at a girl who's done a lot of makeup and a lot of makeover, anybody would say, oh, she's gorgeous. But if you compliment your partner in the bedroom, you give her a signal that you like her the way she is, and that speaks smiles. That is, don't use your partner like a sleeping pill. That's wrong. So what men think they want and what women think they need. Let's unravel the blindfold. Every wife is a mistress for a husband. See, we all change, you know. Are we same as what we were 10 years back? We all change. So variety is there in our life's nature. We have to learn variety. So every wife is a mistress for a husband. Miss for 1 hour, stress for the rest 20 days. This is wrong. Absolutely wrong. No. We have total, absolute, persistent disregard for her satisfactions. Rishi Vatsayana in Kama Sutra clearly says that it is mutual satisfaction. Samma bhog means equal joy. So what women should do? Regard your husband or your partner as a hero. Never give him any pressures to perform. Yeda hai, teda hai, lekin mera hai. That's important. These women all, they were abandoned by their better halves. And they got a makeover done. And they were again adored and admired by. So my plea to all the ladies here, try and look as beautiful as possible. Spend your husband's money, go to the parlor, look as sexy, as beautiful as. Don't worry about the money, but you should look better. So what men should do? When you come back from home, when your partner is meeting you, listen to her what she's saying. Don't try to give her advices. Keep your mouth shut. Just let her talk. Give her trust, time, not gifts. Share and be transparent. So my take-home message is, the onus of sexual health of your patient is with you. You have to ask your patients, do you have problems in making love? Teach them what is realistic. Don't tell them that, oh, you will rock in bed at the age of 80. No, your things are changing. Your age is there, everything. Counsel them and what is realistic. Friends, wrinkles never hurt anybody. have a life. You may be Hindu, Muslim, Sikh, make lifestyle modification as your first and the most important religion today. Because if you modify your lifestyle, you reduce the pro-inflammatory status which you are in, you reduce the insulin resistance, oxidative stress and endothelial dysfunction, and you will have a reduced burden of sexual dysfunctions. Two-time Nobel Prize winner Dr. Linus Pauling declared when he received his Nobel Prize for the second time, he said nearly all disease can be traced to a nutritional deficiency. What else you want? Such a brilliant man in the earth telling you, giving you this signal. Why can't you counsel your patient on nutrition? It will make a great difference in his life. So we have all PD5 inhibitors. They do not increase the desire. Your desire, they are not desire drugs, they are erectogenic drugs. And 40% of patients are non-responders because they went and took it from the chemist, they didn't tell him anything, they got headache, they left it, they felt, oh, I have to just take medicine to get erection, this is wrong, nothing like that. So what do? We have Badsha, the testosterone, give them. But we got to give it with caution. You can't give it to young patients because of azoospermia, you can't give it to elderly patients because he may develop heart failure or he may have prostatic issues. So who's the Raja of all? The Raja of all is L-arginine, fenugreek, give them bindas, nothing wrong, no side effects at all, and lifestyle modification. This is the best what you can give. But it is seen. Friends, try and love your partner, each other unconditionally. You all are partners for life. And the language of love which a woman understands is communication and romance, and men understand only sex. Feminism needs to be adored, admired, trusted and respected. Look at Mahabharata, look at Ramayana, what did it teach us? If a man who does not admire feminism, we are all born out of her, yaar. We are all born out of her. You need to respect feminism. If a man who does not respect a female or feminism, I pray to God that he should get permanent, incurable erectile dysfunction. Love is a flow, it's creative, and that's why it flows and brings contentment. This contentment is much more deeper and valuable than the contentment after sex. One who knows that contentment will never look for any substitute. Just like a person who acquires jewels never seek pebbles or stones for contentment. Children should be taught to love from infancy. The myth that teaching of love would lead to child into the world of sex is groundless. This is a fear. The more love grows in a person, the more sex energy is transformed into sex and is shared. The less love filled a person, the more sex-minded, more hatred a person has, more jealousy, competitiveness, worry and unhappiness will be in his life. So be fearless, passionate and focused even in the bedroom. Nothing wrong in that. Voltaire beautifully said that being monogamous is like a garden and polygamous relationship is like a jungle. Both are beautiful, but jungle is little wild. But for a garden to make it beautiful, you need to devote time. You need to cut the right type of grass, put fertilizers, give water, etc. So in a monogamous relationship, which is like a garden, you have to devote time. That is what Voltaire beautifully said. Try and cultivate your own garden. Be mono. So friends, erectile dysfunction is not an option. It's how we handle the process and how lucky we are as the process handles us. We've got so many things to give to our patient that there is a cure also available today. It's a blessing in disguise that today with whatever we have, erectile dysfunction is a correctile dysfunction. So if you have patients of erectile dysfunctions, don't send them to quacks. Treat yourself. Simple. It is simple. If you cannot, if you have limitation, Send them to a good sexologist and he will see that he gets a good erections. This is my book, Sex Has No Expiry Date. My last slide. Erectile dysfunction is prevalent and earliest marker of coronary artery disease. Diabetes is a sexual health tsunami of our century. Sildenafil, tadalafil, sildenafil and vardenafil are effective treatment. Low-dose PD5 inhibitors, statins can be the ideal choice for diabetics. Short course of testosterone can be given with caution. L-arginine supplement with fenugreek is a boon. Diabetes remission is a fact and not a myth. Detailed history, counseling, empathy, education are the key. And if so, friends, erectile dysfunction is a correctile dysfunction. So don't let your diabetics die in bits every day. And if so, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have.
Thank you, sir. I think you deserve a better clapping for this session. Come on, let's give a better clap. Thank you, sir. Well, I think we can take one or two questions quickly.
That's for early ejaculation, not for erectile dysfunction. Yeah.
Depoxetine should also have been included in that.
Yeah, depoxetine is a very good drug. It's an SSRI, antidepressants given for patients who have got premature or early ejaculations.
All these early years, we were told that it's all psychogenic.
Yes.
Now things have changed to endothelial dysfunction. So, but
Yeah,
still
psychogenic is a different concept completely. Whereas any organic erectile dysfunction is an endothelial dysfunction. If he has diabetes, hypertension, dyslipidemia. Psychogenic is purely, he says, yesterday I performed and today I can't perform. It's purely psychogenic, it's acute. And organic is gradual. He has a breakup or he has a fight with somebody or something like that.
Usually it's a mix of both, psychogenic and...
Every organic erectile dysfunction has some psychological component always.
Man is potent with the same woman. Man may be having erectile dysfunction with one woman, but he's very potent.
Yeah, but that is,
so that is
situational.
That is a
situational erectile. That is psychogenic.
Thing.
Yes.
Man is
so
important with the same woman at one point of time, but he's
he can get transient ED anytime.
So that what I want to point out is that it is a mixture of
always erectile dysfunction, even if it is organic, there is some psychological component always in it.
Always there, yes. So it is always.
But in psychogenic component, there is no organic component.
I think, yeah, since we're running short of time, we'll have to close the session now. Thank you, sir, once again for that excellent presentation. Thank you. Thank you, Dr. Sunil Matthew, for this opportunity.
I invite Dr. Jacob Cherian, sir, to please present a memento to Jumani, sir, as a token of our gratitude and respect, and for delivering such a power-packed class on such an intriguing topic. Thank you, sir. I also request Dr. Thomas Sebastian, Senior Consultant Physician, Chetipura Hospital, to offer certificates and a memento for our chairperson, Dr. Jacob Cherian. Moving on to our next session, we have with us Dr. Binoy Paul, Professor of Medicine and Chief of Rheumatology at KMCT Medical College, Calicut. He will be sharing and teaching us the correct way to approach a patient with vasculitis. This session will be chaired by Dr. B. Padmakumar, Professor at Alapura Medical College, and Dr. Jayashree, Senior Consultant Physician at GH Pathanamthitta.
Good afternoon, everybody. We are thankful to Abdul Qadir sir and thank you, Sunil Matthew sir, for giving us this opportunity to chair this wonderful session. After an interesting talk by Dr. Junani, we move on to another important clinical topic, that is approach to a patient with vasculitis. As we all know, vasculitis is just inflammation of the vessel wall. The clinical manifestations may vary from asymptomatic skin manifestations to very serious catastrophic multi-organ involvement. Usually a clinician will suspect vasculitis when an unusual patient comes with a unusual case presents with a multi-organ involvement, including skin manifestations, joint manifestations, etc., where a diagnosis is not possible. The diagnosis of vasculitis is not as easy as we think because of the resemblance to many other clinical manifestations. So naturally the diagnosis of vasculitis is delayed also. So as in any other clinical case, a proper history, a detailed systemic examination, and relevant investigations will help us to make a proper diagnosis. So to educate on this topic, we have the right speaker, Dr. Binoy Paul sir. To introduce him, I would like to give the mic to my co-chairperson, Dr. Xviii.
Good afternoon, everyone. My duty is to introduce our speaker with great privilege, Dr. Binoy Paul, the eminent rheumatologist from Calicut. He is a professor of medicine and chief of rheumatology, KMCT Medical College, Calicut. Dr. Hardis MBBS and MD at Kottayam Medical College. Held the position of Secretary of Indian Rheumatology Association 2 times and authored many textbooks and several publications in his name. Over to you, sir.
Respected chairpersons, senior teachers, colleagues and friends. At the outset, I thank the organizers for giving me this opportunity to talk about a topic which is not commonly discussed in the physician forums. And I find it very difficult to talk today after the very beautiful lecture by Dr. Deepak, because the subject he talked was very close to our heart. And in addition, he is a very powerful speaker. And we are going to a very different scenario, vasculitis, a clinical approach. As you are aware, vasculitis is inflammation occurring in the blood vessel walls. It affects arterioles, capillaries, venules and veins. Often leads to destruction of the blood vessel or aneurysm formation. And it could be primary or secondary. The primary where the cause is unknown, and secondary there are many causes like infections, neoplasms, connective tissue diseases, coagulopathies, all sort of drugs and many other miscellaneous causes. But today I am focusing mainly on primary systemic vasculitis. The Chapman Hill's Consensus Conference in 2012 classified vasculitis based on the vessel size. So we have a large vessel vasculitis, a group of medium vessel vasculitis and small vessel vasculitis. A large vessel means aorta and its major branches and the analogous veins. A medium vessel means the main visceral arteries and vein, like the renal artery, the coronary artery, they are the medium vessels. And the small vessels are the intraparenchymal arteries or arterioles. The afferent and efferent arterioles of the kidney are best examples. So basically there are two types of large vessel vasculitis. One is Takayasu arteritis, otherwise called aortoarteritis, and the second is the giant cell arteritis or temporal arteritis. And we have two medium vessel vasculitis, polyarteritis nodosa and Kawasaki disease. And we have two types of small vessel vasculitis, anti-neutrophil cytoplasmic antibody or ANCA-associated vasculitis and immune complex vasculitis. The ANCA-associated vasculitis are different types. The granulomatosis with polyangiitis, previously known as Wegener's disease. Eosinophilic granulomatosis with polyangiitis, previously called Church-Strauss syndrome, and the microscopic polyangiitis. And we have the immune complex small vessel vasculitis like the antiglomerular membrane disease, cryoglomerulemic vasculitis, IgA vasculitis, previously called Hinoxolin purpura, and the hypercomplementinic urticarial vasculitis. All these are immune complex associated system, small vessel vasculitis. And we have variable vessel vasculitis where vessel of any size can be involved, from large to medium to small arterioles, venules, veins. So the best example is Behçet syndrome. A single organ vasculitis, for example, isolated cutaneous vasculitis or a primary CNS vasculitis, they are single organ vasculitis. And vasculitis can be associated with systemic diseases like SLE, rheumatoid arthritis, and sarcoidosis. And vasculitis associated with a probable etiology like infections like hepatitis B or C or syphilis or drugs or malignancy. So in this classification, some of the secondary vasculitis are also coming in this group. So to memorize it once again, we have large vessel vasculitis like temporal arteritis or Takayasu arteritis. We have medium vessel vasculitis like polyarteritis nodosa or Kawasaki disease. We have small vessel vasculitis which may be ANCA associated or immune complex mediated. We have single organ vasculitis like cutaneous vasculitis or CNS vasculitis. Or we have variable vessel vasculitis where a vessel of any size can be involved like the Behçet disease. Even though I say large vessel vasculitis means predominant involvement of the large vessel, there can be some involvement of the medium or small vessel involvement in Takayasu arteritis also. Now coming to the pathogenesis, as you are aware, there is inflammation of the blood vessel, there is endothelial injury producing endothelial damage, active inflammation and scarring. Sometimes it may lead to aneurysm formation. And pathologically there are different subsets. It may be a systemic necrotizing vasculitis, granulomatous vasculitis, but there can be necrosis as well as granuloma together, and even leukocytoclastic vasculitis. So when should you suspect vasculitis? The features that are common to all vasculitis are fever, anorexia, weight loss, arthralgia or arthritis. So patient presenting with this type of symptoms associated with certain other symptoms depending on the size of the vessel. If it's a large vessel that is involved, the patient may come with limb claudication, asymmetrical blood pressure, absence of pulses, bruit over the various vessel, and sometimes aortic dilatation or aneurysms. So that is the usual presentation of a large vessel vasculitis. On the contrary, a medium vessel vasculitis may present with multiple cutaneous nodules, skin ulceration, livedo reticularis, digital gangrene, mononeuritis multiplex, or microaneurysms. On the other hand, small vessel vasculitis usually present with purpura, glomerulonephritis, alveolar hemorrhage, urticaria or cutaneous extravascular necrotizing granulomas, splinter hemorrhages, eye problems like uveitis, episcleritis or scleritis. When a patient presents with this type of symptoms, you have to think about a small vessel vasculitis. So in the clinical scenario, how will you suspect vasculitis? Which are the situations where there is the highest probability for vasculitis? Whenever you see a patient with palpable purpura, it is vasculitis, vasculitis and vasculitis only. If you see a patient with recurrent mononeuritis multiplex and you have excluded common causes like diabetes or Hansen disease, you have to think about vasculitis. When a patient presents with the renopulmonary syndrome, vasculitis is one of the possibility. And probably the high probability can occur with a non-healing clean edge ulcer. Think about a cutaneous vasculitis, a digital gangrene where the other causes are excluded. Patient presenting with multiple pulmonary nodules, asymmetrical pulses, refractory asthma or eosinophilia. These are the situations where there is a high chance that this person is having a vasculitis. But you should consider or suspect vasculitis whenever you see a patient with multi-organ involvement, pyrexia of unknown origin, glomerulonephritis, ischemic vascular changes like claudication or Raynaud's phenomenon, chronic inflammatory sinusitis, recurrent skin lesions like erythema nodosum, uveitis, episcleritis or scleritis, orchitis, arthralgia or arthritis or abdominal angina. In all these situations, when you should also consider vasculitis as one of your differential diagnosis. So approach from a practical angle, first we should find out which are the organ that is involved, which is the vessel that is involved, what is the likely cause. And I will try to tell upon some of the case scenarios of different types of vasculitis to understand it better. This is the story of a 19-year-old female who came to the doctor for claudication pain in the lower limb of 1 year duration. And the doctor found that the pulsations are reduced in the lower limb. And the blood pressure was high. There is some cardiomegaly, but the heart sounds were normal. So he promptly thought of an young girl presenting like this. Our conventional teaching is to think about coarctation of aorta. So she was referred to a cardiologist. He found the echo only LVH, the valves and thoracic aorta are within normal limits, but he found that the ESR was high and there is extensive bruit or the femoral, brachial and carotid arteries without much collaterals. And the Doppler shows narrowing of the proximal aorta, and we did a angiogram, the CT angiogram showing narrowing of the proximal descending aorta. You can see it here also. And also there is narrowing of the left renal artery. So this is aortoarteritis, otherwise called Takayasu arteritis. Whenever you see a patient with young patient below 40 years with asymmetrical pulse, claudication and a bruit over the various vessels, you think about Takayasu arteritis, and a CT angiography will be the best investigation to pick up. You can do other investigations including arterial biopsy, which is not usually required, but one has to rule out other causes. Some of them I have already told, like coarctation of aorta. Syphilitic aortitis is nowadays not very common. Behçet is another possibility. Rheumatoid arthritis can sometimes present with aortitis. So Takayasu arteritis is granulomatous inflammation of the aorta and major vessel, usually occurring in females below the age of 40 years. This is the commonest large vessel vasculitis in India, often associated with vascular occlusion. There are some classification criteria forwarded by the American College of Rheumatology and EULAR in this year. I am not going to the details of this classification criteria, but remember that aortoarteritis is the commonest cause of large vessel vasculitis even in Kerala, predominantly affect young females between the age of 20 to 30 years. It's an important cause of hypertension in young female, and there is a high incidence of abortions. This is the story of an old man, 63-year-old man with chronic headache, evaluated by an ENT specialist. His X-ray PNS and CT head were normal. He noticed loss of vision in one eye and approached an ophthalmologist who found there was some optic atrophy. So the ophthalmologist did some preliminary investigations, and he was found to have very high ESR, rheumatoid factor and ANA were negative. So that stage he was referred, and the striking thing was the prominent temporal artery with tenderness. There is no history of fever, arthralgia, jaw claudication or diplopia. Temporal artery biopsy showed inflammation of the artery in the segmental fashion with granulomas containing giant cells. So he had excellent response to steroids, but his vision has not regained. So unlike Takayasu arteritis, whenever you see a patient with an asymmetric pulse or claudication, think about giant cell arteritis. Of course, old people, one has to rule out atherosclerosis and rheumatoid arthritis. And the investigation of choice is a temporal artery biopsy. This vasculitis is very uncommon in our population compared to aortoarteritis. Giant cell arteritis is extremely uncommon. This is the story of a 27-year-old man who found that he had a swelling in the lower abdomen. You can see the large swelling which was gradually enlarging but painless. So he approached a doctor, and the doctor found that it was a pulsatile swelling. So he was referred to a vascular surgeon. They did an angiogram and found there is a large aneurysm and occlusion of the femoral arteries. So he was evaluated by the thoracic surgery department in Calicut Medical College, And they found that the ESR was high, so he was referred for aneurysectomy and grafting. And the ESR was high, so the thoracic surgeon was wondering why this ESR is high, and they did VDRL, XRHS, TCG, and all the preliminary workup, and was sent to me just for an opinion. But when I reviewed the history, he gave history of recurrent aphthous ulcers. He had 2 episodes of uveitis, and he had recurrent genital ulcer. Recurrent genital ulcers. Even this is the genital ulcer he had and the scrotal ulcer. You can see which he was having this when I examined for the first time. But he was very afraid and reluctant to talk about this. So the diagnosis is very clear. It is Behçet syndrome, recurrent oral ulcer, scrotal ulcer, pustule formation, scleritis, and the hypopyon uveitis, the pus in the anterior chamber. So Behçet syndrome is a common problem in Kerala, even though it is said to be a disease of the Silk Route, starting from the Caspian Sea to Turkey, Iran, China, Japan. But if you look at the sea route, that is the land route, this is the sea route, which is touching only Kerala in India. That may be the reason why this vasculitis is not uncommon in our place. Another feature of Behçet syndrome is pathology test, that is development of a pustule or a papule 48 hours after pricking the skin with a sterile hypodermic needle. And this is positive in 60 to 70% cases in the Turkey and Japan, but our patient has got a low incidence. And this is the same patient. After 6 monthly pulse cyclophosphamide, he was better and undergone a aneurysectomy and grafting. The other side also you can see the surgical scar. So when a patient with recurrent oral ulcers and having 2 more criteria like recurrent genital ulcer, eye lesions, skin lesions, or positive pathology test, you can make a diagnosis of Behçet syndrome. This is another patient who had fever, weight loss of 2 months, ESR was high, creatinine was high. He was evaluated for tuberculosis and malignancy. He was detected to have hypertension and was on amlodipine, atenolol, and losartan. And you can see the claw hand and the foot drop, mononeuritis multiplex. The only serology was negative, even the ANCA was negative, urea and creatinine were high, and a surulnar biopsy showed vasculitic neuropathy. So this is polyarteritis nodosa, characterized by necrotizing inflammation of medium and small arteries, affect middle-aged men. Usual symptoms are fever, weight loss, mononeuritis multiplex, skin ulcers or orchitis, hypertension, and renal failure. In the classical pan, ANCA is always negative, and the renal angiogram you may get small aneurysms. This is another type of vasculitis which is quite common in Kerala, but seen by the pediatric colleagues, not by us. It's a medium muscle vasculitis in children, the Kawasaki disease. Patients, children present with fever, mucocutaneous lesions, conjunctivitis, lymph node enlargement, and coronary vasculitis. And they can even develop large coronary aneurysm in a 5 or 6 year old child. Now another case, 48-year-old male with vasculitic purpura, admitted with hemoptysis, also gives history of hematuria with high ESR. XRHS showed non-homogeneous opacities in the both lung fields. Urine showed plenty of RBCs and RBC cast. Serum creatinine was high. His P-ANCA was found to be positive, and the renal biopsy showed crescentic glomerulonephritis without any immune complex deposition. So it's a post-immune glomerulonephritis with P-ANCA positivity. So this is microscopic polyangiitis. This is another patient I came across recently, 23-year-old female. She had a childbirth 6 months back and lactating. She came to the pulmonologist with dyspnea and cough and was treated as bronchial asthma. She was on Montelukast and inhaled bronchodilators. She presented with fever, polyarthralgia, and skin lesions on both lower limbs. These are the skin rashes with which she presented. And most of her investigations were normal, except that she had a very high count, 19,800, with 31% eosinophils. And the peripheral smear showed marked eosinophilia. Absolute eosinophil count was 12,050. So patient has got vasculitis skin rashes. She presented with arthritis of the ankles, bronchial asthma, and hypereosinophilia. This is called Chextros syndrome, now renamed as eosinophilic granulomatosis with polyangiitis. Her P-ANCA was positive, ANA was negative. This is her skin biopsy report from the pathologist, necrotizing vasculitis affecting small and medium muscles with eosinophilic granuloma. This is known to most of you, one of the common vasculitis, Hynexolin purpura, now known as IgA vasculitis. This is the story of a 41-year-old male who presented with a recurrent sinusitis. He had a functional endoscopic sinus surgery and turbinectomy from UAE, and he presented to us with headache of 1 month duration, swelling and redness of the left eye. Initially he went to the ENT surgeon, then seen by other specialists. There is no renal or lung complaint, no arthritis. The problem was he has significant scleritis and optic atrophy of the left eye, and the ENT surgeon said there is septal perforation, blackish crust on both the nasal cavities. ESR was high, and he was, even though he was asymptomatic, we took a chest X-ray, and to our surprise we saw multiple cavitating nodule. This is the CT of the same patient, multiple cavitating nodule with the sinus collections, and the C-ANCA was positive, and this is the nasal endoscopic biopsy of the same patient, non-caseating granuloma with necrotizing vasculitis. So whenever you see a patient with granulomatous inflammation of the upper and lower respiratory tract associated with necrotizing vasculitis or glomerulonephritis, it is most likely Wegener syndrome. Now another common vasculitis is hypersensitivity vasculitis, where the patient presents with recurrent cutaneous vasculitic lesions, no involvement of the other systems. Skin biopsy showed infiltration of the vessel wall with the neutrophil which become fragmented as they follow the vessel wall. This is called leukocytoclasis. That's a pathological diagnosis. Often we call it as hypersensitivity vasculitis. Rarely we may come across with hypoglomerulemic vasculitis, which is a small vessel vasculitis involving the skin, kidney, and the nerves. It can be associated with HIV infection, myeloma, SLE, and Sjogren's syndrome. This patient had a hepatitis C infection, who presented with circulating cryoglobulin. ANCA was negative. One should also remember that there are a lot of causes for vasculitis which I mentioned initially. Infections, the secondary causes like infections like endocarditis, hepatitis, tuberculosis, syphilis, neoplasms, connective tissue diseases, coagulopathies, and drugs, and many miscellaneous causes. If you look at infection-associated vasculitis, the common viruses that produce this is hepatitis B, hepatitis C, HIV, parvovirus, bacterial like tuberculosis and syphilis, others like fungal and rickettsial. Vasculitis can occur following along with malignancies as a paraneoplastic syndrome, which is usually a small vessel vasculitis in 60%, most common with lymphoma, also occur in hairy cell leukemia, solid tumors, etc. Rheumatoid arthritis can produce vasculitis, but it usually occur in long-standing RA, more than 10 years duration, with severe deforming disease, and some of them can have associated mononeuritis or digital gangrene. Even though it usually affects the medium vessels, sometimes it can produce aortitis. Vasculitis can occur with SLE, and many drugs can also produce vasculitis. These are the common drugs that can cause vasculitis. Now coming to, once you have suspected vasculitis and from the clinical features you think that this is likely to be a large or a medium vessel or a small vessel vasculitis, how will you proceed? You look at the blood counts for eosinophilia or lymphopenia, look for elevated acute phase response, you assess the organ involvement, you have to look at the kidneys, chest, nervous system, and the appropriate investigation should be done. And sometimes you may require biopsies, especially from the skin, which we have done, or gastrointestinal like an angiography, or cardiac involvement by ECG or echo, and sometimes an ENT examination as the vagus, sinus X-ray, CT, or a endoscopic biopsy. And many immunological tests are also available. One of them is ANCA. I will come to that a bit later. And if it is a secondary vasculitis to connective tissue diseases, ANL can be positive. Anticardiolipin antibody, rheumatoid factor, complements, and cryoglobulin. Depends on the situation, we have to look. Anti-neutroplastics antibodies to cytoplasmic constituent of granulocyte is the ANCA, anti-neutrophil cytoplasmic antibody, which are two types: cytoplasmic ANCA, otherwise called C-ANCA, and the perinuclear ANCA, or the P-ANCA. C-ANCA is against the proteinase 3, so it is anti-proteinase 3, so it is also called PR3 ANCA, very classically positive in active Wegener's granulomatosis, and P-ANCA in myeloproliferative diseases. That is against myeloperoxidase enzyme, so it is called anti-MPO ANCA. So the C-ANCA will be positive in 80 to 90% of Wegener's granulomatosis and 60% of limited Wegener's, and the P-ANCA is non-specific: microscopic polyangiitis, Church-Strauss syndrome, renal limited vasculitis, and even in Wegener's you can get P-ANCA positivity. Now, the rheumatoid factor in low titer can be positive in connective tissue disease and infection, high titer in rheumatoid arthritis, but when you get a very high titer of rheumatoid arthritis, think about cryoglobulinic vasculitis. Complements are usually normal in primary systemic vasculitis, but in secondary vasculitis like SLE, rheumatoid vasculitis, it can be low, especially C3 and C4. HLA studies are not needed actually. If you have a doubt, you can do HLA-B5-1, which will be positive in most of the cases of Behçet syndrome. One should not forget about the important mimics of vasculitis. Due to the lack of time, I am not going to that. Just one or two slides about the management. In large vessel vasculitis, we usually give corticosteroid with methotrexate. The other options are azathioprine or mycophenolate. Corticosteroid and methotrexate are usually needed. In medium vessel like PAN, steroids and cyclophosphamide pulse. In Kawasaki disease, we use a very different regime, IVIG and infliximab. These are the drugs effective. And in ANCA-associated vasculitis, apart from corticosteroid, rituximab is used upfront because it is superior in efficacy and much less side effect than the earlier used cyclophosphamide, and plasmapheresis and IVIG in resistant cases. I think I can stop here with the take-home messages. A high index of suspicion is highly essential to diagnose vasculitis early. Primary systemic vasculitis is increasingly diagnosed in our country. Secondary vasculitis is much more common than primary systemic vasculitis. Beware of the mimics of vasculitis, and prognosis is favorable if the treatment starts early. Thank you very much.
Thank you, sir. Thank you for the extensive and comprehensive presentation on this difficult topic. The highlights of the presentations were, first of all, as the practicing clinicians, we had to suspect vasculitis. Then only we will look into it, especially when a patient presents with multi-organ involvement, especially as he mentioned, skin manifestations, especially palpable purpura, and joint manifestations, and also lung involvement. We had to suspect and we had to properly evaluate the patient. And also we should not forget regarding this vasculitis mimickers also. So this topic is open for discussion. One or two questions.
Thank you, sir, for the. Hello. Yeah, am I audible?
Yeah.
Yeah. Okay. Thank you for the excellent presentation. I would just like to add a point that this out of the large vessel vasculitis that you have mentioned, temporal arteritis also is not very uncommon because we see that not so uncommonly. Many a times the patients comes to the neurologist for headache, and which may be many a times mistaken for either a migraine or a hemicrania continua, and the patient may be treated on those lines. But it often turns out that many of those elderly patients who comes with unilateral severe headache who may or may not have other symptoms like polymyalgia rheumatica or jaw claudication or things like that, and those who have a high ESR and high CRP, even when they do not have a very high ESR, they may have sometimes a very high CRP. And unlike previous criteria, it's really not always necessary that we should have a temporal artery biopsy also to confirm the diagnosis. Even if you do a temporal artery biopsy on one side, it can be negative, and in which case we can do the temporal artery biopsy of the opposite side. So that may come as positive, and the patient symptoms may be on one side, the biopsy test may be on the positive side, on the opposite side. So these patients respond, as sir was telling, excellently to corticosteroids, and it's a very rewarding experience to treat these patients. But the caution is that the steroids may have to be continued for long, because even in small doses, unless otherwise these patients are very prone to develop visual problems.
Yeah, in Calicut Medical College there was a thesis study by one of the students, and we found that the ratio between aorta arteritis to temporal arteritis was 30:1. Compared to aorta arteritis, it is much uncommon. And whenever there is a problem like headache associated with dimness of vision, we have to start treatment fast, otherwise they will lose the vision. We don't have any time to look for the temporal artery biopsy, which may be or may not be positive. So starting steroids is very crucial to save the sight.
Sir, what about this tuberculosis producing vasculitis, TB vasculitis, because TB is very common in our place?
Yeah,
what is your experience?
Even though it is said in the textbooks that tuberculosis is well known to produce vasculitis, it's often difficult to prove. Suppose a patient is having a blood vessel involvement, we have to take, if suppose a patient is coming with a stroke-like presentation, and it may be due to an arthritis, due to tuberculosis itself. It's very difficult to prove. So many a time, even though we say tuberculosis can also produce vasculitis, it's relatively uncommon in my clinical practice.
If there is no more questions, we can wind the session. Thank you, sir, and thank you, the Pushberry team, for.
Okay, thank you.
Truly, the eyes won't see what the brain doesn't know. Thank you, sir, for the wonderful depiction of such a complex topic in such a simple and easy way. I humbly request our chair people, Dr. B. Padmakumar sir and Dr. Jayashree ma'am, to please offer Dr. Binoy Paul a small token as a gesture of our love and gratitude for his wonderful talk. I also request Dr. Shashi Kumar, Senior Consultant Physician at Mavelikara, to please gift our chair people certificates and mementos of appreciation. Thank you, sir. Many a times we have wondered what anti-epileptics are optimum and what has to be used in certain clinical situations. Going forward to the next session, we have Dr. James Jose, Professor and HOD at the Department of Neurology, GMC Calicut, to help us in making rational decisions in epilepsy management. This topic is chaired by Dr. Sangamitra Dilip, Professor and HOD at Mount Zion Medical College, Adur, who was the former Professor and HOD of General Medicine at Kottayam Medical College, and Dr. Jose Matthew, Senior Consultant Physician at Kanyarapalli. I request our chair people to please come on stage and to introduce the guest as well.
Good afternoon. Myself, Dr. P. Sangamitra and Dr. Jose Matthew express our sincere gratitude in honoring us to chair this session. And decision making in epilepsy management is sometimes very challenging, especially when we treat the first episode of seizure. Again, is it a true seizure or a pseudo seizure? And treatment of epilepsy or seizure disorder in pregnancy and the issuing of driving license, etc. Sometimes it becomes most challenging one. To deliver this and give insight into this decision-making capacity, we have Dr. James Jose. He's a head of the Department of Neurology, Government Medical College, Calicut. To introduce the speaker, I hand over the mic to my co-chairperson, Dr. Jose.
Many thanks to Dr. Sunil for asking me to co-chair this session. To introduce Dr. James Jose, he is Professor and HOD of Neurology, Government Medical College, Kozhikode. He had his MD from Medical College, Kottayam, and DM from Government Medical College, Trivandrum. He has got many publications, of which 11 international and 60 national orations and presentations in CME. 2 books to his credit, Cognitive Neurological Examination and Spinomotor Localization. He has got so many other qualifications to his credential. Over to you, Professor James.
Respected chairpersons, teachers, colleagues, and students. I thank Kader. I call him Kader because he is my friend Sunil and the organizing team for giving me an opportunity to address you. In fact, I feel more homely when I come to Kottayam, Tiruvalla, etc. Even though I am working in Calicut for the last 30 years. More familiar faces are at Central Travancore. So once again, I thank this team to have acquaintance. Tommy, physician, my own classmate, is there. We have a very good type this time. Reggie is there, so I can meet all of them. Now, you know that the neurological treatment, especially that of epilepsy, physicians are shying out from its treatment. After the acute management, they are referring it to a specialist or a epileptologist because they hesitate to take up neurology cases and epilepsy. But the most important thing is the treatment of epilepsy is a long-lasting treatment, and after the consultation, because they are the advice givers. That is why I was very happy when Sunil suggested this topic. I will concentrating not mainly on differential diagnosis and all. I will concentrate myself on the drugs which are used. Now, the question comes, why should you treat epilepsy?
Why should treatment be started? It's a big question, because unlike many other diseases which you have already heard in the previous sections, this is a problem which is occurring once in a while. So many patients are hesitant to start treatment. Why should start treatment? Because it's once in a while phenomenon for which I have to take potentially harmful drug for so many years. So naturally this question will come to the physician's mind also. Why should we treat epilepsy? Should remember that seizure involves restrictions on everyday activities, and it restricts carrier choices. The mortality is 3 times in epilepsy, and sudden unexpected deaths are very common with the epileptic patients. So you have to treat it. The treatment increases the life expectancy and improves the quality of life. So many restrictions are there in getting driving license, workplace, and for epilepsy patients. And if they are asymptomatic, this is all dissolved. Then comes, when should treatment be started? Patient has a seizure, when should start treatment? For that you have to remember the risk. A risk of recurrence of a first seizure is about 46%. And after a second seizure, it is more than 70%. So, should treatment be started after first seizure? Answer is probably no. Exceptions are there. You see that an epileptome EEG is there, structural CNS abnormalities are there, epilepsy with a high recurrence rate is there. You may have to change your mind. And again, severity of the seizure, even if it is a first seizure, if the seizure is a prolonged one, timing. For example, it's sometimes the seizure occurs at fixed time, in the working hours, you may have to consider starting. And individual vulnerability. For example, the person is a coconut climber, or if a person is working with machines, they are highly prone for damage. So they may also have to be considered for starting treatment. Should treatment be started after second seizure? The answer is yes, provided if the seizure severity is not of significance. You may sometimes get a minor seizure, for example, a twitching of the face or a jerk. You may not start. If the interval is more than 1 or 2 years, suppose a patient has got 3 seizures in a span of 10 years, you may think that it is better to leave him without a treatment. And if the informed patient do not so wish, that's what important criteria. Some patients choose that they want to prefer, they leave with the second seizure. They are ready to take the risk of a second seizure. In such cases, you need not compel them to start treatment, because there is a place for the patient's choice. Now, when you start treatment, you know that many of the disease, when there are plenty of drugs, when the things are not getting controlled, the tendency is for using multiple treatment. You have heard in hypertension, antibiotics and all, you use multiple drugs. But in the principle of treatment of epilepsy is monotherapy. Monotherapy. If a drug is not effective, you go for the alternative monotherapy. If they fail, then you consider polytherapy. If the polytherapy is failing, you consider alternate therapy. Alternate therapy. That is the principle of management of. So remember that combination treatment is not usually indicated in epilepsy. Now, which anti-epileptic should be chosen for initial management? As you go to a breakfast in the hotel, you have a lot of confusion which should be chosen. So if you see that a lot of development of anti-epileptic from up to 50, we will have only phenobarbital and phenytoin. Then comes carbamazepine, valproic acid, primidone, ethosuximide, benzodiazepine. And From 86 onwards to 2000, we had several newer drugs like levetiracetam, lamotrigine, oxcarbazepine, topiramate, vigabactin, sonisamide. So many drugs have come. And from 2001 to 2015, lacosamide, perambanil, rufinamide, tripendol, and all are recent one. And in 15 to 21, brivaracetam, cannabidiol, and fenfluramine. Fenfluramine is not an old drug. It was actually a drug which was used for obesity, which was now introduced for treatment of epilepsy. So you know that the development of anti-epileptics. If you see the drugs up to 85, they are called first line management. From 86 till 2001 or whatever is going to happen is considered as new generation, newer anti-epileptic drugs. So there is a big divide between the old one and big one. Why should these medicines are developed, newer anti-epileptics were developed? Because they increase the spectrum, they increase the efficiency, they decrease the side effects and less drug interactions and less teratogenicity. These are all the problems with the old anti-epileptic drugs, and a trial and an attempt was made to decrease the problems with the older one with the introduction of so many drugs. You know, if you see this graph, this is from a European pregnancy register. You can see that after the introduction of the newer drug, how the prevalence of major congenital malformations has decreased in women. From 6%, it has come to 4.4%. This change in tetragenicity is mainly because of the introduction of newer anti-epileptic drug. But you should remember one thing. While modern anti-epileptics have novel anti-seizure mechanism, their increasing use did not seem to have improved overall long-term seizure control. The modern anti-epileptic drugs still lack the capacity of rectify the underlying neuropathological process and reverse epileptogenesis. That is a problem. Even with this much drugs, the process of epileptogenesis is not reversed. In a way, you can say that they are all symptomatic treatment, not curative treatment. Now, when you decide to start treatment, how to individualize drug selection? That is another problem which you face. Which drug you should start? Several factors influence the disease selection. The first and foremost is the seizure type. Know that seizure, if you take 80% of seizures are focal onset seizures. They may be remaining as focal, or they may progress to focal becoming generalized. The other one is generalized seizure. 20% is generalized seizure. For focal seizure, these are the drugs. You know that most of the old generation or the older drugs are effective for focal one, except lacosamide, which is a newer introduction. They are useful in focal seizure. Whereas, if you take the newer generation, most of the drugs are broad spectrum. That is, they are useful in both focal seizure as well as generalized seizure. The advantage is, if you have difficulty in differentiating whether it's a focal or generalized by EEG or other means, the broad spectrum can be used by anybody. Of the drug, valproate is an old drug which comes under broad spectrum. The second consideration is gender. This should be a major consideration, which we won't consider. This should be a major consideration for starting an anti-epileptic drug when a patient is developing seizure. See, you know that so many problems with the new anti-epileptic drugs, it reduces the intrauterine growth restriction. So topiramate is the classical one. If you start it in a lady pregnant, it will be a retarded child, growth retardation. Neurodevelopmental disorder. Apart from the congenital anomalies which they produce, valproate produces a lot of cognitive impairment as well as autistic spectrum disorder in the child. So when you start it, you should not start with valproate. See, finally comes the teratogenic risk. This is very important because our patients, if you start him some of the drugs which are teratogenic, the follow-up will be like that. We don't know when the patient is going to marry, when the patient is going to become pregnant. They will come to you when she was referred by a gynecologist to have a checkup. Then you see that the patient is on sodium valproate. That is a risk. So always consider the risk. See, if you see this chart, the newer anti-epileptic drugs are relatively safe. You see the older ones have got a higher risk with the maximum risk for sodium valproate. 6 to 25% risk of congenital malformations are there. The newer drug like levetiracetam, lamotrigine are having only minimal risk. The third consideration would be comorbidities you may have to take. For example, these carbamazepine, lamotrigine and valproate are mood stabilizer. You know that many patients are having mood disorder. You may have to select some of them. Then migraine and obese patient, you may have to use topiramate, which are useful for migraine and obesity. And anxiety, if a patient is having severe anxiety disorder, pregabalin may become a choice. Another one is depression. You know that everybody uses levetiracetam. Its neurocognitive impairment is very severe. It's actually contraindicated in patients with depression. You should remember that at least 20% of people in the society have a depressive component in their life. See, cognitive, topiramate, if you give it to a school child, a school-going person, there will be a lot of problem with the topiramate because it will decrease their school performance. And co-medications like warfarin, you know, OCP, enzyme-inducing drugs, you should avoid as much possible as possible. Then comes the factor of age. Sometimes you know that carbamazepine is a commonly used drug. Its efficiency in old age is not that much good. Epileptic syndrome, there are certain syndromes like tuberous sclerosis and all things resistant to many drugs, but drugs like vigabactin is very useful. And of course, don't remember the fact of cost of medicine. You have to look at the pocket of the patient and then start deciding. So many factors has to be taken to decide. There is nothing like a first drug, second line drug or third line like what you do in hypertension. There is nothing. You have to take each patient and decide which is the best type of drug which I have to select. That is the thing, most important one which you have to. So what is the dose? The dose is initially titrate to the lowest maintenance dose that is expected to be effective. There is no standard dose. There is a concept. Subsequently titrate to the maximum dose. Initially you should not go for the maximum dose because drugs are effective at a lower dose. For example, if you take carbamazepine, see 400 is effective. You can go up to 1600 milligram. Actually, you should not go to that level for the first time. For each drug, there is a average dose which is usually effective. And if you maintain them, and if they are not effective, go for the next drug. Dose titration, it should be a gradual dose titration. It improves the CNS tolerability, reduce the risk of idiosyncratic reaction. This is one thing which I want to stress. If you start an antiepileptic A or B or C, start at a lower dose and go very slowly. Tolerability is the most important thing. I usually see that levetiracetam, when people are starting, they start with 1000 milligram daily. Initially, 90% of the patients won't tolerate that. So always start first aim is not effect, first aim is tolerability. Because epilepsy is a chronic process which may recur only after 1 or 2 months. So there is no hurry in reaching the target one. You go very slowly. Same way, many of them cause severe reactions. Reactions can be reduced to a large extent if you they titrate very slowly. So never be in a hurry. There are certain situations where there may be rapid institutional therapy when there is emergencies or recurrent one. Then use drugs, injectable drugs like levetiracetam, valproate, phenytoin and lacosamide, which can be, as you know, that you can be given injectable and reach a high dose when you want. In all other scenarios, you go for very slowly. Should serum concentration be measured? Usually you think that it is no. Modern use of drug monitoring underemphasize the value of reference range because control can be obtained with less therapeutic serum concentration. Similarly, sometimes even with adequate one you may not get a response. So what you have to, the modern suggestion is identify the serum concentration associated with the best response in a given individual and use it as a reference to adjust dose when a pharmacokinetic change is expected. For example, a lady is becoming pregnant, so you want to know whether it has to be increased. So you should have a basic serum level and keep it, change the drug accordingly rather than just going for the this one. Now regarding the discontinuation of treatment, the consensus is when should the treatment be stopped. It's thought that a minimum of 2 years seizure free is required. If you wait it for 4 years, it is better. What should be the duration of tapering? That is the important thing. You should not taper rapidly. It should be a very, very gradual process taking 6 to 9 months. Favorable factor for these are there: rapid freedom from seizure, normal neurological status, normal EEG after MRI, epilepsy with a good prognosis, onset in childhood, they are all good factor. Risk of recurrence are there, so many risk factors are there. If it is favorable, you can stop at 2 years. If not favorable, you may have to continue for a longer time. Now you will see what is called a pharmacoresistant epilepsy. Failure of 2 anti-epileptic drugs, whether as monotherapy or in combination to achieve sustained seizure free, is considered as resistance epilepsy. See why there should be resistance. You know that so many mechanisms are shown here. Whatever is shown as the first one. See, you see that this is a receptor which rapidly make the drug out of the neurons. So drug concentration won't reach in neurons. Here is another site. You see that this is the receptor site where our drugs are acting, but it is mutant, so the drugs are not effective. Here you see that there are this is a tight junction where none of our anti-epileptics are effective. So this may be the mechanism of epileptogenesis. You see the other one. This is where there is a auto-antibody at the receptor site. So our anti-epileptics are effective. So many mechanisms are there for resistance. So when you go for a pseudo-resistance, always remember that it could be a wrong diagnosis, or what you are using is a wrong drug. For example, wrong diagnosis means pseudo-seizure may be treated as seizure. Wrong drug may be selected. Wrong dose may be selected. Poor compliance. This is the most important thing. Patient forget to take the drug, but you think that it is resistant. And lifestyle issues, alcohols, sleep deprivation and all produce resistance. So when there is a resistance, you see you go for polytherapy. Which drug you what is the choice of drug for polytherapy? How will you select? When you choose another drug as a combination, consider 2 factors: mechanism of action of individual anti-epileptic drugs. Second is interaction between anti-epileptic. These are the 2 considerations which you have to take when you select a second drug in combination with the first. For example, if you see the mechanism of action, you see that these drugs act at the sodium channel blockers are there. Then you see that calcium channel blockers are there. GABAergic drugs, SV2A receptor like levetiracetam. Then potassium channel receptors agonists are there, AMPA receptor, so many different mechanisms of action. So when you select a drug, select 2 drugs which has got different mechanism of action rather than same mechanism. For example, there is no point in combining carbamazepine with phenytoin. So if you use carbamazepine, you use another drug, say example clobazam, you use clobazam. So 2 mechanisms. So this is the first consideration when you take a drug. So this is the site where the levetiracetam is acting, and then the pharmacokinetic interactions and pharmacodynamic interactions. For example, there are certain enzyme inducers, enzyme inhibitors are there. When you use 2 inducing drugs, enzyme inducers, they compete each other to decrease the effect. Same way pharmacodynamic interactions are there. Some drugs are synergistic. For example, if you use sodium valproate and lamotrigine, they have got a synergism. Same way carbamazepine and clobazam, there is a synergism. So use some drugs which are synergistic. Avoid antagonistic drug. For example, 2 drugs which has got the same mechanism of action, they are antagonistic. So these sort of considerations should be there when you select the second drug. Now you have monotherapy, alternative monotherapy, and polytherapy. They are all failing. So you remember that there is a proportion of epileptic patients who are very resistant to treatment, Adding drugs one after another won't improve their outcome. With a first drug, you will have a certain proportion of patients getting a response. If you add a second drug, another proportion, say about 10% of patients will get a response. A third drug, probably a 5% response. If you add a fourth drug, practically it won't produce much effect. So after 3 drugs, you should be careful. You should verify whether it is a true resistance at all. Because many times what happens is you just imagine your condition. How many of us can take our drug regularly every day? The answer is very difficult. So assure that a patient is have adequate compliance. The one problem is there with the anti-epileptic drug. The problem is your brain will register as the day's medication which was taken on the previous day. You will get confused whether it is on the previous day or on the same day. That is the problem with anti-epileptic drug. To avoid that, we should all insist that there is a drug tray. The morning, from the 1st to 10th, 10th to 11th to 20th, 20th to 31st. Patient has to keep his drugs separately in a tray and verify by the patient and bystanders, see whether they are taking it regularly. So after, and you have to exclude pseudo seizure, whether it's a true resistance. You can have mobile phone with you, with everybody. They can register the events in the mobile phone and show to the physicians when they are coming, and take all the steps before you labeling him as drug resistant epilepsy. And if you are convinced that it is drug resistant epilepsy, you go for the alternative therapy, which include ketogenic diet and epilepsy treatment, epilepsy surgery, which in the appropriate case may give a benefit. And you should remember that compromise. When seizure freedom cannot be achieved, the ultimate goal is the best possible quality of life. That's what you have to remember, best quality of life. Drugs cause a lot of side effects. Epilepsy causes problems in their life. You should have a compromise between what is the best quality. 2 drugs with once in a while a seizure, is it better than a seizure free with 4 drugs? You have to decide. And it is suggested that the best possible quality of life is aimed to be obtained through a compromise between reduction in seizure frequency or severity and the burden of the side effect. Thank you.
Thank you, Dr. James. We had an in-depth discussion on the various aspects of epilepsy management. And if you have got any queries or comments, I'll start with a question, sir. Once you have decided to stop the drug treatment for epilepsy, and if there is a recurrence, how will you manage it? With the same drug or with a separate group of drug?
No. If the drug which we are using was giving an adequate control, then you can use the same drug. If a person is on carbamazepine, he has a very good control during the recurrence. When you start treatment, start with the same drug. There is no role for changing a drug.
Then can you then think that the initial treatment was not for proper duration?
No, I told that the medicines are all symptomatic treatment.
Yes.
is not changing the basic epileptogenic mechanism. So even if you treat an epilepsy, you should remember that the epileptic mechanism is not altered by our drug. Epileptic mechanism is there. That is the reason for a recurrence. That doesn't mean that the same drug is not going to be effective.
Sir, if a patient lady is on sodium valproate, she becomes pregnant, will you change that drug or to another one? Or
See, madam, that's a very difficult question to answer, because you know that once the patient came to know that she is pregnant, it takes about 4 weeks, isn't it? Minimum 4 weeks, another appointment and all take another few weeks. In short, what happens is by the time a lady is coming to you saying that I am pregnant and I am sodium valproate, it's already late to change the drug. The harm has already happened. So the recommendation is, if a patient is on sodium valproate and become pregnant, there is no recommendation for changing it. The recommendation is that you can continue the same drug and if possible reduce the dose. There are criteria. If the patient is symptom free for a sufficient time, reduce the dose. And the risk of developing a uncontrolled seizure is high if you change the drug during the pregnancy. That is why I emphasize that when you select a drug, you consider this factor.
Okay. So will anomaly scan at 20 weeks will helpful for that patient?
Definitely. You know that if a patient is on an anti-epileptic drug, at 16 weeks you have to do the anomaly scan, and at 20 weeks you have to do the anomaly scan and see whether the fetus is in good condition. But you should remember one thing: anomaly scans are not as perfect as what we think. If you ask the radiologist, you know that the difficulty for detecting the cardiac abnormality and all. Gross abnormalities like meningocele, anencephaly and other things are easy. But the cardiac abnormality, cardiac echo, fetal cardiac echo is a very difficult thing.
So another thing is about the driving license, sir. When will you advocate?
Driving license. No, that different countries follows different rules. Most of the Western countries insist that there is a seizure-free period of 2 years. India has not any specific rule. We all adopt, I think there is no rule. We all adopt the Western standard that if the patient is having adequate control for 2 years, we will give driving license. But another factor is there. There is no means by which you can say that a patient is having epilepsy, seizure-free period. If a patient is epileptic and he says that I have no seizure for the last 2 years, you have to believe that, isn't it? But I shall tell you, I don't discourage patient from driving just because of the factor that he is an epileptic. Because if you take these people, see, as far as possible, epilepsy patient, my own view is that restrictions in life is more problematic for the patient than the seizure. That is what I have seen. We are all restrict them. Don't see film, don't use mobile, don't drive, don't go out alone. These sort of restrictions and observations. Parents just open the door and see whether the child has got a seizure when he is sleeping. These sort of restrictions annoy the patient and destroy the patients. Actually, seizure is compatible with a normal life. So most of the patients ask me, can I drive? If the seizure is reasonably controlled, I will say that you can drive. And if accidents are common, if a patient is developing a seizure while driving. That usually happens when patient is not on anti-epileptic. A non-epileptic patient practically never develop an accident because they are so careful. They are so careful in their driving. They know the epilepsy is coming. Some warning will be there. They will be immediately braking the vehicle and all. So the incidence of a traffic accident by the epilepsy is very negligible.
questions from the audience? If there is no more questions, we can wind up the session. Thank you, Dr. James Jones, for the excellent speech and the practical points.
Thank you,
Thank
James,
you,
sir,
madam.
for
Thank
such
you.
a precise and practical talk. I request our chairs, Dr. Sangamitra Dilip and Dr. Jose Matthew, to please offer a memento of appreciation for his wonderful and informative talk. I also request Dr. Raji Thomas, Professor and HOD of Neurology, Pushpagiri Medical College Hospital, to please gift our chairpersons certificates of appreciation.
Now, for the final session of the day and today's conference, it brings me great joy and happiness to be able to introduce our final speaker who will draw the curtain on today's session, Dr. Sajan Ahmed, who is a senior consultant cardiologist at St. Gregorius Mission Hospital, Paramala. He is currently serving as the editor-in-chief of the Kerala Journal of Cardiology. Sajan sir will endeavor to teach us on the rational use of NOACs. To chair this session, we also have another equally dynamic and brilliant clinician, an excellent teacher and a great researcher, and a great personal friend of mine, Dr. Atulya Ashokan, Assistant Professor at Kottayam Medical College. I take great privilege in inviting you on stage, ma'am. I'm sure we can expect great things from this combination.
Good evening, all. I don't think Dr. Sajan needs any introduction. He's a astute clinician, an excellent academician, and a researcher who has various publications in his name. As said, he's a editor of the Journal of Cardiology, and he is doing an excellent work now at Paramala. The topic also is a very interesting topic for us clinicians because it is on the rational use of newer anticoagulants. And with the price control in place, now we are using it rampantly. So let us hear from the expert on the use of newer anticoagulants. Over to you, Dr. Sajan.
Thank you very much. So good evening, everyone. Even though this is the football season, I'm happy to be the last batsman. So, yeah, okay. So, thank you very much, respected chairperson, my dear teachers. Many of my teachers are here, and seniors and friends. Thank you very much to the Pushpagiri team, especially Sunil sir, Ajish, Kader sir, and everyone, Tommy sir, because coming to a Pushpagiri CME is like Spider-Man's homecoming, because I've been here with all of you for so many years. So thank you so much. So let's go to the topic. This is on NOAC, the novel oral anticoagulation, or DOAC, direct acting oral anticoagulant, whichever way you would like to call it, and how can we use this molecule rationally. Voltaire said that a man can be judged by his questions rather than his answers. So probably a drug too can be judged by the questions that it poses to us. So let us look at some of the questions regarding NOACs. What exactly are they? Why are they required? When can we use them? And if we decide to use, which one to choose, how to prescribe, and most importantly, when not to use these molecules. So the WHO says that rational drug use is the right drug at the right dose, by the right route, at the right time, for the right patient. So let's come to what are NOACs. We know that thrombosis or coagulation is at the core of many of the pathophysiological processes that we encounter in clinical practice. And we have had many molecules which act at different levels in the coagulation pathway. The classical one being warfarin, which acts against factors 2, 7, 9, and 10. It is actually the Wisconsin Alumni Research Foundation Kumaran which has been called as warfarin. And in 2000, we came to know that VK has reduced stroke in atrial fibrillation by 2/3, and it scored over aspirin. Over the course of time, the thrombin inhibitors came. Dabigatran was found to be at least as effective, and then came rivaroxaban and apixaban, which were found to be equally effective. And finally, we are now in a decade where we know that NOACs could be safer and even slightly more effective compared to VKA in ideal patients. So we have two major groups of NOACs. One is the direct thrombin inhibitor, which is dabigatran, and we have factor 10 inhibitors, that is apixaban, rivaroxaban, and edoxaban, of which the first two are available in India. So dabigatran, we know, I'll just go over the basics, especially for the postgraduates, which is an oral direct thrombin inhibitor. The doses, standard ones, are 150 milligram BID and 110 milligram BID. 110 milligram is used especially if there is increased risk of GI bleed, concomitant use of verapamil, and if the age is above 75. There is also a 75 mg BID dose which is available in India. And the major trial was the RELY trial, where it was found that if we use 110 milligram BID compared to warfarin, the thromboembolism was similar to warfarin, but with a lesser rate of major hemorrhage. That was the advantage. But if we use the 150 milligram BID when compared to warfarin, it actually was associated with lower risk of stroke and embolism, but with the same kind of hemorrhage compared to warfarin. So we can choose. The next molecule that came to us was rivaroxaban, which is an oral factor 10A inhibitor and is currently the only OD dosage NOAC which is available now. And the problem and the advantage is that there are so many drug doses which are available, so we need to be aware which dose to be used in which patient. So we have 20 milligram tablet, 15 milligram tablet, 10 milligram tablet, and 2.5 milligram tablets which are available. And the standard dose for stroke prevention in atrial fibrillation is 20 milligram once daily. We'll come to the details. And the ROCKET AF trial was the major trial which showed that there was no difference compared to warfarin, and the intracranial and fatal bleeding was in fact less compared to warfarin. The third one, probably becoming more popular now, is apixaban, which is again a factor 10A inhibitor. The standard dose is 5 milligram twice daily, and the dosage, lower dosage of 2.5 milligram twice daily should be chosen if 2 out of the 3 following criteria are satisfied. One is age above 80 years, second is weight less than 60 years, and third is creatinine more than 1.5 milligram %, because these are the patients who are at higher risk of bleeding. Or if the creatinine clearance is less than 30, again standard dose should be 2.5 milligram twice daily. So the next question is, why is there a need for NOACs when we had one of the greatest drugs of all time which we were using so long? And why change to NOAC? Because we now know that old may not always be gold. I'm planning to watch this weekend if possible. So there are two major issues with vitamin K antagonists that we know. One is that the INR to be in the target range, it's very erratic. Each time the patient comes to the OP, it is either too low or too high. Then we ask them to decrease dose, come back again. So it adds a lot of discomfort to the patient. The second is the time in the therapeutic range. That is the percentage of time during which the INR is in the target range. That is also dismally low in many of our patients. And another practical issue is that when we start these drugs, we know that it takes around 3 to 4 days for the action of VK to really start. So we might need to bridge them with parenteral drugs. But that advantage is there for the NOACs, because the onset of action is very fast and starts acting in 2 to 4 hours time. The next is when to use. You don't have to take the photos. I'll give the presentation for the PGs. So the next is the major indications. Which are the major indications for the NOACs? One is the standard indications. There are 2 major indications. One is for atrial fibrillation to prevent thromboembolism and stroke. The second is in the setting of venous thromboembolism, which includes both pulmonary embolism and deep vein thrombosis. So both for prophylaxis and for treatment, we can use NOACs. Now there is a new indication in that in certain subsets of coronary artery disease patients and in patients with peripheral arterial disease and claudication, we can use it. And there are also evolving indications like preventing stroke in patients with left ventricular clot, use in chronic thromboembolic pulmonary arterial hypertension, and the controversial use in antiphospholipid antibody syndrome. Of course, most of us here would have used this drug right, left and center in many of our patients with COVID in the recent 1 or 2 years, because the clot is part of the plot in COVID. Now, in practice, when do we choose NOAC? When we have a patient who satisfies the indication, when we think that the patient can afford it, it offers the convenience of taking the tablet and avoids the difficulty in monitoring, we choose NOAC. This is data from our own state. The data collection was in 2016-17, almost 5 years back. We were also a part of this registry, Venugopal sir and myself. So that time, the NOAC usage in AF patients in Kerala was only around 5 to 10%. So now it has significantly gone up over the last 5 to 6 years. Now, just like new products in the market with more choices, lesser drug cost, it has become more accessible, because now with less than 1,000 rupees per day, we can treat a patient with AF with NOACs. So NOACs are now trending, and it is being used by people belonging to all specialities, and all the guidelines recommend that when anticoagulation is required for atrial fibrillation, a NOAC, either of these NOACs, is preferred over and above a vitamin K antagonist. So previously it was you may use if possible. Now it is preferred over vitamin K antagonist if there is no contraindication. But remember that it is applicable to non-valvular AF, which means that AF occurs in the absence of mechanical prosthetic heart valve and in the absence of significant mitral stenosis, which is usually rheumatic in most parts of the world. So somebody with a mechanical prosthetic valve, don't use. Somebody with mitral stenosis, rheumatic, don't use. All other patients we may use. It is okay to use it, and it is good to use it in AF in the setting of MR, AS, AR. We can still use it. If we use a bioprosthetic valve, the surgeon uses a bioprosthetic valve or does a valve repair surgery, again, NOAC can be used after the initial 3 to 6 months. But for the initial 3 to 6 months after any valve surgery, we still have to use the vitamin K antagonist. What about hypertrophic cardiomyopathy with atrial fibrillation? It's a common combination. Again, we can use NOACs. In venous thromboembolism, both DVT and pulmonary embolism, now the guidelines, 2020 guidelines recommend that DOACs are preferred over vitamin K antagonists. So here we come to the different doses apart from the AF doses. If you look at the last point, that is rivaroxaban, if somebody has an acute DVT or pulmonary embolism, we want to start oral treatment instead of the usual injection heparin or enoxaparin followed by NOACs or VK. We can directly start with rivaroxaban 15 milligram twice daily for the first 3 weeks, and then continue with 20 milligram once daily. That is a standard dose. So there 15 mg BD for 3 weeks followed by the standard 20 mg OD. If you want to use apixaban, the initial dose is again higher, 10 milligram, double dose, 10 milligram twice daily for 1 week followed by the standard 5 milligram BID. Dabigatran, but dabigatran, there is no data for starting it directly. We have to give initial at least 1 week of parenteral anticoagulation and then change to the standard dose of dabigatran. For long-term prophylaxis, a lower dose is used, that is 2.5 mg BD of apixaban and 10 milligram OD of rivaroxaban. In surgical practice or orthopedic practice, when we have somebody undergoing major orthopedic surgery and we want to prevent thromboembolism, again a lower dose is preferred, that is apixaban 2.5 mg BD or rivaroxaban 10 milligram OD. So the first two ones are preferred, the half dose. If somebody has AF, somebody has AF along with coronary artery disease, stenting, all these problems are there. So that patient requires antiplatelet also along with anticoagulation. There the problem is the bleeding risk is more. So we have to minimize the duration of triple therapy, and if at all we are using antiplatelet, as far as possible use a single antiplatelet along with NOAC, and this antiplatelet clopidogrel is preferred over the more stronger antiplatelets like ticagrelor and prasugrel. Somebody is we are stenting for the first 1 to 3 months, we may use triple therapy, but after that we have to change to double therapy. Now, the new indication is in certain subsets of high-risk coronary artery disease or chronic coronary syndrome, and in patients with symptomatic peripheral arterial disease, there is something called the vascular dose of rivaroxaban, which is used not in patients with AF. This is in sinus rhythm. If somebody with symptomatic PAD with AF, again, this doesn't have any role. So here it is rivaroxaban 2.5 milligram twice daily along with a single antiplatelet, which is usually aspirin 75 milligram, which was used in the trial. We can also use clopidogrel. This is based on the COMPASS trial. Now, previously in cancer patients who require thromboprophylaxis, the drug of choice was low molecular heparin. Now this has also changed. The latest guidelines recommend that NOACs are preferred because these patients, it is easy to administer them and ensure compliance. And we have to remember that when we use these drugs for thromboprophylaxis in cancer patients, especially in GI cancers, gastric cancers, and in luminal GI cancers. We should avoid rivaroxaban because it is associated with higher incidence of GI bleed. So prefer other molecules. Now coming to how to use, what the guidelines say and what we can do practically. One important thing is when we prescribe rivaroxaban, we should remember that it should be taken always along with food. Warfarin, we used to tell don't take food along with that. Rivaroxaban, the bioavailability is only 66% when it is taken without food on an empty stomach. But it dramatically increases to 100% bioavailability when it is taken along with food. So the guideline recommends that mandatorily rivaroxaban should be taken along with the major meal of the day, which probably could be lunch in our part of the state. And on each follow-up visit, whichever drug we use, we have to reconfirm the indication and the contraindication. Ask actively whether there are any bleeding manifestations. Don't ignore even minor bleeds, because minor bleeds could be harbingers of major bleeds in future. Monitor hemoglobin for occult GI blood loss, and always check renal function, because the creatinine clearance will change over the course of patient may be on your follow-up for the last 2 years, 3 years. Now the creatinine clearance may be changing. Now what about chronic kidney disease? In patients with CKD, can we use NOACs? All NOACs are contraindicated if the creatinine clearance is less than 15. So if it is less than 15, don't use, standard. If the creatinine clearance is 15 to 50, we can use rivaroxaban at a lower dose, that is 15 milligram. If the creatinine clearance is less than 30, we can use apixaban 2.5 milligram twice daily. The important thing is dabigatran is a drug which has got the maximal renal excretion, and ideally it should be avoided as far as possible, and the drug with the least renal excretion should be used in CKD patients, that is apixaban, and mostly the dose used in CKD is 2.5 milligram twice daily. Now recently the US FDA has given a cautious extension of apixaban use to patients who are undergoing hemodialysis, but this has not actively come into mainstream practice. What about chronic liver disease? In child C patients, we should not use NOACs. In child A patients, we can safely use it. In child B, we have to balance the risk and benefits, get the opinion from the gastroenterologist, and also document, because we are practicing in difficult times. What about elderly patients? Should we be concerned in starting it in elderly? Not really, because in the major trials, the mean age of the population itself which was studied was above 70 years. So probably they are, they are safe. And it was found that in the elderly, the introduction of NOACs has increased the prevalence of OAC use, and it has also improved their adherence, because it is difficult for most of our patients to come frequently to the OP and get the blood checked, etc. Very, very important, Batman, we should always assess the fall risk in elderly and frail, because patients on NOACs who are having recurrent falls, we may create more harm than good. What about weight? Patients with extreme body weight, either very low body weight or very high body weight, the bioavailability cannot be ensured, and in these situations, morbid obesity, VKA may score over NOAC. What about thrombocytopenia? Less than 20,000, absolute contraindication. More than 50,000 platelet count, we may use it if there is a strong indication for anticoagulation after discussing the risks and benefits. There are some groups of patients who have LV apical clot after an anterior myocardial infarction. Previously, we used to give heparin in the hospital and then discharge them on warfarin. Now, we have option of starting newer oral anticoagulants. What about after transcatheter aortic valve replacement, which is now coming up? So in these patients also, NOACs can be used. Out of our 4 patients that we did, 1 patient had AF, and we are giving rivaroxaban. Now, somebody is on one drug, wants to switch due to multiple reasons. So how can we switch in clinical practice? So somebody is on VKA and now wants to change to NOAC because of erratic INR. So what we should do is check the baseline INR. If the INR is less than 2, we can straight away start the NOAC. If the INR is between 2 to 2.5, we can tell that you start from tomorrow after skipping today's evening VKA dose. If the INR is between 2.5 to 3, we can start after 2 days. If you find that the INR is more than 3, don't start NOAC right away. Ask the patient to come back after 2 days with a repeat INR and then start. Somebody is on NOAC and then comes and tells that, doctor, I want to stop this, I want to change back to VKA, or I want to change to VKA. So what to do is continue the NOAC and start the VKA along with the NOAC, and check the INR after 3 days, and stop the NOAC once the INR is in range. Now somebody is hospitalized with an AF and he is on unfractionated heparin. You are planning for discharge, you want to change to a NOAC. So how should you do it? Stop the unfractionated heparin, and we can safely start the NOAC 6 hours after the last dose of unfractionated heparin. But if it is a low molecular heparin, we need to wait for at least 12 hours. Somebody is on NOAC who is being admitted to the hospital for inpatient treatment. We want to change to unfractionated heparin. Once you give a NOAC dose, wait for 12 to 24 hours before starting the next drug. Now, somebody is on a drug, NOAC, they are planned for other non-cardiac procedures. So before a surgical strike, what should we do? So we have to assess the bleeding risk that is related to the procedure. For example, is it a minor bleeding risk procedure like a dental extraction or a cataract, endoscopy without biopsy? Or many patients used to phone us during COVID pandemic, IM injection, vaccination. So low risk bleeding is complex dental procedure, endoscopy with biopsy and probably coronary interventions. High risk is of course cardiac, neurosurgery, ERCP, hepatic and renal biopsy, urological procedures and major orthopedic procedures. So we have to assess the risk that is likely to produce bleeding. So if the procedure is a low bleeding risk procedure, patient has normal renal function, simple to remember, just stop it for 1 day. If it is a high risk procedure, stop it for 2 days. If patients has an abnormal renal function, even if it is the procedure is a low risk, wait for 2 days, give 1 extra day. And if it is a high risk patient, abnormal renal function, we have to wait for 3 to 4 days. And when to restart? After a low risk procedure, for example, cataract surgery, 1 day prior stopped, cataract surgery done, after 24 hours we can start. After high risk procedure, it is after 2 to 3 days. And very, very importantly, perioperative bridging with heparin is not recommended when you stop. Now, Rajis is here, but still, what about the neuro connection? You know that I have a very strong neuro connection in my home. So she couldn't come because my son is alone. So when to start oral anticoagulation after stroke? Somebody comes with AF and stroke. And so if it is only a TIA and the imaging does not show any abnormality, it is probably safe to start the NOAC on the next day. But based on the NIHS score, if it is a mild stroke, we have to wait at least 3 days. If it is a moderate stroke, at the end of 1 week. And if it is a severe stroke, we should wait for at least 2 weeks before starting NOAC. And this should be done definitely after doing a repeat imaging to rule out hemorrhagic transformation. Now, how can we try to bring down the bleeding risk? One major bleeding problem is the GI bleeding. So, use of proton pump inhibitors is recommended along with NOAC use, especially if the patient is elderly, is at a high bleeding risk and has got concomitant antiplatelet therapy. So, somebody who is on clopidogrel along with rivaroxaban, definitely it is better to advise a proton pump inhibitor. What about alcohol and NOAC? Very common combination in our state. It is not a good combination apart from the fact that they can climb ladders and fall. Even otherwise it increases the bleeding risk and should be avoided. What about pediatric practice? NOACs have recently been tried in pediatric indications also and it has found to be safe. Now even though hopefully COVID is on its way out, hopefully, maybe because we are not testing, we are not getting it. Anyway, in-hospital prophylaxis for COVID, always LMWH is preferred, but if we are using NOAC, we can use apixaban 2.5 mg BD or rivaroxaban 10 mg OD, that is half dose. And post-discharge thromboprophylaxis, this is Kerala government's guideline. They have also post-discharge, high-risk patients only, not for all COVID patients. Rivaroxaban 10 mg OD was recommended. In this guideline, apixaban 5 mg BD was recommended, but I think 2.5 mg BD is enough for thromboprophylaxis. Now, one important question everybody used to ask us, we have vitamin K for VARF overdose. What do we have for NOAC if somebody bleeds? Thankfully, after so many years of use, we never had to use the antidote. So there are 3 major antidotes. The antidote specific for dabigatran is idarucizumab, which is a monoclonal antibody, and the company claims that they will give it free of cost because it costs approximately 1 lakh. Thankfully, nobody required this. And the advantage is because it is short acting, by the time we arrange the drug, the side effect would have gone or something else would have happened. Okay, anyway, the second drug is andexanet alpha, which is a factor 10A inhibitor antidote. And then we have a universal soldier in siraparantag, which will neutralize all these for the sake of the postgraduates. Just remember the names. And beyond antidotes, what we can do is activated charcoal practically is good when administered within 3 hours for dabigatran and apixaban. And dabigatran, remember that it is dialysable. So if you do early hemodialysis, you can take it out of the system. Now coming to the most important point, when not to use NOACs, because these multiple doses being available, we tend to get confused. So it is seen contra in mechanical prosthetic valve, valvular atrial fibrillation or mitral stenosis, and creatinine clearance less than 15. No confusion. Remember these 3. And NOACs should be avoided in pregnancy and in women planning pregnancy and during lactation because we don't have enough safety data. This is the latest guideline. But now we are having reports of its use in pregnancy and in breastfeeding, and probably in future it might be included. Now, one area of Achilles heel for the NOAC is the APLA syndrome, where still vitamin K antagonists are preferred over NOACs. Also, in chronic thromboembolic pulmonary arterial hypertension also, probably vitamin K antagonists are better, but even though DOACs are still being used. The concomitant use of newer antiplatelet drugs I have already mentioned, ticagrelor and prasugrel to be avoided if at all possible along with NOAC. Finally, to conclude with some perspective, we know that NOACs have the advantage that no monitoring is required, but then when it was introduced, everybody used to ask, is it like a double-blind study? We are giving a drug, we don't know whether it is acting or not, so whether it is really acting. But we know that it is acting, and it also produces abnormalities also. Some patients, even if we start NOAC, they will come as a habit with the INR value, and we'll find that the INR value is high. So all these drugs will affect the PT, APTT, ACT and the thrombin time. It will be elevated, but it will not have any therapeutic correlation. So we should not rely on these things. So what about the cost of health? So is it just that we are using more costlier molecules? This was a problem initially, but right now with less than 1,000 rupees per month, we can treat patients with AF and pulmonary embolism. And we also save the repeated hospital cost and also the cost of testing the INR. And the cost effectiveness ratio was studied and it was found to be cost effective. So to conclude, we have discussed about what are NOACs really, why are they required, which are the conditions where we can use, if we decide to use, which one to choose, how to prescribe and monitor a patient during follow-up, and very importantly, when not to use. Now, which drug to choose? It is very easy to remember the theory, but in the OP, when somebody is coming with AF, they don't want to admit. Usually what happens, AF patient comes, we will tell cardiology consultation or something, or we'll admit and start heparin, and then we'll decide which one to start. But now, sometimes the patient may not be ready for admission. Previously, we had no other option. Now we can safely start oral treatment in the OP after checking echo, ECG, ruling out MS, do a baseline creatinine, hemoglobin, platelet, PTINR, and start the drug immediately. So that's the advantage. So ultra modern machine gun, Malappuram Katti, all options are available. But ultimately, we have to remember that while trying to bring down thrombosis, we should not increase bleeding. So we have to have a Buddhist middle path. And the decision making will always be beyond guidelines. We'll have to decide based on the patient's clinical scenario, what is the treatment plan? Am I treating this patient on OP basis, IP basis, ICU, ward? What are the comorbidities? What is the age? What is the renal function? Baseline HB? What is the bleeding risk? And as doctors, we all have our comfort zones, the kind of molecules that we are familiar with and the guidelines in the CMEs that we attend. And also economics and compliance. Compliance is extremely important. Any drug is only as good as its compliance. And finally, some dark corner of our mind, we should also have the medico-legal angle, because the tough times in which we are practicing. And finally, like I always say, whenever we are faced with a tough clinical decision-making problem, the best thing to do is ask yourself how you would treat yourself or somebody in your family when we have an indication for a NOAC. Then we will understand how difficult it is to choose a drug. You're sitting in an OP and writing prescription, it will come to us immediately at the spinal level. But if you want to start for yourself or your father or your mother or your wife, then you will think thrice before starting a drug. So that we should be remembering. And so guidelines, even though they are extremely useful to guide clinical practice and should be followed as far as possible, especially the postgraduates, but the guidelines should always be interpreted and applied in the context of the individual patient. And as doctors, we should have the humility to accept that what is best practice today may not be the best tomorrow. Maybe 5 years later, Jasher may give another talk and tell that whatever Sajan sir said is wrong, because the guidelines will change. Because I read the last guideline in 2016, this came in 2020. 4 years, everything has changed. So we have to have that humility and understand that when we see prescriptions, don't just blame the doctor who has written prescription. Be kind to each other and not only to our patients. And with that, I conclude, and thank you so much once again. And I'll be happy to take any questions. And I have given the slides. Any postgraduates are interested, you can please take it.
Thank you, Dr. Sajan, for that excellent and detailed presentation.
Thank you.
So the topic is open for discussion. If there are any queries.
Bleeding.
Is it very common to get the bleeding episodes after this or near oral anticoagulant?
Okay, sir. Thank you. A very important question. Bleeding is a real problem. All the trials and clinical practice have shown that the bleeding rate is around 0.8 to 1%. So if you give for 100 patients, 1 patient will bleed. That we have to accept. So the more patients you treat, you are more likely to encounter. But overall, after NOACs have been introduced, the incidence of bleeding has been the kind of patients we see with bleeding has come down compared to warfarin. Because with warfarin, there was always this going down, increasing, all those things. Now this molecule is giving a stable anticoagulation, so bleeding is actually less. But I also accept the fact that as a cardiologist, when I prescribe, I may not be seeing the bleeds in my patients. My patients may go to register with IC bleed. My patient may go to a gastroenterologist and get admitted with a GI bleed. They will go to a urologist with a hematuria, and I will be happily saying that my data is correct, nobody is bleeding. So we have to have an open mind, but right now, if I develop an AF, maybe my chart score is not that high, so I may not have to. Also, for example, my father, God willingly, if I'm just staying for understanding, develops an AF, I will prefer a NOAC over vitamin K antagonist. So that is what I will do for my patient also.
So how do you counsel your patients regarding start of NOAC? Do you tell them like regarding the antidote availability, all those things, because of the medico-legal issues?
The initial period we used to do like that because we didn't have the support from the guidelines that NOACs are preferred over vitamin K antagonist. But right now we don't have that much reticence. So we tell them that there are two drugs and we tell them about the plus and the minus and the cost. And we tell that apart from പച്ചവെള്ളം അല്ലാതെ ഞാൻ സാറിന് പറയാറുണ്ട് പച്ചവെള്ളം അല്ലാതെ ലോകത്ത് സൈഡ് എഫക്റ്റ് ഉള്ള ഇല്ലാത്ത ഒരു സാധനവും ഇല്ല അപ്പോൾ എല്ലാ മരുന്നിനും അതിനൊരു സൈഡ് എഫക്റ്റ് കാണും and right now the side effect profile is either equal or slightly less compared to vitamin K antagonist, and because the cost has really come down, most patients want that because they don't want to come back again, check the drug, etc., etc. And there is no restriction on the food intake, all those things, because drug interaction, food interaction, they're all less with DOACs. Antidote, we don't actually talk too much about that.
So one more question. If a patient on NOAC develop chest pain and turns out to be unstable angina, and then you want to start heparin,
yes.
Do you wait for 12
Yeah, that's
hours?
what I said.
Yeah.
We can wait for 12, if the last dose was correctly taken. Suppose I took my NOAC in the morning at 8 a.m., I'm getting a chest pain while talking here. So it is now probably കണക്ക് വളരെ മോശമാണ് എന്നാലും എത്രയായി 4 മണിയും 8 മണിയാകുമ്പോൾ 8 മണിക്കൂർ ആയിട്ടുള്ളൂ. So 8 hours, which means that my body has got sufficient anticoagulation level. So I will not start immediately. I will wait for some time. And definitely in this current era, when somebody has a documented ACS, that patient will be admitted and most probably will be planned for a coronary angiography at the earliest. So again, we are going to do an arterial puncture either on the radial artery or on the femoral artery, which means that we don't want any active anticoagulation at that point of time. So we'll decide the strategy after we do the procedure.
Sir,
yes,
that was an excellent talk.
Yeah,
But thing is that we were wondering what happened to aspirin in case of a CAD with AF. You told that the triple therapy is not usually used,
yes,
and we'll be going for clopidogrel and NOAC.
Yeah.
And what happened to aspirin? We were wondering about that.
What happened to aspirin? Okay. Yeah. So aspirin, of course, for all CAD patients who undergo angioplasty with a drug-eluting stent, for the guideline, there are different subcategories, but for ease of understanding, for 1 year after angioplasty with a drug-eluting stent, all patients will require dual antiplatelet therapy. That is with aspirin plus one of the 3 drugs, either clopidogrel or ticagrelor or prasugrel. So that's the standard. But we are now talking about somebody who has an additional atrial fibrillation. For example, I had a patient who had CAD, I did angioplasty, then she was doing well, came for follow-up, again with AF, with pulmonary edema. So that patient requires aspirin, clopidogrel, along with an anticoagulant. So in that situation, we should try to minimize the triple therapy for maximum is 3 months. So if possible, we try to stop it after 1 month. If the bleeding risk is okay, we will continue it up to 3 months, and then we will give 1 antiplatelet with 1 anticoagulant. Because there are 2 pathways, no aspirin. We will stop aspirin, yeah. We don't want 2 antiplatelets and an anticoagulant after 3 months. Because we would like to give, but the downside is that patient will develop bleeding. So we will be happy patient will not die of MI, but I don't want my patient to die of a stroke also, IC bleed also. So we have to balance that. It's always a tricky situation. Because all the trials have shown that aspirin, the subset which was taking aspirin had higher incidence of fatal bleeds, including GI bleed. So in all the trials, clopidogrel was found to be the best antiplatelet to be used along with the oral anticoagulant. The only exception is when I talked about the chronic coronary syndrome and the peripheral arterial disease with the vascular dose of rivaroxaban 2.5 milligram. That trial, COMPASS trial, used aspirin 75 milligram. And actually after that trial came, people started criticizing, why did you use aspirin, why not use clopidogrel? Probably a new trial will come. Sir, all drugs can have theoretical interaction with NOAC, but compared to the vitamin K antagonists, the CYP3A4 inducers, inhibitors, all those, there is less interference with the NOACs. The only area where there is a major issue is patients with HIV who are on antiretroviral therapy. When they have AF and they take DOACs, we have to be careful because many of those drugs can interfere, and also some cancer therapy medications. But most of the drugs that we routinely use in practice, they don't have any problem with. And one important thing is, so I'm just saying for the sake of understanding, because we have got different pharma companies which have come up with all molecules. It's like all we know, sitagliptin came, everybody came. So rivaroxaban came, everybody came. Dabigatran came. So we are being bombarded with many doses, drugs. So very often we know only what they tell us. So that should not happen. I mean, it is good, we should listen to them, but then we should also know which dose is to be used in which condition. And many of the brands, they sound similar to other molecules. So we should not make that mistake also. So we should use it, and when we start prescribing any new drug, not only NOAC, new brands are being prescribed, we should write in bracket the chemical name, otherwise it can create, because these are drugs which have potential for harm.
If there are no more questions, I think we can end the session. Thank you.
Thank you so
once
much.
again.
Thank you.
I thank the organizing team, my own team, Khader sir, Sunil sir, Tommy sir, for giving me this opportunity. Thank you.
Thank you, sir. I was expecting a wonderful talk from you, sir, but you've simply exceeded our expectations, and you've delivered a superb talk. And I also hope the movie invitation was open to all of us. I request our chair. I request our chair, Dr. Atulya, to please gift Sergeant Sir with a small memento. We are truly honored you decided to speak at a humble CME, sir. I also request our dear Medical Director, Dr. Abraham Verghese, sir, to please gift our Atulya ma'am with a certificate and a memento as a token of our gratitude and love for chairing this session. Thank you so much.
Next, we would like to announce the much awaited results of e-poster presentation. I invite Dr. Tommy Phillips, sir, Principal and Professor of Pushpagiri Medical College, to kindly come onto the stage to give away the cash prizes for the winners. We had around 13 candidates who enthusiastically participated for the e-poster competition. The scoring was based on the relevance of general medicine, clinical knowledge, style of presentation, and academic reasoning. According to the judges, all candidates did exceedingly well in their efforts, and final scores showed an extremely edge-of-the-seat contest with differences of half a marking separating multiple candidates. Without much delay, let me announce the winners. First prize goes to Dr. Chandni, PS, Medical College, Kottayam. Second prize, Dr. Shilpa from, again, Medical College, Kottayam. Congratulations, winners. Now, may I request Dr. Abdul Qadir, sir, to come on to the stage and please convey our token of gratitude to Dr. Prashant Kumar, Professor of Medicine, Medical College, Kottayam, and Dr. Mohan Verghese, Professor of Medicine, Believers Church Medical College Hospital. Both of us have wholeheartedly accepted our request to be the e-poster judges for today's conference. Please come on to the stage, sir. I request all the PGs who have participated in the e-poster competition to please collect their certificates from the registration counter.
As we draw the curtains to a very successful program, we would like to express our overwhelming gratitude to each and every one of you who has participated in this program. It is only because of you, our dear audience, that we have been able to see months of fruition finally coming to a reality. I really do hope that everyone here at the audience today has learned something new and has amassed a wealth of information that can be used in your daily practice. It would be remiss of me if I wouldn't thank my dear colleagues and postgraduates who has tirelessly worked behind the stage for the past many months, making sure to get every detail right and coordinating every aspect and putting together this mega CME. This wouldn't have been a smashing hit if not for our unity in our department and our single-mindedness to achieve perfection and success. On behalf of the Department of Internal Medicine at Pushpagiri Medical College and the organizing committee, we, Dr. Dasan Joseph,
Dr. Chinmayi,
are signing off in the hopes to see all of you again in perfect health, all hearty and gale during the next conference. Until then, take care, safe travels, and God bless you all. Let's all rise for the national anthem before we part ways.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे